Symptomatology, Psychognosis, and Diagnosis of Psychopathic Diseases. Introduction. We are getting more and more awake to the importance of the study of the phenomena of abnormal mental life. The student of normal psychology begins to realize the necessity of a knowledge of the various manifestations of the abnormal mind, both conscious and subconscious. The phenomena that lie on the borderland of what is regarded as normal mental activity are of great interest and importance, because, being deviations or variations from the normal and the familiar, they are apt to call attention to the mechanism, causation, and laws that govern mental activity in general, normal and abnormal, conscious and subconscious. The normal psychologist has learned to pay attention to the facts of abnormal mental life, since a knowledge of them sheds a good deal of light on the various manifestations with which he himself deals, manifestations which have resisted psychological analysis, such as emotion, will, personality, and even such apparently simple mental functions as associative processes and perception. Not that the normal psychologist has not made important contributions to the understanding of all those processes, but many of the studies touched the surface, and did not penetrate deep into the subsoil of mental life, into the subconscious activity where all the sources of mental life have their being, where mental processes have their origin, and whence all mental processes come to light in the focus of consciousness. The phenomena of memory are of vital importance. 02 Introduction in normal psychology. And while a good deal of work has been accomplished by the normal psychologist in this subject, and some far-reaching laws, such as those of Ebbinghaus, have been formulated, still we are far from a real understanding of this fundamental function. In this respect, abnormal psychology is of material help, on account of the great number of variations which that function presents to the psychopathologist. In fact, most of the studies of recent psychopathology may be regarded as researches in the domain of memory. From a certain standpoint, psychopathic maladies may be regarded as affections of memory. Studies in abnormal psychology are thus of vital interest to the investigator in normal psychology. A study of the anesthesias, abulias, amnesias is of consequence to a right understanding of memory and volitional activities. The phenomena of dissociation of personality or of multiple personality give an insight into the labyrinth of human personality, while dreams, illusions and hallucinations give a broad view and clear understanding of the various elements of perceptual processes. If, however, abnormal psychology is of importance to the normal psychologist from a purely theoretical standpoint, it is certainly of the utmost consequence to the medical profession. A clinical knowledge of the facts of abnormal mental life should be in the curriculum of every medical student. Every medical practitioner should be more or less familiar with the symptoms of psychopathic diseases. We must not forget that mind and body are intimately related. The two cannot be separated. One reacts on the other. Physical disturbances bring about mental aberrations which in their turn influence physical introduction high functions. It is a kind of a closed circle. Nearly every disease of a physical character, if it is chronic, brings about nervous and mental disturbances which in their turn aggravate the physical disorder. In many disorders with purely physical symptoms, the main trouble is mental, a fact which many an experienced general practitioner will readily concede. This is strongly brought out by the researches of various investigators in the domain of abnormal psychology or psychopathology. To be able to recognize the mental and to be able to differentiate it from the purely physical is certainly of the highest consequence to the general practitioner, even if the treatment may fall into the hands of specialists who have devoted their life to such work. The reason why all kinds of occult cures have become so rampant in this country is because the medical profession ignores the mental side of the patient. The medical student, the practitioner, is in sore need of a training in psychology, normal and abnormal. Our medical colleges are apt to run in a routine. They give special courses in ophthalmology, otology, in special nervous organic diseases and even in tropical maladies which a general practitioner may not see in a lifetime, but they ignore psychopathic maladies which almost crowd the office of the general practitioner, and which he finds not only difficult to treat, but is even unable to recognize and diagnose. It is sincerely to be hoped that this hostile attitude to the mental requirements of medical students will be changed, and medical colleges will realize that they have to give some mental equipment to their students. The courses given in psychiatry do not cover the ground of psychopathic diseases. To one case for introduction of insanity there are thousands of cases of functional neurosis and psychopathic affections which have absolutely nothing to do with insanity, affections which the psychiatrist, from the very nature of his training, is neither in a condition to grasp nor able to deal with. The medical profession must realize the importance of a working knowledge of subconscious mental affections. More than one half of the patients that come to the general practitioner are cases of psychopathic disorders. An early recognition and appropriate treatment would not only vindicate the professional man, but would help the patient at the right moment and prevent him from becoming a chronic invalid. I must say that many medical men, regarding themselves as belonging to the conservative type, show a good deal of opposition to abnormal psychology. Thus some medical men accused me of carrying on work in spiritualism. Others with medical authority lecture on the limitations of psychotherapy. Vulgar psychotherapy is all they know of the vast domain of psychopathology. It is but 6 years or so since a well-known medical journal rejected, without as much as a comment, my clinical studies in psychopathology afterwards published in the Boston Medical and Surgical Journal. I have not the least doubt that my present volume will meet with no less opposition from similar quarters, and especially with attacks by psychologizing neurologists and psychiatrists taking refuge under Freud's paternal wings. I sincerely hope that in the course of time the more liberal, the more open-minded and progressive men of the medical profession will be more appreciative of the work done in normal and abnormal psychology. The introduction of the younger generation of medical men, I trust, will realize the importance of a working knowledge, both theoretical and clinical, of psychopathic mental diseases. I may say that a knowledge of psychopathic troubles is of more material help to the practitioner than all his studies in experimental physiology, for instance, with its muscle nerve preparations, more important than the bacteriological technique with its examinations of bacteria and bacilli, toxins and autotoxins, with the endless sera, often of a highly doubtful character, much advertised by commercial houses. Perhaps it may be well to remind the medical man that a good deal of what is taught in the medical schools as materia medica, or pharmacology, theory and practice, should be really regarded as courses in suggestive therapeutics, given under the guise of medicine, of virtues and properties of drugs so that the physician should have faith in them himself when he treats his patients. The nemesis of faith in the so-called scholastic medical therapeutics with its lack of psychological knowledge is fast overtaking the medical man. The Freudian school with its symbolical, Kabbalistic, occult notions and sexual sensationalism, rivaling that of the yellow press, has become the favorite in certain medical quarters. Physicians innocent of all psychological knowledge publish voluminous pseudo-analytic papers under the impression that they furnish the last word in medical psychology. The sight of some medical dignitaries taking a regular bath in sexual filth, possibly as a matter of redemption and expiation, would be ludicrous, if it were not so pathetic. It is amusing to read puerile compositions, each a mile long, going into detailed description of sexual experiences introductions with a zeal worthy of a better cause. The Freudians select choice cases of sexual perversion and degeneracy, much of which is of a purely suggestive character, and describe them with a gusto that well displays their own subconscious trend. According to Freudian pseudoanalytic science, the world is a madhouse of sexual perversion and inversion. The Freudian gloats over his sexual experiences. In order to accomplish this remarkable result, a whole mass of tokens, signs and symbols is formulated and organized into a systematized, paranoidal complex. This Freudian verbigeration and rumination some medical authorities and their followers hail as the gospel of medical psychology, a new up-to-date German importation, known under the high-sounding name of psychoanalysis. Psychoanalysis is a form of medical bacchanalia. Is it not the nemesis of psychology, that mad medical dance of psychoanalytic worshippers round the shrine of Venus and the altar of Priapus? It would have been amusing, if it had not been fatal to the mental and moral balance of the patients, to hear some medical authorities advising their patients to take a course in psychoanalysis. If those neurological practitioners should understand what a course of treatment in psychoanalysis really means to a nervous person, they might as well advise him to commit moral suicide, or to take a course in sexual profligacy. I have seen many a patient who has become a sexual ruin long before the psychoanalyst got through with his sexual courses. I have known many a patient who, under the highly suggestive, psychoanalytic treatment, has begun to masturbate daily and has become a sexual per introduction 7-vert. Psychoanalysis is a conscious and more often a subconscious or unconscious debauching of the patient. Nothing is so diabolically calculated to suggest sexual perversion as psychoanalysis. Psychoanalysis paraded as psychological investigation is not only a danger to the patient, but it is a menace to the community. And yet this form of mental debauch commends itself to some medical authorities as a great discovery in the domain of abnormal psychology. Better Christian Science than psychoanalysis. There is at present a current in psychopathology that ascribes a good deal of importance to desire, to purpose, to meaning. This current is essentially Freudian in character. The representatives of this tendency are not satisfied unless they read some meaning, conscious or unconscious, into the various phenomena of abnormal mental life. They try to find in the abnormal symptoms of psychopathic patients some mysterious significance which they attempt to reveal by special interpretation. They try to find some hidden meaning in phenomena regarded as symbolic of unconscious trends which they decipher by a special code of procedures, signs and tokens. They are somewhat like the ancient augurs who could read the future from the flight of birds and the guts of animals. Others, carried away by the same influence, but rather more cautious in their speculations, attempt to find special meanings in each and every symptom of psychopathic cases, and are not satisfied until some meaning, however obscure and laborious, is forced out of the facts under their examination. Now in all my work, carried on for years and pub 8 introduction listed in various works and papers, I lay special stress on the fact that the phenomena of abnormal mental life do not present any purpose in the present. They are repetitions, recurrences of a past, but they have no aim, no purpose, no meaning in the present life existence of the patient. In fact, the symptoms are pathological, just because they have no purpose, no meaning in the life of the patient. The most superficial and puerile method is that of tracing subconscious meanings in lapses of words, in amnesias, by means of association methods. The physician gives a series of words and the patient is supposed to answer with some words which are scanned by the physician as to time and quality. All kinds of symbolical and diabolical combinations are then formed by the physician who thinks he is doing great psychoanalytic work. All he does is ingenious, Kabbalistic casuistry worthy of medieval scholasticism. When Freud's Psychopathologie des Alltagslebens published, I discussed the examples, so ingeniously worked out by Freud, with the late Professor James of Harvard. James laughed at the puerility of Freudian associations. He threw up his hands at the psychoanalytic absurdities, and characterized Freudian psychopathology as silly and nonsensical. Some similar opinion is maintained by Wundt, Ziehen, Oppenheim, Aschenberg and others. Not a single psychologist or psychopathologist of note accepts Freud's sexual fantasies and one-eromancy. The association method used by the Freudian school, in order to discover the hidden meaning that lies in the subconscious or the unconscious, is arbitrary. The followers of Freud are inexperienced in the actual introduction 9 gations of subconscious phenomena in which suggestibility plays such an important role. There is not a single case of the Freudian school that is free from artifacts of subconscious suggestion, played between patient and physician, in which the Freudian is the biggest dupe. In fact, the very methods of free association and one-eromantic interpretations are of such a character that any associations may be formed, according to the wish of the physician. The Freudian himself is possibly the best illustration of his own theory that one may be duped by his own wishes. In this respect the Freudian does live up to his theory that everything can be explained by wish and its ideal fulfillment. As I put it in another place, if wishes were horses beggars would ride, the Freudian rides such horses. On the whole, teleological psychology is questionable. One can find any number of purposes in mental symptoms and associations. Speculations in that direction are often as idle as they are useless. When Harvey discovered the circulation of blood, the objection was the teleology of it. What is its purpose? What is its meaning? Harvey had to defend his theory against objections that claimed that he did not go deep enough into the subject, as he did not give the meaning of the circulation of blood, and, therefore, his discovery could not be true. To those who repudiate the circulation, Harvey writes because they neither see the efficient nor the final cause of it, and who exclaim cui bono. I have yet to reply, having hitherto taken no note of the objection which they take up. Teleology is a tradition handed down through the scholastic Middle Ages from Plato and Aristotle, ex introduction, and often comes to life in sciences that have not reached their state of maturity. Not that I deny the purposive element in mental life, but I do claim that its sphere even in normal life is extremely limited, and that it is almost completely absent in states of morbid psychic affections. Freudism is a good example of it. Morbid mental states have no meaning. In a certain sense we may even say that mental states are morbid, just because they have no meaning. The cure often consists in the fact of either having such states completely eliminated from the stream of mental activity, or in finding for them a meaning which originally they do not possess. Clinical psychopathology should not burden itself with all kinds of speculations and hypotheses, but stick to facts. Teleology, or the finding of meanings, infantile and others, the discovering of hidden purposes and unconscious meaning, because of the metaphysical dogma that the unconscious can only wish and form desires which the symptom complex of the malady expresses as the meaning of the hidden conation, is to bind oneself with arbitrary speculative theories and metaphysical hypotheses. The most consistent of those speculators are unconscious followers of Schopenhauer, who puts the unconscious will at the basis of his metaphysics. Will is at the heart of things. Hence there is a craving in the unconscious which is the very essence of the phenomenal manifestations of the will. According to Schopenhauer, the phenomenal world is the manifestation of the will, of the Kantian Ding und Sich, of the noumenon which is beyond time, space, and causality. The unconscious in nature is the will. Introduction 11, which works and manifests itself in it. The world is the objectification of the will. The will is the thing in itself, the content of all phenomena. The phenomena are throughout necessary. This follows from the unrestricted validity of the principle of sufficient reason. In another aspect, however, the same world is for us, in all its phenomena, objectivity of will. This metaphysical doctrine of will is at the basis of Freudian pseudoanalysis. The doctrine of will, desire and suppression, resistance and abwehr is a close copy of Schopenhauerian metaphysics. In the resistance of the will, says Schopenhauer, allowing what is contrary to it to come under the examination of the intellect, lies the place at which madness can break in upon the mind. Each new adverse event must be assimilated by the intellect, the conscious, or das Bewusst. It must receive a place in the system connected with our will and interests, whatever it may have to displace that is more satisfactory. Whenever this has taken place, it already pains us much less, but this operation itself is often very painful, and also in general, only takes place slowly and with resistance. However, the health of the mind can only continue so long as this is in each case properly carried out. If, on the contrary, in some particular case, the resistance and struggles of the will against the apprehension of some knowledge reaches such a degree that that operation is not performed in its integrity, then certain events or circumstances become for the intellect, für das Bewusst aber nicht für das Unbewusst, as the Freudian would say, completely suppressed, because the will cannot endure the fit of them, and then, for the sake of 12 introduction, the necessary connection, the gaps that thus arise are filled up at pleasure, by the activity of the unconscious. Thus, madness appears. For the intellect has given up its nature to appease the will, the man now imagines what does not exist. And here comes another fundamental Freudian metaphysical tenet. Yet the madness which has thus arisen is now the lethe of unendurable suffering. It was the last remedy of harassed nature, i.e., of the will. Freudianism is Schopenhauerian metaphysics gone mad. Psychoanalysis is truly perverted medical metaphysics. In psychopathic cases, the symptom complex of the functioning systems, characteristic of the pathological condition, has essentially no meaning in the present, although the patient, especially with the help of the physician, may find some meaning, as do the insane when trying to account for their pathological state. The psychopathic symptoms are survivals, relics from a previous epoch of the life existence of the patient. The psychopathic symptom complex is a survival from a stage of experience the meaning of which is gone, and is therefore entirely irrational. It is only when we come to realize the irrationality and lack of adaptation, inner and outer, of such pathological, meaningless systems, conscious and subconscious, that we begin to understand the psychopathic character of the symptom complex. In this respect, psychopathic systems are analogous to the irrational customs and myths found in various stages of human culture. This point is specially misapprehended and misapplied by the Freudians. As long as one attempts to force on myths a meaning, philological or sexual, one is sure to go astray and to be lost in a maze of introduction 13 verbiage and sophistry. Myths are survivals of savage thought, now meaningless and irrational. The Freudians clearly reveal their absurdity by the allegorical subtleties of their mythical, sexual psychology, in which their sexual fancy runs riot. Myths are relics of savage thought, recurrent manifestations of savage experience, surviving phases of savage Weltanschauung. All the Freudian psychologizing about myths is nothing but idle pseudo-analytic fancy without the least foundation in fact. To the problem, why irrational ideas survive in myths, Andrew Lang pertinently says, we may be asked, why do savages entertain irrational ideas which survive in myths? One might as well ask why they eat each other, or use stones instead of metals. Their intellectual powers are not fully developed, and hasty analogy from our own unreasoned consciousness is their chief guide. Myth, in Mr. Darwin's phrase, is one of the miserable and indirect consequences of our higher faculties. All the casuistry of Freudian mythology is arbitrary and sophistical. The Freudians use scholastic casuistry for the rationalization of what is essentially irrational. It, the myth, says Lang, is a jungle of foolish fancies, a Walpurgis nacht of gods and beasts and men and stars and ghosts, all moving madly on a level of common personality and animism, and all changing shape at random, as partners are changed in some fantastic witches' one revel. The imagination of the savage has been defined as midway between the conditions of a healthy, prosaic, modern citizen and of a raving maniac or of a patient in a fever ward. Just as the irrational elements of myths are the survivals from a savage state of mind which has no mean 14 introductioning in the present life of civilized communities, so we may say that mental, subconscious, psychopathic symptomacomplexes are survivals of a former period of mental activity. They are atavistic systems which keep on recurring, like the type of recurring moment consciousness, under appropriate circumstances and favorable conditions, but which are now irrational, without meaning and purpose. The Freudians have invented a psychopathic Oedipus complex of which they make much capital. They show, however, by it a sad lack of psychological understanding and a deficiency of scientific insight as well as absence of common sense. Neither is their analysis of the Oedipus myth in any way correct, nor is their interpretation of clinical facts in the least approaching the truth. The whole of psychoanalysis is nothing but puerile, Talmudic hair-splitting sophistry. The Oedipus complex, which is kept in so much reverence by the Freudian devotee, is scientifically and clinically false. The Oedipus myth is wrongly interpreted by the Freudian sexual mythology and has absolutely nothing to do with the actual condition of psychopathic cases. All there is to the Oedipus complex is a matter of ordinary suggestibility to which psychopathic patients readily lend themselves and of which the psychoanalyst is principal dupe. Max Miller regards the Oedipus story as a solar myth. It is, however, quite probable, as J.G. Fraser points out, that there is in the myth a survival from the early savage period of matriarchate or motherkin, when the right to the throne was in the female line. The father exposed and slaughtered the son, and the son in his turn. Introduction 15 throned the father by force and murder. The savage chiefs and kings sacrificed and killed their male children, especially their firstborn sons, while the surviving sons assassinated their fathers. The myth is a reminiscence, a relic handed down from savage times of the struggle for existence, going on within savage communities for the tenure of kingship. The marriage with the king's widow was requisite in order to obtain the right to the throne. The father murdered the son, and the son, when he was rescued, had to assassinate the father. It was a matter of killing or being killed. What we find in the myth is another example of the working of the instinct of individual and more specially of social or tribal self-preservation. Father, son, and members of the royal family were sacrificed as an atonement for tribal sins. They were immolated and slain as an expiation for the transgressions of the community, and hence their deaths were supposed to ensure the prosperity of society. The Oedipus myth, with its deaths of Laios, of Oedipus, of Jocasta and of the children of the royal house for several generations, is a relic of savage practice in the struggle for self-preservation. This is well brought out in the Greek myth of Athamas, current in Alis, a town in Thessaly. King Athamas and his family had to furnish victims as synoverings for the whole country and thus ensure its welfare. The wife and children suffered exile and death in various ways, and King Athamas himself was ordered by the oracle to be sacrificed for the good of the community. The unhappy king was saved by his grandson, Cytisrus. Athamas became insane, quitted his country and went wandering in the wilderness. Here we have 16 introduction, a modification of the Oedipus myth, a modification which shows the real nature of such stories, namely that they are relics, survivals, or recurrences of savage practices in the struggle of tribal self-preservation. The Freudian sophistic interpretation of their Oedipus complex is as shallow as it is arbitrary. It is pseudo-analytic rubbish, sexual trash without any rhyme and reason. Distasteful as it is for me to do it, I find it my duty to enter a protest against the vagaries and absurdities of psychoanalysis, which is nothing but a pseudo-science, the same as astrology, eromancy, palmistry and magic. On account of the sensational noise made by the devotees of psychoanalysis, the medical practitioner confuses psychoanalysis with scientific and clinical psychopathology. In condemning psychoanalysis, many a clinical man of sound good sense also unjustly condemns all clinical, psychopathological research. The following statement is an extract from a letter written to me by an eminent medical man who stands at the head of the medical profession of this country. I think that the majority of men in general work do not separate psychopathology from psychoanalysis. Freud's theories and the whole trend of psychoanalysis have been so turned into the channels of distorted and perverted sexual life that it has blinded people to the fact that there are many dominant phases in mental life which are not sexual. The ordinary healthy-minded and vigorous practitioner sees a lot of motives in life that are not sexual, and where everything is turned and twisted to one side, one complex, he becomes indignant and disgusted, and condemns the whole broad subject of psychopathology. My clinical work as well as my experimental introduction 17 and observations prove to me conclusively that not all mental processes are purposive or meaningful. Mental life activities are a matter of habit, often silly, and meaningless, even hurtful or pathological. Quite frequently the activity is carried out reflexly in response to external stimulations often detrimental to the life existence of the individual. Most of the actions which have no selective value may be completely indifferent. This lack of purpose and absence of meaning in normal life may be regarded as being even more emphatic in pathological cases. It is only paranoiacs or paranoidal cases that may put a quasi-meaning on their abnormal experiences, but this meaning is entirely delusional. Of the same paranoidal type may be regarded the kind of meaning put on the symptoms of psychopathic cases. Psychoanalysis is a matter of suggestion played between the physician and the patient. Both are deluded. Psychoanalysis is sheer humbug. We may lay it down as a law that psychopathic life lacks meaning. I lay special stress on this principle, lack of meaning characteristic of psychopathic affections. This absence of meaning is the key to a right comprehension of the facts of psychopathology and of the methods of psychotherapy. Perhaps it may be fitting here to say a few words about psychognosis. Psychognosis is not a special method. All I wish to convey by it is what the term means, namely a study, an acquisition of a working knowledge of the patient's soul, so to say. The best way is to study the case by all kinds of methods, hypnoidal, hypnotic, and especially by a close observation of the waking states. The best way is not to rely on cut and 18 introduction dried methods, such as pedantic laboratory tests, which are clumsy, awkward, and highly misleading. It is best to live with the patient, to watch him closely when he acts spontaneously, converse with him, discuss with him, work with him, be with the patient day and night, and labor with him for hours, as well as live with him intimately for weeks and months. It is only under such conditions that we come to realize the actual condition of the patient and can obtain a glimpse of the workings of his mind. No cut and dried tests, reaction time or association time or tests with association words, and then leading the patient along lines suggested unconsciously by the physician, or any attempt at putting the case into some pigeonhole of a classification, common with the neurologist and psychiatrist, such as dementia praecox, psychasthenia and so forth, can lead to any understanding of the case. The best way is to study the case, know it by the description of its symptoms, and dig deeply into the conscious and subconscious sides of the patient's character and life history. In short, we must learn to know the workings of the patient's mind. We must learn his ideals of life, his attitude towards man and to the world, his actions and his total reactions in his adaptations to his environment. In other words, we must learn to understand not only the patient's physical, nervous, and mental condition, not only his history and the development of his present trouble, but we must learn his personality as a whole, his attitude to his external surroundings, his Welton scoring, so to say. This can only be accomplished by all methods at our disposal, by hypnoidal and hypnotic states, by examiner introduction 19 in the waking state, by constant watching and observation, by drawing out the patient in discussion, and by closely observing him in his actions and behavior in regard to his family, his friends and strangers for a long period of time. The knowledge thus obtained of the patient's psychic life is what I regard as psychognosis. Such a knowledge is indispensable for a right comprehension of the patient's condition, and is still more important, if we wish to cure him. In other words, psychognosis is of importance not only from a theoretical, psychopathological standpoint, but is of the utmost consequence to a right, practical, psychotherapeutic procedure and treatment. I may add that some of the chapters included in this volume have been published by me in the form of articles in various medical and psychological journals. Boris Sidis. Sidis Psychotherapeutic Institute, Portsmouth, New Hampshire, July, 1914. Part Subconscious Borderland I States Phenomena Symptomatology, Psychognosis, and Diagnosis of Psychopathic Diseases. Chapter The I Subconscious and the Conditions Manifestation of Its of We can study the manifestations rethink before psychopath diseases. It is well to review the subconscious, its conditions and its principal states. The nervous centers of man's nervous system, if classified as to function, may be divided into inferior and superior. The inferior centers are characterized by reflex and automatic activity. A stimulus excites the peripheral nerve endings of some sense organ, at once a nerve current is set up in the afferent nerves. This current in its turn stimulates a plexus of central ganglia, the nervous energy of which is set free and propagated along the efferent nerves towards muscles and glands. Secretions, muscular contractions or relaxations are the result. Ingoing and outgoing nervous currents may be modified by the nervous centers. Nervous currents may be intensified, decreased in energy or even entirely inhibited by mutual interaction. Such a modification takes place according to the law formulated by Ziehen. If an excitation of a definite intensity, M, take place in 212 diagnosis of psychopathic diseases, one cortical element, pound, and another excitation of a different intensity, take place at the same time in another cortical element, C, which is connected by a path of conduction with B. The two intensities of excitation may reciprocally modify each other forward / although such modifications may frequently occur, it nevertheless remains true that the inferior centers are of a reflex nature. No sooner is the nervous energy of a lower center set free than at once it tends to discharge itself into action. The physiological process of setting free the nervous energy in a central ganglion, or in a system of central ganglia, is accompanied in the simpler, but more organized, more integrated centers by sentience, sensibility, and in the more complex, but less integrated, less organized centers by consciousness, sensations, perceptions, images, ideas, and emotions. Turning now to the superior or the highest nervous centers, we find that they are characterized by the function of choice and will. A number of impressions, of sensations, of ideas reach those higher will centers, and a critical, a sifting, a selecting, an inhibitory process at once begins. Some of the mental states are permitted to develop and to work themselves out within certain limits, others are given full play, while others and possibly the majority of them are rejected and inhibited. Psychologically, this process expresses itself in the fiat or in the negate, in the I will, or the I will not. Everyone is well acquainted with the will effort, especially when having to make some important decision. These superior choice and will centers, localized by Ferrier, Wundt, Bianchi and others in the frontal lobes, and by others in the upper layers of the cortex, on account of their selective and subconscious manifestation 13 inhibitory function, may be characterized as inhibitory centers par excellence. Parallel to the double system of nervous centers, the inferior and the superior, we also have a double consciousness, the inferior, the organic, the reflex consciousness, the subconsciousness, and the superior, J&E controlling, the choosing, the critical, the will consciousness. The controlling consciousness may be characterized as the guardian consciousness of the species and of the individual. From an evolutionary, teleological standpoint, we can well realize the use of this guardian consciousness. The external world bombards the living organism with innumerable stimuli. From all sides thousands of impressions come crowding upon the senses of the individual. Each impression has a glandular affection, a motor reaction which, if not counteracted, may end in some possibly harmful or fatal result. It is not of advantage to the organism to react on all impressions coming from external stimuli, hence that organism will succeed and survive in the struggle for existence that possesses some critical, selective, inhibitory choice and will centers. The choice and will centers permit only a certain number of impressions to take effect, the rest are inhibited. Only those impressions that are advantageous to the life existence of the individual are allowed to take their course, the others are nipped in their bud. The guardian consciousness wards off as far as it is able all the harmful blows which the stimuli of the environment incessantly direct against the life of the individual. In the normal condition of man, the superior and inferior centers work in perfect harmony. The upper and lower centers and their concomitant forms of 14 diagnosis of psychopathic diseases consciousness are a unity, forming one conscious, active personality. Under certain conditions, the two systems of nerve centers may become dissociated. The superior centers, with their critical, controlling consciousness, may become inhibited, or cut off, split off from the rest of the nervous system with its reflex consciousness, which is thus laid bare, open to the influence of external stimuli or suggestions. The inferior reflex consciousness constitutes the subconscious. The subconscious is highway of suggestibility. The subconscious is manifested as or laid bare by inhibition of the inhibitory centers, or in other words, by a disaggregation of the superior from the inferior centers, followed by an increase of ideosensory, ideomotor, and sensory-secretory reflex excitability. Psychologically regarded, inhibition of the controlling, waking consciousness results in the uncovering of the reflex consciousness, the revelation of the subconscious. To get at subconscious states, definite conditions must be strictly observed, no matter what the method of procedure is. The first and general condition of experimentation on the subconscious is fixation of attention. I ask the patient or subject to look at some particular point chosen by me, the time of fixation usually varying from 2 to 5 seconds. Fixation of attention is an important condition of access to the subconscious. The next condition is distraction of attention. The asterisk by the subconscious is meant all processes of intelligence which are subjectively known as conscious, but which under special conditions fall outside the range of awareness, or of the knowledge of the individual. The subconscious is essentially a consciousness other than the personal consciousness. See the Psychology of Suggestion / Multiple Personality, The Foundations of Normal and Abnormal Psychology, and Appendix 4. Subconscious manifestation. 15. Subject or patient has for a brief time, varying from a few minutes to hours, to fix his attention on some irrelevant point, spot, thing that has no connection with the material of the experiments or with the matter under investigation. In all my experiments on the subconscious, I have always had to guard against variety of impressions. Slight noises, coming from the adjoining rooms of the laboratory, are distinctly unfavorable to the experiments. There must be monotony. The subjects have to be accustomed to the conditions and objects in the room. A new impression, however slight, always proves a disturbance. Limitation of voluntary movements is another important condition. While fixing their attention, the patients or subjects have to keep as quiet as possible, otherwise they are disturbed, the attention begins to wander, and the work has to be abandoned for the time being. The subjects should be asked to make themselves as comfortable as possible, so they should not have to change their position during the investigation, and have their limbs relaxed. The condition of limitation of voluntary movements must be strictly observed. Limitation of the field of consciousness may also be considered as one of the important conditions of investigation of subconscious. This condition is in fact a result of the former ones, namely, fixation of the attention, monotony, and limitation of voluntary movements. For when these last conditions are present, the field of consciousness becomes contracted and limited to a few sensations and ideas. Contraction of the field of consciousness may, however, be effected where the other conditions are absent. A sudden, violent 16 diagnosis of psychopathic diseases impression may instantly effect an enormous shrinkage of the field of consciousness, and then the other conditions will naturally follow, or rather coexist. Consciousness will reverberate with this one violent sense impression and will thus attend to the latter only. There will also be monotony, since a sudden violent sense impression tolerates few neighbors, and drives out fresh incomers. Voluntary movements become limited, the body becomes paralyzed and relaxed. Work on the subconscious cannot be successfully carried on without the condition of inhibition. I ask the subject when he concentrates his attention and fixes it on a dot or object that he should try, as much as it is in his power, to banish all ideas, images which have no connection with the object in the focus of consciousness, that he should make his mind a perfect blank, and inhibit ideas, associations which may arise before his mind's eye and claim attention. This condition, of course, is rather a hard task for the subject or patient to comply with, still it is observed as far as it is possible. The very last, but not the least condition, in the experiments is immediate execution. The subject has to perform the act required by the nature of the experiment as soon as he perceives the signal. We may now make a synopsis of the conditions necessary for reaching the subconscious strata of the mind in the normal waking state. 1. Fixation of the attention. 2. Distraction of the attention. 3. Monotony. 4. Limitation of voluntary movements. 5. Contraction of the field of consciousness. Subconscious manifestation. 17. 6. Inhibition. 7. Immediate execution. The conditions of distraction of attention and immediate execution are requisite for suggestibility in the fully waking states. The induction of more or less stable subconscious states is brought about under persistent action of 5 factors. 1. Fixation of attention. 2. Monotony. 3. Limitation of voluntary movements. 4. Contraction of the field of consciousness. 5. Inhibition. It should be clearly understood that the factor of limitation of voluntary movements means essentially bodily relaxation. The study of subconscious states is of recent origin, but it is now daily growing in importance. The mechanism of the human mind. The more elementary psychic processes are not directly given to the immediate introspective knowledge of self-consciousness, the results alone are given. It is the subconsciousness that one must look to in order to grasp the full meaning of the workings of the mind. In experimenting on the subconscious in the normal waking state, we may use two methods: I, the method of conscious impressions. 2. The method of subconscious impressions. I. By the method of conscious impression we endeavor to reach the subconscious through the medium of impressions of which the subject is fully conscious. This method may in its turn be subdivided into A. The method of indeterminate action. These conditions will be described in greater detail further on. 18. Diagnosis of psychopathic diseases. B. The method of determinate action. A. When working with the method of indeterminate action, we allow the subject, within certain limits, of course, to do or write anything that enters into his mind at the moment the experimentation is over. In studying, for instance, the suggestibility of the Sufi conscious, we may direct our efforts to find out, say, the suggestiveness of different conditions, such as the influence of the earliest or latest impressions of certain stimuli, or the effect of a series of successive frequent or coexistent stimuli. B. The method of determinate action, or that of choice. When working with this method, we limit the subject to a definite number of actions. Thus, in studying the suggestibility of the normal individual, we may seek to determine the influence of the factor of strange, unfamiliar things and actions, or that of abnormal position, and so on. 2. The method of subconscious impressions consists in arranging the experiments so as to influence the subconscious, but in such a way that the subject should not be conscious of the impressions. This method may be divided into A. The method of choice distraction. B. The method of guesses or of subconscious impressions. A. By means of the method of choice we distract the patient's attention, engaging it in some other direction, meanwhile influencing the subconscious in the determination of subject's choice. The mechanism of these experiments may be arranged somewhat like the following. A series of complicated patterns is made on slips of subconscious manifestation 19 paper, each slip having a different pattern. The subject has to look at the drawing of the pattern for about 10 seconds. The slip is then withdrawn and he has to reproduce the drawing from memory, an extremely difficult task. In my experiments on the subconscious, it took the subject about 15 seconds and more before he could make anything bearing the slightest resemblance to the figure shown to him. When the subject is through with his drawing, a cardboard with a series of numerals is shown to him. He chooses any numeral he pleases. Now on the margin of each slip is also a numeral, so that when the subject studies his pattern for reproduction, the number impresses itself subconsciously on his mind. Even if at first he notes the numeral, he soon ignores it, thinking that it is the number of the drawing in the series. He soon overlooks it. He does not see it consciously anymore, but sees it subconsciously. In my experiments conducted by this method, the subjects had not the slightest suspicion of the real purpose of the research. They were sure that the whole matter was concerning imitation of the patterns, and that the choosing of the numeral on the cardboard was but a device to break up the attention in passing from one pattern to another. The subjects were so intensely absorbed in the contemplation and then in the reproduction of the drawing, which was extremely complicated, that they wholly disregarded the marginal numbers. B. The method of subconscious impressions helps us to determine the relations of the subconscious to the asterisk. The number of choices influenced by the marginal number seen subconsciously is noted down and the total number of choices is determined. 2. Diagnosis of psychopathic diseases. Subject's self-consciousness. The mechanism of the method is simple, though important. We give the subject an impression that lies outside the range of his field of conscious sensibility, and ask him to guess the particular or general character of the stimulus or impression. We take a series of 10 cards and tell the subject that on each of them there is a letter or numeral. We then put each card outside the field of his vision and ask the subject to look at it for some time and then to guess the character, particular or general. If letter A, for example, is shown to him and he guesses it correctly, then he guesses both the particular and general character, so that we may say that every correct particular guess is also a correct general guess. If he guesses a wrong letter, say B, he guesses correctly the general character only. If, however, instead of the letter he gives a numeral, say 6, then he fails completely. If we eliminate the chance element, we have the number of cases due to subconscious vision. Perhaps it may be well to mention a method of * to eliminate the chance element and to find the percentage of correct guesses, both general and particular, due to subconscious vision. Let 3 be the correct general subconscious guesses. Let, again, X represent the correct particular guesses due to subconscious vision. P and / the general and particular chance guesses. We have the following formulas, M and N being given by experiment, P plus Y equals trademark symbol, I, are all the correct general guesses as mere general, pi / X, again, in the second equation are the correct particular guesses as particular. From I, we have, Y equals M, P, 3, these are all the correct general guesses. Now, in equation 3, P is 50%, because each guess has only one alternative, letter or figure, in 100 observations, pound equals 50, hence Y equals M, 50. Since there are only 10 characters to guess in each particular case, therefore in 100 cases the chance element in equation 2 is 10, or P equals 10 and X equals N, 10. Subconscious manifestation 21. Preaching the subconscious, or as it is put in reaching the so-called suppressed complexes. 5. This consists in giving the patient or subject a series of words and by observing the quality of the answers as well as the time of the reply made or the association time. The character of the suppressed complex is supposed to be reached, if the association time is found to be lengthened. The same can be done with the galvanometric reflex. When a special complex associated with a suppressed emotion is reached, there is a greater galvanometric deflection. The same is claimed to be accomplished with other graphic records, such as sphygmographic, pneumographic, or plethysmographic records. Judging from what Pavlo has written to me that he and his collaborators are at work on the higher nerve activity of the brain of the dog, according to the methods of conditional reflexes, then it may be possible to study man's mental life or his reactions, however complicated, from observed glandular secretions. This fantastic prospect is at present as yet in the distant future. I myself have done a good deal of work with all the graphic methods, sphygmographic, plethysmographic, pneumographic, and galvanometric. I have taken Sev * in my work on galvanometric deflections carried out with Dr. H. T. Camus at the Research Laboratory of the Massachusetts Institute of Technology, and at my psychopathological laboratory we come to the following conclusion. Our experiments clearly point to the fact that active physiological, sensory, and emotional processes, with the exception of pure ideational ones, initiated in a living organism bring about electromotive forces with consequent galvanometric deflections. In my galvanometric work with Dr. L. Nelson performed on various animals, on man, frogs, rabbits and cats, we arrive at the following conclusions. Galvanometric deflections are brought about by Psycho 22 diagnosis of psychopathic diseases, 1,000 tracings of each in normal and abnormal cases. I can say without hesitation that from a clinical standpoint their worth is nil. They are good as charts, as curves, as pictures and illustrations for the eye after the data are acquired, but as a guide for psychognostic or diagnostic purposes they are all worthless. Similarly with the association method. Nothing is more misleading and clumsy than the physiological processes, but not by purely ideational processes, under the influence of various stimulations. To these galvanic deflections termed by us galvanic reactions are not due to variations of resistance, whether of skin or of body. 3. The galvanic reaction is the result of variations of electromotive forces produced by the psychophysiological processes set into activity by the agency of external or internal stimulations. 4. The causation of the galvanic reactions cannot be referred to circulation, nor can it be referred to secretory currents, whether of skin glands or of other glandular organs. 5. The central nervous system and the sympathetic nervous system are alike excluded as factors concerned in the manifestation of the galvanic reaction. 6. The galvanic reaction is a muscular cutaneous phenomenon due to the influence of various agencies, emotional, sensory, physiological, chemical, thermal, electrical or mechanical. 7. The galvanic reaction is chiefly brought about by the muscles and glands within the circuit. 8. Prolonged active peristalsis gives rise to galvanic deflections which are due to the contraction of the muscles and the action of glands involved in the process of peristalsis. 9. The galvanic reaction diminishes and even completely disappears with the repetition of the same kind of stimulation. 10. This full or complete disappearance of the galvanic reaction with the repetition of stimulation is usually due to a decrease of sensitivity in regard to the same repeated stimulation. 11. The fall, however, of the galvanic reaction may also be brought about by the action of a prolonged stimulation resulting in a gradual fatigue of the muscles in the circuit. 12. The heartbeat, like the contractions of any of the other muscles, gives rise to galvanic deflections. Neither from a practical clinical standpoint nor from a purely theoretical, psychopathological standpoint can we say that the galvanometer is of any value. We can no more study mental states with a galvanometer than we can investigate ideas and feelings with a microscope or telescope. The trouble with the medical man is that he wishes to examine mental states as he examines urine. Subconscious manifestation 23 elation words, the replies, and the time taken. Some people may amuse or deceive themselves with it, but as to the insight which it gives into the delicate working of the human mind in general and of mental troubles in particular, the value may be said without hesitation to be less than nothing. The results are misleading and deceptive. The late Professor James was fully right when he characterized this kind of psychological work as brass psychology. We can come more closely to the subconscious, in an imperfect way though, through dream states. Dream states belong to the region of the subconscious, but they reach our knowledge in a distorted and vague form. They rapidly fade away and melt under the light and warmth of the waking consciousness. It is a rare thing to remember fully a dream, as a rule, but mere shreds remain, and often even these soon disappear or are totally absent on awakening. Still, we must make the best we can of what is directly given to us. Dreams may be studied either by the memorial method of self-observation, by the statistical method, and by experimentation. There are 5 methods. 1. The memorial method of self-observation. 2. The statistical method. 3. The psychophysical method. 4. The psychophysiological method. Sputum, blood, or bodily reflexes. This cannot be done in the case of mental states. There is no physical instrument with which mental states can be examined and studied. The sooner the medical man learns it, the less will he be carried away or deceived by some new wonderful instruments for discovering hidden thoughts or measuring and photographing ideas and feelings. Introspection and observation, supplemented by the physician's or psychopathologist's introspective interpretation, will ever remain the tool of the psychologist and psychopathologist. 24. Diagnosis of psychopathic diseases. 5. The method of psychic stimulation. 1. The memorial method consists in giving as complete an account of the dream from memory as it is possible. The dream is written down immediately after awakening, otherwise the whole may fade away altogether. Since many dreams occur during night and disappear, giving place to other qualitatively different states, and thus no memory is retained of those dreams on awakening in the morning, it is advisable for one who undertakes such an investigation to put near his bed a match, pencil, and paper, so that should he wake up any time during the night he may write down the dream immediately while he is yet in condition to catch a glimpse of the positive images left by the dream shadows. 2. The statistical method consists in collecting dreams from many observers, classifying the dreams, comparing notes, and drawing conclusions. 1. However, must use such material with great precaution as not all observers are trustworthy in such accounts. We must find out whether the records were taken immediately after the dreams, otherwise the facts must be rejected, or put at least under the heading of doubtful cases, since in such records later images from waking states may in all probability have been interpolated. The first two methods bring us indirectly in relation with the subconscious. The other three methods bring us in more direct touch with subconscious life activities. 3. The psychophysical method or that of physical stimulation is the artificial production of dreams by means of physical stimulation of the special senses. The experimenter watches his subject while asleep and applies different stimuli to his peripheral sense organs. Subconscious manifestation 25. He pinches, pricks, squeezes the hand, leg, cheek or some other portion of the subject's body. He lights matches before the subject's eyes, drops water on his face, gives him something to smell, agreeable or him taste different substances and so agreeable makes on. Dreams are awakened by the stimulations the summation of which finally arouses the subject. In fact, some of the dreams occur during the short period of awakening. The subject tells his dream which is at once recorded by the experimenter. 4. The psychophysiological method or that of physiological stimulation consists in the artificial excitation of dreams by means of some stimulants, drugs. The dreams may be intaken before falling asleep. Used be anesthetics, chloroform or ether, or by drugs such as chloral, veronal, medinal and other hypnotics. 5. The method of psychic stimulation is the arousal of dreams by means of psychic stimuli, such as words. When the subject is in a deep sleep, the experimenter in a low voice calls out some words or phrases. At first the subject does not seem to hear, but the words summate themselves at last, and the subject sometimes awakens with a start. Meanwhile the subject frequently has dreams formed by the floating images aroused by the speech. As soon as he wakes up he is to give an account of the dream, if any was formed. It is advisable, while making such experiments, to use words and phrases that are of intense interest to the subject, or words that are familiar to him, his own name, or the name of those who are near and dear to him, also names, words and phrases to which he is used to respond promptly. This may bring him out of his deep sleep, but may TVQT have 26 diagnosis of psychopathic diseases sufficient power to awaken him fully. The words or phrases will thus be enabled to arouse images which will be formed into dreams, following the summation of the stimuli. We should bring the subject out of his deep sleep by degrees. By means of the induction of the hypnotic state or by the induction of the hypnoidal state, or the twilight state, we can come in direct touch with the subconscious. The methods of hypnotization are various, but all of them must conform to the conditions of suggestibility. We can hypnotize subjects or patients by having fixed their attention on some bright object, by fixating attention on the expectation of some sudden bright light, on a glass, a crystal, or on some object held before the patient's eyes. The patient is also told to concentrate his attention on the sounds of suggestion of sleep given by the hypnotizer. The hypnotic state can also be induced by passes. The patient concentrates his whole attention on the passes made over him. While the patient is concentrating his attention, there should not be distracting noises. He should listen to the hypnotizer's monotonous voice or to some monotonously sounding apparatus. Any monotonous stimulation in fact will do, such as monotonous stroking or patting, uniform alternation of light and shade, such as flickering, or uniform alternation of sound, uniform movement, swinging, rocking, or rotating will bring about the effect of plunging the patient into a hypnotic state. The patient's voluntary movements should be restricted. He should keep quiet and, as much as possible, have his limbs completely relaxed. At the same time, the patient's field of consciousness should be limited. Ideas should be banished as subconscious manifestation 27 much as possible. A state of monoidism should be induced. The subject should only think of sleep, sleep, sleep. In short, all ideas and reasoning should be inhibited. Sometimes all this can be brought about by a sudden strong stimulus unexpected by the patient. The intense emotion of fear aroused in the patient fixes the patient's mind on the stimulus, which paralyzes his consciousness and his motor adjustments. The patient falls into a state of physical and mental relaxation with a monotonous consciousness, into a state of physical and mental inhibition. These procedures produce that peculiar state known as hypnosis, in which the subconscious comes to the foreground. I have for many years employed a method which gives uniformly excellent results. I wish to attract the attention of the medical profession to this method of hypnoidization, as it is not only of theoretical importance for the purposes of psychopathological analysis, but it is possibly of still greater value for practical therapeutic purposes. In the Psychology of Suggestion and in other works I have pointed out the following conditions of normal and abnormal suggestibility. 28 Normal diagnosis of psychopathic diseases. Suggestibility. Abnormal suggestibility. 1. Fixation of attention. 1. Fixation of attention. 2. Distraction. 2-3. Monotony. 3. Monotony. 4. Limitation of voluntary move. 4. Limitation of voluntary movements, mens. 5. Limitation of the field of con. 5. Limitation of the field of consciousness, psiousness. 6. Inhibition. 6. Inhibition. 7. Immediate execution of the sug. 7. Gestion. In the same work I come to the conclusion, as the result of the investigation, that the nature of abnormal suggestibility is a disaggregation of consciousness, a slit, a scar, produced in the mind that may extend wider and deeper, ending at last in a total disjunction of the waking, guiding, controlling consciousness from the reflex consciousness. Normal suggestibility is of like nature. It is a cleft in the mind, only here the cleft is not so deep, not so lasting, as it is in hypnosis or in the state of abnormal suggestibility. The split is here but momentary, evanescent, fleeting, disappearing at the very moment of its appearance. We have also shown that the laws of normal and abnormal suggestibility may be stated as follows. Normal suggestibility varies as indirect suggestion and inversely as direct suggestion. Abnormal suggestibility varies as direct suggestion and inversely as indirect suggestion. The general law of suggestibility is, suggestibility varies as the amount of disaggregation, and inversely as the unification of consciousness. It is on these general laws and nature of relation of the personal consciousness to the subconscious that I have based my method of hypnoidization. In order subconscious manifestation to reach the dissociated mental states, we have to lay bare the subconscious, and this can be effected by the conditions requisite for the induction of normal or abnormal suggestibility, conditions which bring about a disaggregation of consciousness. In cases, therefore, where hypnosis is not practicable and the subconscious has to be reached, we can effect a disaggregation of consciousness and thus produce an allied subconscious state by putting the patient under the conditions of normal suggestibility, fixation of attention, distraction, monotony, limitation of the voluntary movements, limitation of the field of vision, inhibition, and immediate execution. This is precisely what the method of hypnoidization consists in. The patient is asked to close his eyes and keep as quiet as possible, without, however, making any special effort to put himself in such a state. He is then asked to attend to some stimulus such as reading or singing, or to the monotonous beats of a metronome. When the reading is over, the patient, with his eyes shut, is asked to repeat it and tell what comes into his mind during the reading, or during the repetition, or immediately after it. Sometimes the patient is simply asked to tell the nature of ideas and images that have entered his mind. This should be carried out in a quiet place, and the room, if possible, should be darkened so as not to disturb the patient and bring him out of the state in which he has been put. As modifications of the same method, the patient is asked to fixate his attention on some object while at the same time listening to the beats of a metronome. The patient's eyes are then closed. He is to keep very quiet. 30 Diagnosis of psychopathic diseases while the metronome or some other monotonous stimulus is kept on going. After some time, when his respirations and pulse are found somewhat lowered, and he declares that he thinks of nothing in particular, he is asked to concentrate his attention on a subject closely relating to the symptoms of the malady or to the submerged subconscious states. The patient again may be asked to keep quiet, to move or change position as little as possible, and he is then required to look steadily into a glass of water on a white background, with a light shining through the contents of the glass. A mechanism producing monotonous sounds is set going, and after a time, when the patient is observed to have become unusually quiet, he is asked to tell what he thinks in regard to a subject relating to his symptoms. He may be asked to write the stray ideas down, if speaking aloud disturbs the induced states favorable to the emergence of the dissociated mental states. In some cases it is sufficient to put the patient in a quiet condition, have his eyes shut and command him to think hard of the particular dissociated states. The method of guessing has been for years utilized by my collaborators and myself as a clinical method for coming in contact with the subconscious, dissociated systems of which the patient remained unaware in his otherwise normal waking consciousness. The patient is put in a chair, or on a lounge, is told to be quiet and have his eyes shut. He is then told to concentrate his attention on some of the more prominent symptoms of his trouble and tell immediately any idea, phrase, sentence, picture or image that may at that moment enter his mind. In this way we obtain scraps from his subconscious manifestation, subconscious life activity. On fitting them together we have something to start with in the psychognosis of the cases. I further combined this method with the methods of studying the patient's dreams. The patient's dreams are near the surface of his everyday waking consciousness, and since they are experiences coming from his subconscious life activity, I could, by the method of guesses, obtain the dreams which the patient experienced and which have often proved to be chips of experience which went to form his present mental makeup, and have been the cause of his present disease with all its characteristic symptoms. The patient often lived through in his dreams the events which caused his psychopathic malady. The experiences are usually obtained in chips, scraps, and bits. By piecing them together we penetrate more and more deeply into the patient's subconscious mental activity. This method of guesses together with the method of studying the dream activity yield, along with other methods, such as the direct observation of the dream activity and along with the hypnotic state, good material for psychognostic purposes. My clinical and laboratory researches led me, however, by degrees to the discovery of the hypnoidal state, which I have since found to be of the utmost consequence for psychognostic and psychotherapeutic purposes. In fact, I found that in most of the cases what I thought to be a state of waking consciousness was in reality a hypnoidal state. In directing the patient to close his eyes and keep quiet and concentrate his thoughts on a definite symptom, dream or event in his life, I found that the patient passed into a L32 diagnosis of psychopathic diseases hypnoidal condition. This led me to the formulation of the method of hypnoidization, or the induction of hypnoidal states. Chapter The Bihypnoidal 2 Twilight State. The method of hypnoidization. We produce a peculiar state which, for the lack of a better term, I designate as hypnoidal twilight state. What is the hypnoidal state? The hypnoidal state is essentially a borderland state. The subject is apparently awake and seems to be in full possession of all his powers, and still he is more closely in touch with the dissociated experiences than he is otherwise in the full waking state. Perhaps the sub-waking state would possibly be an apt term for the hypnoidal condition. The subject seems to hover between the conscious and the subconscious, somewhat in the same way as in the half-drowsy condition we hover between wakefulness and sleep. The hypnoidal state is not a stable condition, it keeps on fluctuating from moment to moment, now falling more deeply into a subconscious condition in which outlived experiences are easily aroused, or again rising to the level of waking states. In such conditions the patient often tells you something has come, but it is gone. The hypnoidal state has changed, it has become lighter, and the dissociated moments have become again submerged. There is a constant struggle going on in the hunting out of the stray dissociated systems. The state brought about by hypnoidization is essentially a transient, evanescent, mental disaggregation of 33-34 diagnosis of psychopathic diseases, the personal consciousness from the reflex subconsciousness. The hypnoidal state borders closely on light hypnosis, and still it is not exactly a hypnotic state and may be regarded as an intermediate state. In a series of experiments on the nature of sleep of lower animals as well as of infants and adults, the facts tend to indicate that the hypnoidal state is intermediary between hypnosis and sleep on the one hand and the waking state on the other. The hypnoidal state may either lead to sleep or to hypnosis. The close relationship of the hypnoidal state and of hypnosis is sometimes forcibly brought to the attention of the experimenter. Some patients while in the hypnoidal state are observed to become unusually quiet, less talkative, become relaxed, and after a time a distinctly cataleptic condition of the extremities may be observed. The patient has apparently passed into hypnosis. In most of the cases the hypnosis is of brief duration, while in a few cases the hypnosis may become lasting and deep. On the other hand, in many cases the subject falls into a sleeping state without as much as touching on hypnosis. The hypnoidal state is an intermediary state, intermediate between the waking state, sleep and hypnosis. Subwaking may possibly be an appropriate descriptive term of the character of the hypnoidal state. The subwaking, hypnoidal state, like sleep and hypnosis, may be of various depth and duration. It may range from the fully waking consciousness, and again may closely approach and even merge into sleep or hypnosis. The same patient may at various times reach different levels, and hence subconscious experiences the hypnoidal twilight state 35 which are inaccessible at one time may become revealed at some subsequent time, when the patient happens to go into a deeper level of the hypnoidal state. On account of the instability of the hypnoidal state and because of the continuous fluctuation and variation of the depth of its level, the subconscious dissociated experiences come up in bits and scraps and often may lack the sense of familiarity and recognition. The patient often loses the train of subconscious associations. There is a constant struggle to maintain this highly unstable hypnoidal state, and one has again and again to return to the same subconscious train started into activity for a brief interval of time. One must pick his way among streams of disturbing associations before the dissociated subconscious experiences can be synthesized into a whole, reproducing representatively the original experience that has given rise to the whole train of symptoms. The hypnoidal state may sometimes reproduce the original experience which, at first struggling up in a broken, distorted form and finally becoming synthesized, gives rise to a full attack. The symptoms of the malady turn out to be portions, bits and chips of past experiences which have become dissociated, subconscious, giving rise to a disaggregated subconsciousness. The method of hypnoidization and the hypnoidal states induced by it enable us to trace the history and etiology of the symptoms and also to effect a synthesis and a cure. Any arrangement of external circumstances tending to produce monotony and limitation of voluntary movements brings about a subconscious state of suggestibility in which mental life can be affected with 36 diagnosis of psychopathic diseases. I find that in that subconscious state, consciousness is vaguer than in the waking state, and memory is more diffused, so that experiences apparently forgotten come in bits and scraps to the foreground of consciousness. Emotional excitement becomes calmed, voluntary activity is somewhat passive, and suggestions meet with little resistance. The induced subconscious state is a rest state, a state of physical and mental relaxation. It is a state of rest and relaxation that is specially amenable to psychotherapeutic influences. The important results obtained by me led me to a closer study of what I then thought was a peculiar mental state designated by me as the twilight subwaking, or the hypnoidal state. The subwaking, or hypnoidal state is essentially an intermediary twilight state belonging apparently to the borderland of mental life. On the one hand, the hypnoidal state closely touches on the waking condition, on the other, it merges into sleep and hypnosis. A close study of the hypnoidal state shows that it differs from the hypnotic state proper and that it can by no means be identified even with light hypnosis. In my years of work on patients and subjects, I have observed the presence of the hypnoidal state before the development of hypnosis and also before the onset of sleep. When again the hypnotic or sleep state passes into waking, the hypnoidal state reappears. The hypnoidal state then emotional state. Be regarded as an intermediate and transient somewhat related state has been long known in psychological literature as the hypnagogic state which precedes the oncome of sleep and is rich in hallucina. The hypnoidal twilight state 37 known under the term of hypnagogic hallucinations. In coming out of sleep, a closely related state may be observed, a state which I have termed hypnapagogic. In both states, hypnagogic and hypnapagogic, dream hallucinations hold sway. The hypnagogic and hypnapagogic * states do not belong to light hypnosis, as it can hardly be claimed that men fall into light hypnosis twice or possibly more than that every day of their life. We do not go into light hypnosis with every nap we take. We do, however, go into the hypnoidal state when we pass into sleep or come out of sleep. Every drowsy state has the hypnoidal state as one of its constituents. Every sleep state is preceded and followed by the hypnoidal state. Hypnosis may be regarded as belonging to abnormal mental states, while the hypnoidal state is more closely allied to waking and sleep and, as such, belongs to the normal, physiological, mental states. At first, I regarded the hypnoidal state as peculiar, but as I proceeded with my observations and experiments I could not help coming to the conclusion that the hypnoidal state is found in all the representatives of animal life and is as normal as waking and sleep. The hypnoidal state may be said to partake not only of the nature of waking and sleep, but also to possess some characteristics of hypnosis, namely, suggestibility. It is clear that from the very nature of its mixed symptomatology the hypnoidal state is variable and highly unstable. The hypnoidal state may be regarded more in the light of an equivalent of sleep. Like sleep, the hypnoidal state has many levels of depth. It differs. Hypnagogic states are hallucinatory dream states appearing just before falling asleep. Hypnapagogic are hallucinatory dream states experienced just before waking. 38 Diagnosis of psychopathic diseases. However, from sleep in the rapidity of oscillation from level to level. In the experiments of various investigators, the depth of sleep is found to be represented by a rapidly rising curve during the first couple of hours and by a gradually descending curve during the rest of the hours of sleep. Michelson measured the depth of sleep by the intensity of sound stimuli that can awaken the sleeper. The stimulus was the fall of a ball of a definite mass through a definite distance. Plotting the hours of sleep on the abscissa and the sound stimuli in thousands of gramma-centimeters, he finds the curve of sleep falls rapidly after the first hour. 1510501234567 Colescutter, who also worked with sound stimuli, represents the sleep curve as follows. The hypnoidal twilight state. 39 Santi de Sanctis and Nevros worked with the esthesiometer on the senses of touch and pressure. They found that the sleep curve should be represented as follows. 01 No such regularity of curve can be found in the hypnoidal state. The depth of the hypnoidal state changes very rapidly, and with it the passive condition and suggestibility of the patient. Chapter The Hypnoidal 3 Twilight State Infants in Animals and of the I find in my experiments on the induction oida state in man that the hypn int conditions of monotony, limitation of voluntary movements, limitation of the field of consciousness are of the utmost consequence. In my experiments on animals I followed the same line of work and as far as possible reproduced the same conditions. I tried to limit the incoming sensory impressions, to limit the voluntary movements, relax them as much as possible and produce a monotonous state by the continuous inhibition of new and varied stimulations. After narrowing down the animal's psychophysiological activity I invariably found that when I succeeded in maintaining closely the same conditions which have been found favorable in human subjects for the induction of subwaking states, the animal uniformly fell into a passive condition closely analogous to the subwaking state and in many instances into a deep sleep. The condition of the animal was often strikingly similar to the one observed in the human subject. The respiration and pulse were lowered, while mental activity in the higher animals, alertness of sensory and motor reactions to external stimulations in the lower animals became greatly reduced and even completely suppressed. In the higher animals, such as dogs, a transitory cataleptic state, a state in which the voluntary hypnoidal state in animals and infants' 41 muscles retained the position given to them, could be observed accompanied by a disturbance of respiration and heartbeat. The slight disturbance then subsided and calmness supervened. The calm lasted but a brief period of time and the disturbances reappeared. The latter were once more succeeded by calm which ended by a full waking state or by a deep sleep. In other words, the experiments allow me to draw the conclusion that I had here the typical manifestations observed under the same conditions in the human subjects. I found here the manifestations characteristic of the intermediary hypnoidal states, the animal now passing into waking and now falling into sleep. In the series of experiments carried out on frogs, I find present the conditions of monotony and limitation of voluntary movements, as well as of limitation of what may be regarded in the frog as consciousness, or of the limitation of the activity of the sensorium by cutting off the regularly incoming sensory stimulations. As a result, we find something analogous to what we should have expected in the human subject under like conditions, namely, the presence of peculiar passive states. That is all that we are thus far justified in saying of them, observed and described by experimenters who do not have the possibility of getting the subjective experience of animal under observation. What we find in the state of the frog is a condition somewhat analogous to what we have found in our experiments in the human subjects, namely the presence of intermediary states of the subwaking hypnoidal type. The symptoms observed differ somewhat, but in general they may be regarded as alike. We find %42 diagnosis of psychopathic diseases passive state with cataleptic manifestations. The state varies from catalepsy to relaxation, or what may be regarded as lethargy, and again from passivity to activity, from sluggish to very lively reactions in response to external stimulations. We have therefore here manifestations which remind one of like manifestations in the human subject, namely, subwaking hypnoidal states which are on the borderland of waking, hypnosis, and sleep. Of course, we should not expect to find that frogs which stand so low in the scale of vertebrates would manifest phenomena of the higher vertebrates, but we should expect that some similar phenomena, though otherwise widely different, would be present. This is precisely what we find in the frog. We find the general characteristics, though rather vague, of what is afterwards fully developed in man as the subwaking, hypnoidal state. We must remember besides that the hypnoidal state is very unstable and its manifestations, having the characteristics of waking state, sleep, and hypnosis greatly vary in different individuals, and at different times in the same individual. We should therefore expect that the hypnoidal state would show still more radical differences from the typical in the various species of animals, especially in those that stand so far apart from each other as frog and man. What is surprising to MLE is not the variation and great difference of the hypnoidal state in the frog as contrasted with that of man, but that the difference is really not far greater, considering the gap that exists between the two organisms. In fact, the similarity is far more striking than the difference between the hypnoidal states of the two. Hypnoidal state in animals and infants. 43 trusted organizations so widely apart in the scale of evolution. My view then is that the phenomena observed in the frog are hypnoidal in character. The phenomena themselves as well as the conditions under which they are induced warrant my view of the hypnoidal nature of the states. In this respect we can well understand the apparent disagreement of the early observers on the subject. Chermak and Danilewski regard the phenomena as being of the hypnotic order, Hubel regards them as being more of sleep states, while Preyer views them as being the results of fright which give in the waking state cataleptic manifestations closely similar to those observed in hypnosis. Verworn, who regards the phenomena as large coercion due to central inhibitions, really does not conflict with any of the views. It is simply a general physiological hypothesis which may be in accord with any view, a physiological hypothesis which may or may not be true. It is a hypothesis far removed from the special facts and should be tested on its own merits. My point of view is not a matter of hypothesis, but describes and explains the phenomena in terms of states having similar manifestations and produced under the same conditions, states which are more developed and stand out more pronounced in higher animals. These states possess many of the characteristics of waking state, sleep, and hypnosis. Hence the reason why the early observers regarded the phenomena as waking states, others considered them as hypnosis, while other investigators regarded the phenomena as sleep states. 44 Diagnosis of psychopathic diseases. As a matter of fact, the phenomena and the conditions under which they are induced make the view highly probable that the different investigators are not far from the truth, but not being acquainted with the peculiar hypnoidal states described, they observed the phenomena in two one-sided terms, in terms of sleep, or hypnosis, or of waking states. In reality, the phenomena and conditions under which they are induced point strongly to the fact that the states are hypnoidal in character, states which partake at once of all the three apparently contradictory manifestations: waking, sleep, and hypnosis. Now the manifestation of the waking state, now the symptoms of sleep, and now again those of hypnosis predominate. The state induced in the frog under the conditions of monotony, limitation, and inhibition is a variety of the sub-waking, hypnoidal states. This induced hypnoidal state, being intermediary in character, may either partake of the catalepsy of hypnosis strongly modified and manifesting itself differently in the frog than in the human subject, or may again go over into the passive state of sleep or some state analogous to it. It is perhaps of importance to call attention to the significant fact that the first stages induced in the frog are rather of an unstable character. The frog, when put on its back and kept down for but a short time, falls into an apparently cataleptic state of short duration. The animal soon rights itself and is fully awake as before. This instability is very characteristic. Now the hypnoidal states are characterized by this fundamental trait of instability. It is only when the condition of monotony, limitations of voluntary movements and inhibition are sufficiently prolonged, that the catahypnoidal state in animals and infants 45 lepsy becomes more or less fixed for some period of time, and when this passes off, and the conditions under which the frog is kept are continued still further, it is only then that the frog sinks into a passive state which may last indefinitely, unless brought out of it by some strong stimulation. It seems to me then, that if we take all this into consideration, we cannot possibly describe the state in which the frog is put, in other terms than what we have on other occasions discovered to be the intermediary, sub-waking, hypnoidal state. The experiments on guinea pigs gave results somewhat similar to those of the frogs, though the cataleptic states were not so pronounced, in fact they were transient. Still the induction of sleep was brought about under conditions of monotony, limitation, and inhibition. It was far more difficult to bring about rest or passive states in guinea pigs than in frogs, on account of the great liveliness and ceaseless activity of the pigs. At times anesthetics were resorted to in order to facilitate the production of hypnoidal states. It may be objected that the anesthetics somewhat modified the result, because it may be claimed that the sleep states induced were really due to the anesthetics used. This objection, however, can be easily obviated by the rejoinder that the action of the anesthetic was only to reduce the extraordinary activity and restlessness of the animal and thus make it easier to induce sleep. The sleep states themselves were really produced under the same conditions as were the ones induced in frogs and in my human subjects. In fact, even when the guinea pigs were really lively and active, it was sufficient to subject them to the conditions described. When they gradually fell into a state very much of the CHA 46 diagnosis of psychopathic diseases, actor of hypnoidal states and sleep. The phenomena though were not so well marked as in the frogs. A set of experiments were carried out by me on birds and chickens with similar surprising results. The birds were subjected to the general conditions of hypnoidization. In all the subjects the manifestations of the hypnoidal state were clearly observed. In the experiments on kittens we find the phenomena of the sub-waking states somewhat more developed than in the guinea pigs or in the frogs. The cataleptic phenomena are not so pronounced as they are in the frog, but the manifestations of the sub-waking states approach more closely the manifestations observed by me in human subjects. The state is more hypnoidal in character, there is present the transient scarcely perceptible catalepsy which appears for but a moment, giving way immediately either to sleep, or to the waking state. Of course, we should not expect to meet with a typical, fully developed suggestibility or somnambulistic state in guinea pigs or in kittens, considering the fact that even in man, the imbecile, the idiot, and the mentally obtuse hardly go into any such a state. It requires a mind of a highly organized constitution to get into a state of abnormal suggestibility and of somnambulism with their accompanying manifestations. What, however, we do find is the characteristic instability of the manifestations of the intermediary, subwaking, hypnoidal states, having some of the most general somatic symptoms of hypnosis, such as slight catalepsy, but leading into a passive condition on the intensification of the state. The state in which the animal is plunged under the condition of monotony. Hypnoidal state in animals and infants 47 and limitation is hypnoidal, leading towards sleep. Dogs are subject to the same conditions of sleep states as is the case with other animals experimented upon. The experiments on dogs bring out the fact that the conditions requisite to induce hypnoidal states in men also hold good in the case of dogs. The hypnoidal states, both in falling into, as well as rising from sleep, are far more pronounced in the dog than in the lower animals experimented upon. The states themselves come up far more closely to similar states observed in man under the same conditions of monotony, limitations, and inhibition than they do in other animals, such as the frog, the guinea pig, the cat. Phylogenetically regarded, the hypnoidal is the primitive rest state out of which sleep and hypnosis have become differentiated. The lower the animal, the more insecure, the more unstable are its rest states. The animal must be on the alert in its rest, and sleep if at all, with its eyes open, so to say. It must be quick to wake and run from danger, or if it cannot get away, it must freeze and feign death. In other words, it must be able for the sarke of protection to fall into a state of catalepsy. Hence the rest states must partake of waking, sleep, and hypnosis, that is, must be essentially hypnoidal in character. The experiments on dogs are more instructive than the ones carried out on other animals, because they clearly bring out the general principle of monotony and limitation in the causation of sleep. Diminution in the variability of the volume of sensory impressions brings about the hypnoidal state as well as that of sleep. The experiments on animals were followed by X48 diagnosis of psychopathic diseases experiments on children. The subjects were of different ages ranging from infants a few days old, to children 12 and 13 years of age. It is well known that children usually fall asleep more easily than adults, they sleep longer and also more soundly. This is especially the case with young children and particularly with infants. We know that an infant passes most of its time in sleep, when it does not eat. We should expect therefore that the material would readily lend itself to our present purpose of experimentation, to the induction of sleep states. As a matter of fact, I find that in a number of my cases dealing with children it is no difficult task to put them to sleep, or to induce some form of subwaking state, hypnoidal or other closely allied to it. The child easily falls into a subwaking, hypnoidal state. When trying to put children to sleep I have often obtained a hypnotic condition, and on the other hand when attempting to put my little patients into a hypnotic state I have only succeeded in putting them to sleep. Before going, however, into either the hypnotic or sleep state, I observed, by close examination, the presence of the hypnoidal state, induced under the conditions of monotony and limitation of voluntary movements. Since limitation of the voluntary activity, limitation of the field of consciousness, and inhibition all help to a greater monotony, we may characterize the whole set of conditions requisite for the induction of sleep as the conditions of monotony. In children, especially in infants in whom voluntary activity and the field of consciousness are undeveloped and limited, we should expect the child would form a far better soil than the adult for the induction of the intermediary subwaking hypnoidal state in animals and infants, 49 states and sleep. This is precisely what we find to be the case. Moreover, the mind of the child, and more particularly that of the infant, specially depends on muscular activity and on the wealth of incoming sensory impressions. That is why the child and the infant take such delight in motor activity, in tasting, testing, and handling things. If now the motor activity is limited and the main source of sensory impressions, such as sight, is restricted, and if the environment is kept in a state of monotony, such as darkness and lack of auditory stimulation, or monotony is brought about by continuous noise and buzzing of some instruments producing a uniform noise, the child, on account of the poverty of its inner mental life, easily falls into a subwaking, twilight hypnoidal state, and then into sleep. Thus we find that in infants and children, as in lower animals, sleep, hypnosis, and twilight hypnoidal states are intimately related. The hypnoidal chapter 4, twilight state and sleep and limitation of voluntary NY monoto movements, work in one direction. They tend to raise the thresholds of psychomotor reactions, they cooperate in the induction of sleep. These conditions are usually brought about naturally in the course of the daily or nightly life activity of the individual organism, or the conditions may be produced artificially. In both cases the result is the same, the organism falls asleep. In the life of higher animals the two cases may often combine. When the individual has fagged out his life interests in his active relations with his surroundings, when the stimuli have become monotonous to him, and his activity with its correlative motor consciousness has become limited and lowered, he makes artificial arrangements for the intensification of the conditions of monotony and limitation of voluntary activity. He seeks for a dark nook, closes his eyes to exclude as much as possible all extraneous disturbing stimulations and tries to lie down quietly and comfortably, restricts his voluntary movements, breaks his connection with the external world, and goes to sleep. The organism falls into sleep when the thresholds rise, wakes and rises when the thresholds fall. Looked at from a physiological standpoint and expressed in terms of energy, of the cell energy, sleep by threshold is meant the just perceptible stimulus requisite to set a system into activity. The hypnoidal twilight state and sleep 51 may be regarded as the onset of fatigue, as the onset of exhaustion of the levels of dynamic energy in response to external stimuli. Each particular stimulus has its maximum amount of energy which can be drawn upon, under ordinary conditions of daily life. As the special stimulus approaches its limit, it works under greater and greater difficulties, draws less and less energy, and finally ceases to awaken any response. The threshold is raised to its maximum and the organism, as far as that special stimulus is concerned, is no longer awake, the organism is asleep. In the course of its daily activity the same takes place in regard to most of the objects, to most or to all of the stimuli that constitute the external world of the organism. The stimuli of the external world have drawn all that was permitted to them on their bank accounts, so to say, and the account for the time being is closed. Nothing more is permitted to go out. No stimulus of ordinary life is permitted to draw over and above a certain amount. There must always be ready capital for unusual situations, for emergencies. When the stimuli have drawn their due, and the organism is left with its reserve energy, liberation of energy with its accompanying waking states ceases. The organism is no longer awake to the stimuli and is asleep. As in the waking states the catabolic processes predominate, so in sleep the reserve processes, the anabolic, take the upper hand. The organism begins to recuperate its losses and fills up the accounts drawn upon by the stimuli of the external environment, when in active relation with them. With the increase of the income of energy, the raised thresholds begin to fall until a 52 diagnosis of psychopathic diseases point is reached, when the stimuli once more overstep the lowered thresholds and once more gain access to the stores of life energy. The organism awakes and enters into active relations with the environment. Regarded then from various standpoints, sleep is a rise of moments thresholds under conditions of monotony and limitation of voluntary movements. In this respect, sleep strongly contrasts with hypnosis. In hypnosis, the individual is especially accessible to any kind of suggestions coming from the external world. The psychomotor reactions are greatly lightened and are released by the suggestions or external stimuli with great facility, far greater than in the waking state. This great facility is often expressed by the statement that in hypnosis the inhibitions are removed. What specially characterizes hypnosis is the fact of fall of thresholds, present in individuals with a predisposition to states of dissociation. In sleep, on the contrary, we have found from our study, the general characteristic is rise of psychomotor thresholds. In passing from the waking state into the subwaking hypnoidal state, the individual may either pass into hypnosis with its dissociated states and lowered psychomotor thresholds, or may go into sleep with raised psychomotor thresholds. The process of redistribution of thresholds in the hypnoidal states brings about a fall of thresholds, due to predisposition to and further cultivation of dissociations. The result is hypnosis. When the redistribution in the twilight states brings about a rise of thresholds, the result is sleep. The sleep states of higher animals are developed out of undifferentiated, intermediary, subwaking, hypnoidal-like states found in the resting states of the low. The hypnoidal twilight state and sleep 53 are representatives of animal life. The hypnoidal state is the primitive rest state out of which sleep arises. Briefly put, the hypnoidal state is the germ of sleep. Chapter The Primitive R-V Rest State He long series of experiments carried out on frogs, rabbits, guinea pigs, kittens, dogs, infants and adults clearly prove that the happy-smiley-noidal state is by no means confined to man, but is also present in animals. This is very important, as it shows indubitably how widely spread the hypnoidal state is throughout the domain of animal life. Moreover, the experiments clearly prove that the further down we descend in the scale of animal organization, the more prominent, the more essential, does the hypnoidal state become. The conclusion is forced upon me that the hypnoidal state is the primitive rest state out of which sleep has arisen in the later stages of evolution. We may say that sleep and hypnosis take their origin in the hypnoidal state. Sleep and hypnosis are highly differentiated states. They have evolved out of the primitive, undifferentiated, hypnoidal state, which is essentially a subwaking rest state characteristic of early and lowly organized animal life. The hypnoidal state is the primordial sleep state. The development of the hypnoidal state into sleep has proven itself useful in the struggle for existence of the higher animals. It has, therefore, become fixed as the rest state characteristic of the higher representatives of animal life. Hypnosis, as well as other trance states, variations of the primitive, hypnoidal rest state, have become eliminated as useless and possibly harmful to the normal life adjustments of the higher animals, and 54 the primitive rest state 55 can only be induced under artificial conditions in but a fraction of the human race. The hypnoidal state is the normal rest state of the lower vertebrates and invertebrates. The rest or sleep state of the lower animals is a sort of a passive waking state, a subwaking state which has survived in man as the hypnoidal state. Of course, the state has been largely modified in man by the course of evolution, but it can still be clearly detected. just as the tail of the simian can be discerned in the human coccyx, or as the structure of the prehensible hand of the quadrumana can be still clearly traced in the foot of man. Waking, hypnoidal and sleep states may be termed normal states, while hypnosis and various other trance states may be termed subnormal states. The hypnoidal state is normal, it is present in all the representatives of animal life. Sleep, hypnosis, and trance states are variations of the fundamental hypnoidal state. The sleep state has proven useful and has become normal in the higher animals, while hypnosis and the various forms of trance states, likewise variations of the fundamental hypnoidal states and characteristic of man, have not proven of vital value and have fallen below the normal stream of consciousness with its concomitant adaptive reactions. The hypnoidal state is necessarily brief, variable and unstable. They who have observed the rest states of the lower metazo can form a clear idea of the nature as well as of the biological significance of the hypnoidal state in the life of the lower animals. The animal is at rest for a brief period of time as long as it remains undisturbed by external conditions of its environment, or by internal conditions, such as hunger, sexual impulses or other internal disturbances. Soon 56 Diagnosis of psychopathic diseases. The animal begins to move, sluggishly at first, and then more quickly, and, if there are no disturbing stimulations, comes to rest, to be again disturbed from its rest equilibrium by the varying conditions of its environment. The resting state is brief, irregular, in fits so to say, and differs from the waking state in but a slight relaxation and in comparatively slow reactions to stimulations and in a passive condition of the muscular system. Respiration becomes a little more regular and diminished in rate, the heartbeat is slightly decreased and general catabolic activity is somewhat reduced. The relation of the hypnoidal state to waking, sleep, hypnosis and other subconscious states may be represented with following diagram: Hypnoid prance, the primitive rest state 57. The animal, however, is quite alive to what is going on all around. The animal rests watching for danger. The resting and active states alternate periodically, if possible, but usually quite irregularly. The resting state is but a passive condition in which the animal may be considered to hover between waking and what we describe in the case of the higher animals as sleep. Sleep in its proper sense does not exist among the lower representatives of animal life. This state of hovering between waking and sleeping, the characteristic of the hypnoidal state, is no doubt of paramount importance in the life existence of the lower animals, considering the numerous dangers to which they are continually exposed. The animal must always be on the watch, either for food or for foe. It can only rest or sleep with its eyes wide open. The hypnoidal sleep can be best characterized as a sub-waking rest state. I demonstrated in my experiments that the animal while in the hypnoidal, sub-waking rest state is apt to fall into a cataleptic state, especially when the movements are suddenly and forcibly inhibited. This cataleptic state, which reminds one of the hypnotic state, may be observed in the lower animals, such as the frog, the snake, the lobster, the bird and, to a slighter degree, even in the higher animals, such as the guinea pig, the cat, the dog, especially in the young ones, such as the kitten, the puppy and the infant. There is little doubt that the cataleptic state into which animals fall during the hypnoidal rest state is of some protective value in their life. The animal freezes, feigns death and is thus either enabled to remain undetected by the animal on which it feeds or, what is 58 Diagnosis of psychopathic diseases still more important, is enabled to remain unnoticed by its enemy and thus escape certain death. The sub-waking, hypnoidal state may be regarded as the fundamental rest state of lower animals and is characterized by a mixed symptomatology of waking, sleep, and hypnosis. The hypnoidal state is found in man but in a rudimentary condition, It is a vestige of man's primitive, animal ancestors. The hypnoidal state is brief, variable, and forms the entrance and exit of repose, the portals of sleep. The primordial rest state has shrunk to a transitory, momentary stage in the alternation of waking and sleep. The subwaking, hypnoidal rest state shrinks with the increase of security of life. From a therapeutic standpoint, the hypnoidal state has proven to be an efficacious agency in effecting cures in psychopathic cases, often of a severe character. The great value of the hypnoidal state consists in the fact of its being a most powerful instrument in tracing the past history of the case, in learning the evolution of the symptoms of the disease, and in the discovery of the early germs of the fully developed symptom complex under observation and treatment. The study of the evolution of the malady, tracing its roots down to early child life, thus getting a full knowledge of the patient or the subject, is termed by me psychognosis. Dr. Leo Hirschlaff of Berlin, in a recent communication, tells us of the great psychotherapeutic value of the rest state, a form of hypnoidal state. He has even invented a couple of instruments for the induction of that state, the hesychoscope and the respiration metronome. Chapter Psychognosis and the 6 Hypnoidal Twilight State. In the hypnoidal state, chips of former outlived experiences come under certain conditions to the sur. What these conditions are: phase of consciousness. We have described in this work. We can only add that in the hypnoidal states, lost memories can be reproduced. The patient is put under conditions favorable to the induction of hypnoidization and is asked to make mental efforts to bring up the lost psychic content. Once the patient discovers the successful working of this method, he begins to notice auto-hypnoidization, thus bringing to light many hidden memories and finally bringing about a synthesis of the dissociated subconscious moments. Memories in hypnoidal states may be induced spontaneously without the patient actually intending it, and sometimes under the influence of mental strain, excitement, or effort. The hypnoidal states may come up in a rush, as if hampering floodgates have broken down, and become associated and synthetized with the present functioning moment, with the present state of self-consciousness. I shall give here an account of the hypnoidal states as first observed by me in the classic case of the Reverend T.C. Hanna. When in the hypnoidal state any scene or word or name came up before his mind, it was completely wanting in the elements of recognition and familiarity. A name, for example, 5960 diagnosis of psychopathic diseases, came up before his mind. When asked of what he was thinking, he would simply give the name, but when we pushed our inquiry further and asked as to the meaning of the word, he replied he did not know. When told it was the name of a person or of an object, he was greatly surprised that what appeared to him as a combination of nonsense syllables arbitrarily arising in his mind should have a definite meaning. When he was asked if he had any vague feeling of ever having heard the word before, he invariably replied in the negative. Still more remarkable was the fact that at times, in the hypnoidal states, an entire scene or event arose before his mind. He could describe the scene or the event of his former life experience exactly as he saw it in his mind's eye. He could describe minutely all the details, and yet he had not the slightest trace of recognition that the incident was a former experience of his own. It was to him like arbitrary combinations of images and ideas, somewhat in the way as they take place in our waking reveries or in the dream states of sleep. As an example of such hypnoidal states, we may mention the mental condition of the patient during the recital of a Hebrew passage. Being a minister and having studied Hebrew at Yale, Mr. Hanna in his secondary state was tested with texts from the Hebrew Bible, texts with which he had been familiar in his previous life. What happened was striking in the extreme. During the recital of the Hebrew phrase, a flood of Hebrew passages came into his mind. He recited them aloud in that solemn intonation in which the Hebrew Bible had been studied by him in college. When asked the meaning of the phrases, he was at a loss. He had not the slightest notion what that all meant. It was to him a sort psychognosis and hypnoidal twilight state 61 of speaking with tongues affair, a mere conglomeration of meaningless syllables, mere gibberish. As in the phenomenon of speaking with tongues, the patient was frightened at the sudden outburst of a flood of meaningless jargon. Moreover, the memory for the part read to him was not bad. He was able to repeat each word and sometimes a couple of words and even a phrase as it came from the reader of the text. The texts brought up in the hypnoidal state were gone from his memory as soon as he delivered them. Only a few distorted words could be gotten out of him. The rest vanished from his memory. It was also of importance to notice that instead of imitating the reader who recited the texts to him, as one should expect in a case of imitating unknown words and phrases, the patient had a different inflection and a widely different pronunciation from those of the reader. They were resurrected memories of a buried personality, memories which lightning-like flashed on and vanished from the patient's mind. The unexpected sudden change in tone and manner of the patient's recital of the Hebrew phrases which in the hypnoidal state arose from the patient's subconsciousness were striking in the extreme. His voice became strong and sonorous, he recited impressively, as though from the pulpit. It seemed as if the words and phrases burst forth spontaneously and involuntarily in a moment of inspiration. As an instance of another hypnoidal state we may mention the following. Miss C, to whom the patient was greatly devoted in his former life, and whom he married after the complete cure and restoration of his 62 diagnosis of psychopathic diseases. Former personality, was a perfect stranger to the secondary personality. In one of the experiments this young lady was directed to take the patient's hand and sing a hymn which the young man had heard in his former, primary, personal existence, but had not heard since the injury. The patient was told to remain quiet and listen attentively to the hymn. During the song the patient remained passive, his whole attention was concentrated on the song. When the hymn was finished, he was asked whether he had ever heard anything like it before. He looked at us in bewilderment. When asked what had come into his mind during the singing, he gave 2 words which turned out to be names of people. The patient did not know the meaning of the words and certainly did not suspect that they were names. We learned from the family that the names were those of choir singers whom he knew some 3 years ago. The names flashed from the subconscious on the patient's memory, but without the slightest sense of recognition. I bring the experiments from the Hannah case. Because of its extreme form of dissociation, the characteristics of the hypnoidal state stand out clear and distinct, more so than they do in other cases in which the state of dissociation is comparatively slight. In the ordinary psychopathic cases the hypnoidal state does not present such a complete lack of recognition, still the memories appearing in such states are vague, fragmentary, being apparently devoid of all meaning. Perfect nonsense as the patient often puts it, and as such tend to fade, like the shadowy experiences of the dream states, into oblivion. Psychognosis and hypnoidal twilight state 63. The chance phrases, however, are not accidental occurrences, they refer to the patient's former experiences, and give an insight into the very depths of the patient's subconscious life activity. The hypnoidal state, the state in which all those vague, fragmentary, subconscious memories occur, is one of the most potent instruments of psychopathology and psychotherapeutics. Chapter the 7 Hypnotic State. Many hypnotic state was studied by me the GYOLOS year ago in my Psych of Suggestion. I give here a few brief statements sufficient for our present purposes. The hypnotic state requires the following conditions. The first condition is that of fixation of attention. Thus Braid used to hypnotize his subjects by fixing their attention on some brilliant object or point. He considered a steady attention indispensable. If hypnosis were to be obtained, the subject must look steadily at the object, he must think only of the thing he is fixating, and must not allow his attention to be diverted from it. The ability to direct one's thought in one particular direction is very favorable to hypnosis. They who cannot fix their attention, who are absent-minded, introspective or scatterbrained or hopelessly stupid cannot be hypnotized. 2. Monotony of impressions is another condition of the hypnotic state. The subject must be put into a relatively uniform environment and subjected to a series of monotonous stimulations. My method of hypnotization consists in forming monotonous surroundings. The light is lowered, a profound silence reigns in the room, then monotonously stroking the skin of the subject's forehead and in a low, muffled, monotonous voice go on saying, "Sleep, sleep, sleep," until the subject falls into a hypnotic state. The hypnotic state 65. 3. Limitation of voluntary movements is also a condition of hypnosis. The subject sits down on a chair in a comfortable position and is asked to be as motionless as possible. The subject is directed to abstain from all sorts of movements, not to move his limbs, not even to wink if possible, in fact, not even to attempt the slightest motion of the limbs, not even to think of a change of position. Muscular activity must remain completely relaxed. 4. Limitation of the field of consciousness must be brought about in order to induce hypnosis. The consciousness of the subject should be narrowed to one idea of sleep. Wundt defines the very nature of hypnosis as limitation of the field of consciousness, and to a certain extent he is justified in his assertion. We know that a strong emotion narrows down the field of consciousness. We often find that people under intense excitement lose their senses, so to say, their mind seems to be paralyzed, or rather to say the one idea accompanied by the intense emotion banishes all other ideas and a state of monoidism is thus affected. People are often run over by carriages, automobiles, on account of sudden great fright. The one idea of danger, the emotion of fright, reverberates in the mind like a sudden powerful clap of thunder, confusing and stunning all other ideas and emotions. The mind is brought into a contracted cataleptic state, the field of consciousness is narrowed down to one idea, to one emotion, to a single point. This mode of hypnotization which this particular condition is specially emphasized is successful with people of an intensely emotional nature, but who are not introspective in character. 66. Diagnosis of psychopathic diseases. V. Inhibition is another important condition in the induction of the hypnotic state. The subject must inhibit all ideas, all images, all emotions that may arise in his mind. The subject must think only of the brilliant point, of the tips of the hypnotizer's fingers, of the passes, of the idea of falling asleep. The subject must be able to inhibit all movements, all tendencies to action, all desires and cravings. All such conditions bring about that particular state of abnormal suggestibility known as the hypnotic state. Hypnotization produces a deep cleft in the mind of the subject, a cleft by which the waking, controlling consciousness becomes separated from the great stream of conscious life activity. That is why we have the strange accounts of hypnotic subjects, especially of those who were on the verge of somnambulism, that during hypnosis they were indifferent to the actions of their body, the latter acted by itself, that they were mere spectators of all the experiments performed on them, that it seemed to them that they themselves, their personality, retreated far, far away. The hypnotic state is specially characterized by the fact that associations and dissociations of muscular, sensory, glandular, neural, ideational, emotional and will activities can be brought about. Hypnotic trance is again characterized by the extent of memories which may be widened or contracted. Motor, sensory, glandular, ideational, emotional, memory changes may be effected, and transformations of personality may be brought about. We must however emphasize the fact which is too often forgotten, that all such changes are really and ultimately dependent on the changes produced by such the hypnotic state 67 in the ideas and beliefs of the subject. All the other changes are produced indirectly. The modification is essentially central, ideational, and emotional. The emotion of belief is specially affected. The hypnotized subject is a person in whom faith can be stirred to its very depths. The will is affected. The subject must be of an obedient temperament. The waking, controlling, critical consciousness is practically suspended in the hypnotic state. As I expressed it in another place, hypnosis with its allied states can modify, undermine, create belief, and important modifications may be brought about in the total mass of representative life activity. When the patient sinks into a deeper and deeper hypnotic condition, when the state is so profound as to verge on somnambulism, the waking, controlling consciousness hangs on a thread, so to say, to the rest of organic life, and when that thread too is cut off by suggestion, the waking guiding consciousness loses all contact with the stream of life. Some writers attempt to explain hypnosis by the fanciful theory that the hypnotic state is due to the awakening of so-called complexes or mental experiences of childhood. Where the maternal complexes predominate there the tendency is hypnotization by patting, petting, quieting and so on, while where the complexes of the more stern father predominate there the tendency is present to hypnotization by command and authority. This theory assumes suggestibility as a basal fact, but refers it back to infancy. To push back or repress an unexplainable fact into infancy is not to explain the fact. What sort of experiences in childhood gives rise to suggestibility? Is suggestibility an acquired state 68 diagnosis of psychopathic diseases, or is it a condition fundamentally characteristic of human nature? Psychological studies go to confirm the fact that suggestibility is a fundamental trait of human nature as much as is association of ideas. All that we can say is that certain experiences predispose to certain lines of suggestions, but suggestibility itself is a fundamental characteristic of man, both in his individual and social capacity, whether infant, child, adult, man, or woman. Once, however, we assume suggestibility, the whole parental theory is useless. There is no need of dragging in father and mother in order to fit them on Procrust's bed of some fad theory. The facts of hypnosis can be far better explained by the fundamental fact of suggestibility, which under conditions of removal of the critical, controlling consciousness stands revealed as the essential characteristic of the subconscious. Alcoholic drinks, various drugs, intense emotions, and even a blow on the head may do the same thing. Moreover, the adherents of the theory show little acquaintance with the most elementary facts of hypnosis. The sensorimotor manifestations such as catalepsy, rigidity, of which the patient or subject is not capable in his waking state, the increase of motor activity in certain directions which the subject is unable to perform in his waking state, the anesthesias and hyperesthesias which the subject cannot manifest in his normal condition, the hallucinations, the transformations of personality, the extreme mimicry which the hypnotic somnambulist manifests, a condition of which he is absolutely incapable in his waking condition, the amnesias characteristic of deep hypnosis, the post-hypnotic suggestions that can be delayed for many days, weeks, and months, the hypnotic state 69 presence of dissociated states which subconsciously keep the suggestions, states that can be manifested as hypnoid or co-conscious states of which the subject remains unaware. All these phenomena and a host of others are completely ignored by the paternal, sextal, or incest theory. They who have studied closely the phenomena of hypnosis cannot help coming to the conclusion that hypnosis is a state of dissociation brought about under special psychological and physiological conditions, such as concentration of attention, monotony of stimulation, inhibition of psychomotor activities. In this respect, most of the students in normal and abnormal psychology, though they may differ widely in other respects, agree that the hypnotic state is an inhibition of the upper consciousness, or the inhibition of the organ of a perception, as Wundt puts the same view. Recently other writers came to a similar conclusion. Hypnosis is a cerebral dissociation brought about by the factors of concentration of attention and monotony of stimulation. The hypnotic state is a state of increased suggestibility, it is a reflex consciousness. A changed physiological state must be assumed in hypnosis. This change consists in the disaggregation of the superior from the inferior centers, in the segregation of the controlling consciousness from the reflex consciousness. Strong persistent impressions or suggestions made directly on the reflex consciousness of the inferior centers may modify their functional disposition, produce sensory, motor, and glandular changes and thus affect trophic functions. Disaggregation, dissociation is what specially characterizes the hypnotic state. In the hypnotic state, the subconscious is laid bare. 70 Diagnosis of psychopathic diseases to the influence of the external environment. We get access through the subconscious to man's sensory, motor, and glandular activities, affecting his ideas, feelings and emotions. We can thus produce profound changes in man's life. The hypnotic consciousness is a reflex consciousness, unprotected by the reasoning, critical, controlling consciousness. Once the subconscious is freed from the controlling, guardian consciousness, profound modifications may be effected in man's mental constitution. From a practical therapeutic standpoint, hypnosis is of the utmost importance. Whenever it is possible, the hypnotic state should be used for the alleviation of nervous and mental suffering. Not to avail oneself of hypnosis in the treatment of mental troubles and claim the omnipotence of some other method as a panacea for mental affections is to show undue enthusiasm not justified by experience. Many psychopathic cases have been treated by me and cured permanently by means of hypnosis alone. Some of the cases were of severe character, and the employment of other states and methods would have required months, if not years of treatment with possibly no chance of recovery, on account of the dragging character of the treatment. Treated by hypnosis, the patients became permanently well after a few treatments. Some severe cases that went into a deep state benefited after the very first treatment, and became permanently cured after 3 or 4 treatments. This can hardly be affirmed of any method, no matter how enthusiastic one may be about it. Whenever therefore it is possible to obtain a deep hypnosis, the latter should by all means be used. Hypnosis is a powerful instrument. The hypnotic state 71 meant in the armamentarium of psychotherapy, and the medical man who wishes to get successful results should cultivate its use. It is greatly to be deplored that the use of hypnosis is abandoned by some medical enthusiasts for some new theory and is regarded with neglect and even with scorn. It is acting too deliberately in the interest of some hobby, to cut oneself from the use of one of the most powerful weapons of controlling the aberrations of the subconscious, the source of psychopathic maladies. The hypnotic state is of no less importance from the standpoint of psychognosis, that is, from the standpoint of the finding out the patient's condition, learning the history of the case and following the evolution of the mental malady from its earliest beginnings. We can trace the various symptoms of the disease down to the very roots of early childhood and watch the stages of the development of the malady, since in some interesting and instructive cases the patient can be actually made to live over the experiences that have gradually developed the present morbid condition. The most difficult, the most inaccessible recesses of the subconscious life can be searched in the hypnotic state. It is foolhardiness and mental blindness on the part of the physician to deprive himself of such an efficient instrument of research. It is to play into the hands of various superstitions and prejudices of the vulgar and the Christian Science sectarians, as well as of other would-be scientists who claim that the hypnotic state causes infinite harm to the human soul. As far as I am concerned, and I may possibly say it also for some of my colleagues who have devoted years to the study of hypnotic state and its effects, hypnosis is one of the greatest 72 diagnosis of psychopathic diseases discoveries made in the domain of psychopathology. It is much to be regretted that medical men who devote their life to psychopathology should disparage the use of hypnosis for psychognostic purposes. Hypnosis yields us one of the most powerful searchlights for the psychognosis of the subconscious. At the same time, we must point out an important fact often overlooked by investigators of hypnosis. The hypnotic consciousness is reflex in character. This led to the misunderstanding that the time element of the actions such as simple reaction time or association and choice time must necessarily be shortened. This, however, is not correct. The act or the idea suggested may be carried out, although the time which they take may even be lengthened. Some investigators have shown that reaction time is increased in hypnosis, while others come to the conclusion that reaction time is decreased. As a matter of fact, in some subjects there may be a lengthening and in others there may be a shortening of the reaction. The results are by no means contradictory. We must bear in mind the fact that we deal here with a state of high suggestibility. While certain suggestions meet with no resistance, others meet with increased resistance, due to the same factor of suggestibility. Such in reality we find the facts to be. Some subjects show a marked increase of reaction time, some show a decrease, and some show almost no variation. They who have had long experience with hypnosis expect no other results. It would have been far more difficult to understand the hypnotic states had there been a uniform lengthening or shortening of reaction time in hypnosis. The thresholds of the mental systems of the hypnotic state 73 hypnotic consciousness are not uniformly reduced, but they vary in different directions. Some fall, others rise, while again other systems remain unchanged. The heightening of thresholds of many systems in hypnosis is brought as an argument against the employment of the hypnotic state for psychognostic and psychotherapeutic purposes. This, however, should not be in the way of the experienced physician. A physician who finds difficulty in overcoming the rise of thresholds and the increase of resistance should give up his practice. As a matter of fact, there is always a way of lowering the thresholds of mental systems in the hypnotic state. Chapter H. Hypnoid states. Hypnoid states consist of the presence of two or more fully independent complex mental systems. Such states are found in the phenomena of automatic writing, shell hearing, crystal gazing, in the various forms of coexistent double and multiple personalities, and various other subconscious conditions. In automatic writing, the patient is in his usual state. He may be carrying on a conversation with someone, while at the same time, his hand in which a pencil is placed, begins and continues writing sentences, descriptions or entire essays and chapters in a well-formulated and lucid manner, the subject's upper or principal consciousness knowing absolutely nothing of what the hand had written. During the time of the automatic writing, the hand is anesthetic, but only in relation to the patient's upper consciousness. There is a well-organized system of consciousness controlling the automatic writing, since the hand itself may register responses to questions not understood and sometimes not even heard by the subject. Likewise, if the hand is pricked, although the subject himself does not feel the prick, the hand will nevertheless make marks to indicate the number of pricks. The various forms of double multiple personality have been described in multifile personality. See Dr. Morton Prince's The Dissociation of a Personality. 74 Hypnoid states 75 Immediately after the automatic writing ceases, sensibility returns to the anesthetic hand. All stages and forms of automatic writing are observed from mere scratches to highly complicated discourses. In fully developed cases, the handwriting is of a spasmodic character, as though executed with single rapid strokes. Hypnoid or coexistent functioning, though disaggregated states, may be cultivated with some success by normal healthy individuals. In some the dissociation is complete, in others it is but partial and the subject is conscious of what is going on, but he feels that he has no control over the writing, nor is it his consciousness that has formulated the writing. Instead of writing there may be automatic speaking. The phenomena are known under the name of speaking with tongues. The speaking may range, as in the case of automatic writing, from the simplest to the most complex, from the automatic volubility of meaningless syllables appearing as a new tongue or language, to a connected recital of intelligible phrases. The phenomena of crystal gazing belong to the same category and may be classed with hypnoid states. The vision, the hallucinatory experience, appears to rise from the subconscious and seems to develop independently of subject's consciousness. The subject takes cognizance of what is presented to him by the dissociated mental state, which develops on the basis of some peripheral sensory experience. It is possible to bring forth subconscious experiences by developing in the subject visual hallucinations. The subject looks into a reflecting shining surface, a crystal, a mirror, a glass of water. The subconscious self. 76 Diagnosis of psychopathic diseases brings out visual perceptions which appear as hallucinations to the upper self. The upper self sees the pictures projected by the subconscious self in the same way as the automatic writer reads the product of the automatic writing. The subject may, for example, perform a certain action such as misplacing an article or reading something unconsciously of which there is no recollection. Now the gazing into the crystal may bring out these past experiences as visual hallucinations. Occasionally the subconscious self may so develop in the phenomena of automatic writing or crystal gazing that automatic actions may be manifested and the patient falls temporarily into a complete subconscious state. We can also develop a form of auditory hallucination by bringing various experiences out of the subconscious. This can be accomplished by sounding or vibrating objects. The subject listens intently to the monotonous sounds and experiences, lost to the subject's upper consciousness, but retained by the subconscious, which come in the form of auditory hallucinations. In the many forms of psychopathic anesthesia of considerable persistence and extent, hypnoid states may be developed. The anesthetic hand, for instance, will react to various stimuli, handle different things, give intelligent answers in automatic writing to questions not directly heard by the patient. These phenomena can be brought out by various experimental procedures. Most of the cases of functional derangement and mental dissociation, such as the various forms of functional psychosis or psychoneurosis, fall under the category of hypnoid states. Various forms of sensory, hypnoid states 77 TOR, gastric, emotional, and other disturbances, when of a functional psychopathic character, are often due to subconscious systems dissociated from the patient's consciousness and manifesting their activity in the upper waking life. The patient is aware of the distressing results, but has no suspicion of the active subconscious processes that give rise to such manifestations. The dissociated system forms a center of activity that falls outside the domain of the patient's upper consciousness, the results alone appearing in the patient's waking life. Hypnoid states are coexistent, co-conscious states and may develop into coexistent, Co-conscious personalities. Chapter I. The hypnoidic 9 state. Hypnoidic state is the formation of a YWFLJ personality with a more or less definite character, a personality that is inaccessible to direct suggestion. The hypnoidic state, however, is amenable to indirect suggestion. By means of indirect suggestion it is even possible entirely to remove this hypnoidic personality, and have it replaced by another which may soon vanish to give room to another personality widely different in character and memories. Hypnoidic personalities rise like bubbles from the subconscious and vanish. They may, however, become well organized, stable and permanent. Hypnoidic states consist in the recurrence of outlived phases of the patient's personal life. The hypnoidic state forms a /YWTFJJ individuality, the upper consciousness of the patient being removed. Memories which the upper self is unable to recall and which seem to be altogether effaced suddenly rise to the surface of consciousness as the upper layers of mental activity are removed. In hypnosis, the removal of the waking consciousness is followed by a state of high reflex suggestibility, which is characteristic of the indefinite nature of the secondary self. In the hypnoidic state such suggestibility is absent, because another, 7W35F personality emerges having a more or less definite character, a personality which is not amenable to direct suggestion. By the hypnoidic state 79 means of indirect suggestion it is possible to remove this personality and replace it by another which may again be treated in the same way. Hypnoid states present phenomena of two or of more coexistent, dissociated, co-conscious mental systems. Hypnoidic states present phenomena of mental alternation. Instead of the simultaneity of two or more independent functioning systems of the hypnoid states, we find in the hypnoidic states alternation of two or more independently functioning systems. When one is present, the other is absent or is dormant subconsciously. The interrelation of the alternating states may be of such a character that they may be completely unknown to one another, or they may be known to one, but not to the other. Thus the first series of states may not know the second series, nor the second the first, or while the first series does not know of the second series does know the first. In the first case the dissociation is complete, in the second case, the dissociation is fully present in the primary series, but not in the secondary. Suppose, for the sake of illustration, consciousness consists of moments A, B, C, D, E, etc., then in the case where the states are unknown, the primary series consists say of A, B, while the secondary series consists of C, D, E, F. Both series are independent and dissociated and as such are unknown to each other. In the case, however, where the secondary knows the primary, but not the reverse, then the secondary consists of all the functioning moments while the primary consists only of A, B, and as such it does not know the rest of the moments C, D, E, F, etc. Secondary states may be wide and extensive. Diagnosis of psychopathic diseases enough as to include the primary states, or they may be narrow as to exclude them. In the former case the secondary states may be regarded as more or less complete states, while the primary states are the incomplete ones. Frequently, however, both primary and secondary states are incomplete, and while they may have in common many of the lower automatic and secondary reflex psychic activities, they lack common elements of conscious memory, and hence there is no recollection of one series by the other. The whole series of primary states represents a flowing synthetic organic unity with recognition and recollection of all the primary states, while all the secondary states form another independent, but also an organic unity having recognition and memory for all the secondary states that enter into the flowing unit. In other words, two personalities are formed which to all intents and purposes may be regarded as independent of each other and having two separate centers of synthesis, giving rise to the cyclical phenomena known as a double consciousness. If the cycle appears but once, we have monocyclical bimorphosis. If the cycle is repeated, the condition is polycyclical bimorphosis. There is, however, no reason why the separate series should be limited to two, although this is the most common occurrence. There may be many separate series, with as many independent foci of synthesis giving rise to as many different individualities. In such a case we have the phenomena of multiple consciousness or of multiple personality, in short, the phenomena of polymorphosis. If the cycle occurs but once, then the polymorphosis may be said to be monocyclic. If the cycle, the hypnoidic state 81, is repeated, the polymorphosis is polycyclical. The formed personalities in polymorphosis act as independent individual beings and enter into relations, conversations, and discussions, the whole presenting a dramatic play in which many personages take active part, successively as well as simultaneously. Such, for instance, are those functional cases of multiple personality, reported by many writers, cases which to a certain extent may be reproduced artificially. These many personalities may fuse and form a new personality with all the contents of memory belonging to them, and as such, may have recognition of all of them, or may entirely lack all recognition of them. The hypnoidic states may develop into distinct individualities which may become sharply defined in character with strong claims of independent personalities. They are jealous of their independence and strenuously resist attempts at fusion. The quasi-personality formed puts forth claims of being an independent individual, not even related to the patient's personality of which it is really a constituent. In such cases we usually find one or two predominating personalities which present a high degree of stability and individuality, while the rest are unstable. They come and go and get character and individuality by insistent questioning and indirect suggestions given to them by outside people and their surroundings. There is no doubt that the very interplay of the principal dominating personalities as well as of the subordinate ones is in itself an important factor in the strengthening of the various crystallized individualities, which at first may come into being in a rather amorphous condition. The interrelation of these different quasi-82 diagnosis of psychopathic diseases individualities, though seemingly so insistently and aggressively independent, is really a very intimate one. They are all chips of the same block. A hypnoidic state or fully developed independent personality may be formed of the whole or part of the content of the principal personality, but it does not recognize the source from which the content is really derived. The personalities, however, may become so far dissociated as to possess even different contents so that one cannot reproduce that of another. They are in short, crystallized and organized of different elements, and go to form different individualized moments consciousness, which as far as time relationship is concerned may stand in relation of coexistence, or succession, or even both. The character of the hypnoidic individuality is often some outlived phase of the patient's personal life. Such states may also be induced in hypnosis, but then the artificially produced hypnoidic state is vague and ill-defined. More frequently the hypnoidic state may be fully brought about in post-hypnotic states. I could affect an analogous state in my somnambulic subjects by post-hypnotic suggestion. The difference between the post-hypnotic and the true spontaneous hypnoidic state consists in the relation of the subject to external impressions. In the post-hypnotic state the subject receives external impressions directly and refers them to some external source. He hears, sees, feels, perceives things that happen around him, and frequently carries on animated conversations on different topics. Even in the case of post-hypnotic negative hallucinations, the patient is still fully alive to other not inhibited sense impressions that reach him from the hypnoidic state 83 all sides. Quite different is the true hypnoidic state. The sense organs of the patient are closed to the impressions of external stimuli. He does not perceive anything that takes place around him. His environment is that of the past, and in it he lives and moves. Shut up within one of his past lives, he remains insensible to the world of his objective present. If by chance any impressions do reach the subject, they are at once worked into his present hallucinatory life experience. If the patient is touched, squeezed, pricked, he feels nothing at all, he is totally anesthetic and analgesic, and still within his vision he may be extremely sensitive to pain, shiver from cold, complain of fatigue, and undergo tortures of pricking sensations caused by a strong gale blowing icicles into his face. Of such a nature were the visions in the case of Hannah. The patient hears none of the conversation carried on in his presence. When the patient is spoken to on subjects not directly related to his resurrected life experience, he makes no reply, he simply does not hear. Only when he is addressed on something relating to the experience he is passing through, it is only then that he makes a reply. He does not realize, however, that it is someone else who speaks to him. His replies to questions are to him either answers to his own thoughts or sometimes, a case very rare, he seems to converse with some imaginary person within his hypnoidic state. No direct suggestions are taken by the hypnoidic personality. The personality is fully rational in relation to the environment in which it lives. Thus, in one of his hypnoidic states, Reverend Thomas C. Hanna lived through a terrible accident that happened to him once. 84 Diagnosis of psychopathic diseases. He was on Mount Jewett, Pa. The wind blew high. Lightning rent the sky. Thunder crashed overhead. The gale gained strength and became a tempest. Broken branches and trees were falling on all sides. There is an old woman with a child, one, he exclaimed. Oh, it is terrible, one, it is terrible, he moaned. We must run, we must run. I must drag the woman. Thunder, one, it is terrible. Save the woman. I am so cold. My heart is so weak. Oh, it is terrible. We must run. We must run. To my question whether he knew Miss C, the answer of the hypnoidic personality was highly interesting and instructive. Don't know her yet, acquainted with her a year later. From Mount Jewett to her is a year. This was found to be correct. When I suggested to him that his friend S was with him, he laughed me to scorn. That is impossible, he exclaimed, S is many miles away from here. I asked for the date. He gave the date in which the event took place. It is August now, he said. When I insisted that it was May, the actual time when the vision occurred, the hypnoidic personality became impatient, raised its hand, struck the bed with great force, and exclaimed, I am sure it is now August. You cannot make me crazy. All that time the patient was sitting up in his bed, with his eyes firmly shut, blind and deaf to all impressions that had no relation to the vision. By indirect leading questions this particular personality gradually dwindled away, and lo! A new personality appeared on the scene, a boy personality. The Reverend Thomas C. Hanna became a boy of 13. The scenery changed completely. He was on the hypnoidic state 85 Umbrella Island. It was sunset, it was beautiful. He was expected for supper, but he was on the water, rowing and fishing. On awakening from his hypnoidic state, the patient remembered the vision very clearly, he could reproduce it, as if it were indelibly impressed on his mind. He could not recognize the experiences of his vision as events that had taken place in his past life, He did not know that I or anyone else conversed with him and led him to give answers, nor did he remember any of the many statements to my indirect questioning he had made in his hypnoidic state. He could not remember the answers he gave me to the suggestion that his friend S was with him. He did not know anything of the quarrel we had about the date, nor did he remember anything of the interesting information he gave me about the events of his life, such as the date of his acquaintance with Miss C. He could only remember, and that with extraordinary clearness and distinctness, everything that directly related to the vision itself. Similarly in other cases, such as that of R, M and F, states closely analogous were studied by me. They all manifested alternating, unstable personalities of a hypnoidic type. When left to itself, the hypnoidic personality tends to disappear, to fall back into the undifferentiated mass of consciousness of the subconscious self, for the hypnoidic personality is unstable in its nature. Unstable, however, as the hypnoidic personality is, it is in closer contact with the subconscious life than is the waking self. The hypnoidic personality is in possession of facts, experiences, memories, of which the upper, central consciousness is ignorant. 86. Diagnosis of psychopathic diseases. The following table gives the essential characteristics of the various states, hypnoidal states. 1. They can be artificially induced by the method of hypnoidization. The upper consciousness takes direct cognizance of the hypnoidal states in the moment of their appearance. A prolongation of them tends to the disappearance of the waking consciousness. 2. Hypnoidic states. States. Hypnoid 1. Hypnotic states are 1. They can be artificially falsely induced in induced. They are trance states or usually spontan, may arise spontaneously. Hypnoidic states are not directly cognized by the upper consciousness, the latter is always absent when the hypnoidic states are present. Hypnoid states may or may not be cognizant by what we call the normal consciousness. These states are always usually co-conscious, and are present alongside the upper normal consciousness for which they are independent. 3. The experience of hypnoidal states is vague, shadowy and fluctuating. The experience of the hypnoidic state is very vivid. The experiences are usually vivid. 4. Hypnoidal states possess mere bits, chips of past experiences. 4. Hypnoidic states form complete systems of experiences, whole personalities. 4. Hypnoid states may be parts of former mental states, but soon tend to independent mental content. 5. Hypnoidal states are normal, vestiges of a primitive rest state. Hypnoidic states are hallucinatory, dominant, subconsciously formed personalities of the alternating type. 5. Hypnoid states are often hallucinatory, and when fully developed become parasitic subconscious or co-conscious personalities. Hypnoidic states are of a nature entirely different from the hypnoid and hypnoidal states, which are the hypnoidic state 87 fragmentary, sudden intrusions of isolated subconscious moments consciousness into the upper regions of the waking personality, and can be induced by post-hypnotic suggestion, as well as by methods of hypnoidization. Like the hypnoid and hypnoidal, the hypnoidic states have as their nuclei, past, long outlived experiences, but, unlike the hypnoid and hypnoidal states, they are not fragmentary, dissociated, mental dust. The hypnoidic states are systematized, hallucinatory, resurrected, subconscious personalities. In all states, hypnoid, hypnoidic and hypnoidal, we find, however, one common trait, and that is the emergence of memories or of mental systems that may be known and recalled, whether directly or indirectly, by the primary self. Chapter X. Hypnolepsy. In cases of double and multiple personality of alternating type, a state of hypnolepsy is present. In all cases of mental alternation, one state does not between the two directly merge into the other. There is a state of unconsciousness or of deep sleep, however short it may be. The two alternating functioning systems are separated by an interval of apparent unconsciousness or of deep sleep. At first the interval is long, extending over a period of many minutes, or even hours, but gradually, with the repetition of the alternation, this interval becomes shorter and shorter, and is finally reduced to but a few seconds. In the first cycles of double and multiple personality, none of the personalities are well organized. Each of the leading personalities can maintain itself above the threshold of self-consciousness for but a short time only. With the disintegration of the latter, another personality begins to rise, reaches the threshold of self-consciousness and begins to function. The personality not being well organized, the process of formation and rise requires a considerable time. As the cycles of alternation more and more repeated, the alternating personalities become well organized, and the time between the submergence of one and the emergence of the other becomes considerably reduced. Still, the process must occupy some fraction of time, however short. Hence the intermediary state of deep sleep, the state of unconsciousness. In 88 hypnolepsy 89, passing from one state to the other, the deep sleep must be present. This is the hypnoleptic state. I must add that the hypnoleptic state is, as a rule, not found in artificially produced hypnoidic states. No gap, no state of unconsciousness separates hypnoidic or coexistent personalities cultivated by a long series of experimental suggestion. We may say that hypnolepsy is pathognomonic of actual, spontaneous hypnoidic states. The hypnoleptic state is a true attack. It sets in with a state of irresistible drowsiness, the patient still having consciousness of his environment. Stimuli which must become more and more intense as the state of drowsiness deepens, reach the subsiding, disintegrating personality and revive it, bringing it again into momentary activity. The patient can be aroused for a brief space of time, for a second or a fraction of it, and soon falls back into a drowsy condition. As the drowsiness deepens, the patient's reactions to external stimulations become gradually weaker. Finally, a point is reached beyond which no stimuli, however intense, can possibly arouse the patient. He is in an unconscious state. The hypnoleptic state can therefore be divided into two stages. One may be characterized as the first stage or the stage of drowsiness. The state that follows is the second stage, the stage of unconsciousness. The state of drowsiness or the first of the hypnoleptic state is of the utmost importance for theoretical, experimental as well as for practical therapeutic purposes. It is in this stage that the true crisis of alternation begins. One personality is slowly subsiding while another personality is being formed and is slowly rising to its dominant position in consciousness. The hypnoleptic state was well manifested in the 90 diagnosis of psychopathic diseases Hannah case, a true case of multiple personality, not brought about by suggestion or by hypnosis. To quote from the account, Mr. Hannah was now overcome by an uncontrollable desire to sleep. His eyelids began to close. He was urged to keep them open, but each time they began to drop in spite of his efforts. Attempts were made to arouse him by various stimulations. His limbs were moved violently, cold water was dashed in his face, he was pinched and otherwise stimulated. The onset of the somnolent state was irresistible. The lids finally closed, he could not open them. He fell into a state of unconsciousness. Every effort to keep him awake was futile. Even the mechanical opening of his lids did not bring any response, remained immovable. This is the hypnoleptic state. In this hypnoleptic state Mr. Hannah was physically prostrate. He was like one dazed by a hard blow, who lapsed into unconsciousness. His muscular system was passive. The conjunctival reflex was absent. There was general anesthesia to all forms of sensations. The hypnoleptic state is an attack of sudden onset. It may be divided, as we have pointed out, into two periods. The first is that of a rapidly increasing condition of extreme fatigue and an overwhelming feeling of drowsiness, culminating in a second period, that of unconsciousness. The state of hypnolepsy is observed in all true cases of double and multiple personality. The law of monocyclical or polycyclical bimorphosis and polymorphosis is, all mental alternations have an intermediate state of drowsiness and unconsciousness, a state of hypnolepsy. Hypnolepsy 91. The state of hypnolepsy occurs in the transition from the primary to the secondary, or newly formed personality. The transition from the secondary to the primary personality occurs in ordinary sleep. The order of the cycle is: primary state, hypnolepsy; secondary state, sleep; primary, hypnolepsy; secondary state, sleep; primary, and so on. In other words, the passage from the secondary to the primary is through the ordinary sleep state, no unconsciousness being present, while the transition from the primary to the secondary is through drowsiness and unconsciousness, through the state of hypnolepsy. The transition from the primary to the secondary comes on like a sudden attack. The patient may be lively, in excellent spirits; he suddenly becomes drowsy and lapses rapidly into a state of unconsciousness. When he comes to, he is in the secondary state. Nothing of the kind is observed in the transition from the secondary to the primary state. If the patient could be kept from going to sleep, he could be kept indefinitely in the secondary state. This, however, is not the case with the primary state. The primary state is more unstable. After a few hours the hypnoleptic attack comes on with a consequent transformation of personality. Why is it that while the transition from the secondary to the primary state is through the condition of ordinary sleep, taking place usually at night, the contrary is case in the transition from the primary to the secondary? In other words, why should the transition between the primary and the secondary state take place through an attack through a hypnoleptic state? The answer is, because the sleeping state represents the absence of any dominant moment of self-consciousness. 92. Diagnosis of psychopathic diseases: the absence of any personality. That is just what takes place in the interval of alternating states. But what is the hypnoleptic state? The hypnoleptic state is the reproduction of original attack which brought about the state of double or multiple personality. This was clearly revealed in the Hannah case. What happened in that case was that the patient met with an accident, lost his consciousness, his personality became disintegrated and could not be reinstated, a new personality with new content entered into being, a secondary state, a secondary personality became gradually formed and trained. The original order then was, I, the primary state, representing the patient's whole previous life; 2, the state of unconsciousness due to the accident; 3, the formed and trained secondary state or secondary personality. The succession of the states formed a cycle of the original series, a cycle that went on repeating itself by association of contiguity in the same order. It is the law of recurrence which dominates all life. We can now understand why the hypnoleptic state is of the nature of an attack. Hypnolepsy is a reproduced attack. We can also understand why the order invariably follows a uniform course: primary state, hypnolepsy; secondary state, never the reverse. Such is the original order of events which recurs like the rising and setting of the sun. The phenomena of double and multiple personality have a definite course of their own. Newly formed personalities pass through well-defined cycles, and like new worlds formed by some external or internal catastrophe, they keep on revolving within the same orbits. They follow the same order as the phases of the moon. Hypnolepsy 93. The order is persistent, reflex, automatic, and recurrent. Further on in reviewing psychopathic states we shall bring out this important recurrent aspect of all subconscious states. Part Psychopathic 2 Diseases Chapter The Classification 11 of Nervous Diseases and Mental. And in reviewing the different forms of nervous mental diseases we may classify them into organic. By organic affections we mean and functional. Pathological modifications of the nerve cell and its processes taking place in the very structure of the cell. The modifications are of a degenerative character, end under this categorying in the death of the neuron. Come such diseases as general paresis, dementia praecox, and mental affections of a degenerative structural character. Such diseases may be termed organopathies or necropathies. The functional affections may in turn be divided into neuropathies and psychopathies. There are mental maladies in which the neuron undergoes degenerative changes which at first bring about an apparent increase and then a suspension of function, not necessarily terminating in the destruction of the neuron. The neuron recovers either temporarily or permanently. Such affections are produced by poisons, alcohol, morphine, chloral hydrate, cannabis indica, and other toxic agencies. To this category also belong all mental affections caused by toxic products formed in the organism and slowly and imperfectly eliminated from the body. Here belong all the temporary maniacal, melancholic, and delusional states, such as puerperal mania, epileptic insanity, the insanity of the adolescent and climacteric periods, as well as that of folie circulaire. 97-98 Diagnosis of psychopathic diseases: periodic insanity, alternating insanity, and, in general, all the mental states known at present under the description of manic-depressive insanity. All such neuron affections may be termed neuropathies. Where the affection depends not so much on the neuron itself, but on the association of neurons, the disease may be described as a psychopathy. In this form of mental affection the neuron itself may remain healthy, the trouble being due to associations with systems of neurons which are usually not called into action by the function of that particular neuron or system of neurons. Such conditions are well known in physiology. Thus in the experiments of Pavlov and his school the flow of saliva in the dog could be brought about by association with a blue light or with a whistle or with the ring of a bell. What holds true in the case of saliva holds true, for instance, in the case of nausea and vomiting. Stimuli which are ordinarily indifferent may, by association, bring about such conditions. The fault does not lie here in the stimulus, or in the sensation, or in perception, but in the association with reactions of neuron systems with which that stimulus and its percept have become associated. In other words, the fault is of a purely associative character. Ordinarily only food or gustatory sensations and perceptions of food can call out the flow of saliva or induce nausea and vomiting. Colored light cannot do it. Under special condition of association, however, colored light may call forth the reactions of flow of saliva or of nausea and vomiting, instance the experiments carried on by Pavlov and his pupils. Emotions are specially subject to such associations of classification of nervous and mental diseases. 99 What may be regarded as morbid or pathological in character. Emotions with their physiological effects may be linked by the process of association with any ideas, percepts, and sensations. Sometimes the physiological effects of emotions, or in fact any physiological effects, may be linked by special associative processes with ideas, percepts, and sensations which ordinarily are either indifferent in character to give rise to reactions and physiological effects of a different and even opposite type. Milk may excite nausea, a rose induce disgust, while the croak of a frog or the cawing of a crow may bring about ecstasy. Limburger cheese and overripened game may be enjoyed with intense delight. What association of sense and reaction made the Greeks regard the grasshopper as highly musical? The reactions of muscle and gland are like so many bells which by various connections and combinations may be made to ring from any sensory button. An object, however harmless, may awaken intense fear while a dangerous object may be passed by with indifference. A man may be afraid of pointed sticks for instance and handle carelessly a revolver. The emotion of fear is associated with the one object, but is dissociated from the other. It is such associations and dissociations that give rise to the mental diseases of a psychopathic character. This holds true not only of man, but also of the psychic life of the lower animals. My horse is not afraid of automobiles, regards with suspicion camels, and is somewhat startled at the sight of an elephant, yet passes them by, but he gets scared at a piece of paper. Psychopathies, then, may be regarded as essentially pathological affections of associative life. Mental diseases IOO diagnosis of psychopathic diseases may thus provisionally and roughly be classified into organopathies, neuropathies, and psychopathies. If the psychomotor manifestations of the pathological process of neuron disaggregation and neuron degeneration be formed into a series, then the first stages of that series of that process constitute the phenomena of functional psychosis or of psychopathy. The stages are concomitant with the pathological conditions in which only the associations, the interrelations of neuron systems, are affected by dissociations. The neurons, the dissociated aggregates, themselves remain unaffected. The whole domain of the subconscious belongs to these stages of disaggregation in the course of the pathological process, e.g., the phenomena of hypnosis, of somnambulism, of motor and sensory automatism, of the so-called hysterical sensory motor disturbances of various organs, over the functions of which the personal consciousness is found on examination to have lost control by reason of neuron disaggregation and dissociation. Here belong the phenomena of double and multiple personality, the various phenomena of amnesia, the lost content of which can be revealed in the strata of subconscious life. The domain of functional psychosis or of psychopathy also includes the phenomena of the different forms of so-called psychic epilepsy. Here also belongs the great class of psychomotor derangements, such as phobias, impulsions, obsessions, fixed ideas, and allied states. The phenomena of functional psychosis are coextensive with the whole domain of the subconscious. Functional psychic disturbances, or psychopathies, are correlated not with organic, structural neuron degenerate classification of nervous and mental diseases 101, but with disaggregation of functioning systems or of neuron aggregates. 7. The physiological cause is the rise of thresholds of the intercommunicating neuron systems. In psychopathic affections, the function apparently lost and destroyed is found to be present in the subconscious. The loss of function is only for the direct personal consciousness. The affection is only of a dissociative character. The activity of the affected system is itself sound, in fact, is often found to be exaggerated. The system is only dissociated from other functioning systems. The total energy of the neuron may be classified into dynamic energy, reserve energy, static energy, and organic energy. Neurons XRA eneg. And its stohomotos lower levels of static energy. Neuron degeneration and regeneration. Processes of cytolymph integration and disintegration. Or are upper levels static dynamic energy. J and L processes aggregation RE and TITHLPIO 0 tilde asterisk pound 0 SOI yuan $2 I and G and caret manifestations and caret aggregation. BNES 0 I.JJ GG J JJ GT 0 TAL enig YISJHI caret 0 FNEU at 0 N caret pound I dash caret G caret, y, j, j, caret, comma, caret, inibine, k pot shaluaku, comma. Dalven btj roth, ath il, 8. PHOPATHs. Hawkal PHT 81 Olupatholds J, *apathi *. P to phenomena of neuron, phenomena of association and JORE delta of neuron or of degeneration and regeneration. Dissociation of P low system * or symptoms of neurons. Momenta of consciousness * oconic. FUNCTIOKAL. IO2 Diagnosis of psychopathic diseases. The psychopathies, neuropathies, and organopathies or necropathies may be correlated with the flow and ebb of neuron energy, with the physiological and pathological processes that take place in the neuron in the course of its activity. This may be represented by the diagram on page 101. By dynamic energy of the neuron is meant that part of energy which the neuron as an individual organism can dispose of in its relations to other neurons forming complex functioning organizations. The dynamic energy is represented by the upper portion of the parallelogram AMLK. By reserve energy is meant that surplus amount of dynamic energy which is kept in reserve and drawn upon by the organism under special conditions and emergencies. Reserve energy is indicated by the diagram KNWA. By static energy is designated that portion of energy that is used only for the life maintenance of the neuron, both in relation to other neurons and to its own inner molecular constitution. Static energy cannot be drawn upon by the neuron in its functioning activity with other neurons without bringing about a state of disintegration. Static energy is indicated by the diagram NWFI. By organic energy is meant that energy contained in the very structure of the tissues of the neuron, not as yet decomposed into their inorganic constituents. This is indicated by diagram IFGH. These phases of neuron energy are not different kinds of energy, in the sense of being distinct entities. They merely represent progressive phases or stages of the same process of neuron activity. Classification of nervous and mental diseases. 103 Liberation of neuron energy is correlative with active psychic and physical manifestations. Hence states of the nervous system corresponding to liberations of energy are designated as waking states. Restitution of expended energy or arrest of liberation of neuron energy goes hand in hand with passive conditions of the nervous system, hence states of restitution or arrest of energy are termed collectively sleeping states. In the diagram this correlation is followed out in the direction of the arrows. The arrow, indicating successive levels of liberation of energy, corresponds to a similar arrow which indicates the course and progress of the waking states running parallel to the process of liberation of energy. The arrows at the top of the diagram illustrate the physiological and pathological processes at work in the cycles of expenditure and restitution of energy, while the bottom of the diagram indicates by its arrows the concomitant psychomotor manifestations, the waking and sleeping states. The ascending arrow, indicating the process of restitution euphagy, corresponds to the ascending arrow indicating the parallel psychomotor sleeping states. The descending arrows indicate physiological and pathological processes of liberation of energy, and also their concomitant psychomotor waking states. Ascending and descending mean the rise and fall of the amount of neuron energy, taking the upper level of dynamic energy as the starting point. Briefly stated, descent means liberation of energy with its concomitant psychomotor waking states. Ascent means restitution of energy with its parallel sleeping states. The cycles in dynamic energy correspond to the physiological manifestations of the nervous system in the IO4 diagnosis of psychopathic diseases, activity and rest of the individual in normal daily life. Concomitant with the expenditure of dynamic energy of the neurons, the individual passes through the active normal waking state, and, Hand in hand with the restitution of this expended dynamic energy, he passes through the sleeping state of normal daily life. When, however, in the expenditure of energy, the borderline or margin, AK or NW, is crossed, dynamic and reserve energies are used up, and reserve and static energy are drawn upon. In crossing AK or NW, the borderline that separates the normal physiological from the abnormal or pathological psychomotor manifestations is stepped over. The thresholds of our psychological systems are usually raised, mental activity working in the course of its development and growth of associative processes under ever-increasing inhibitions with ever higher thresholds. On account of the high thresholds and inhibitions, not the whole amount of the psychophysiological energy possessed by the system is manifested, in fact, but a very small portion is displayed in response to stimuli coming from the habitual environment. What becomes of the rest of the unused energy? It is stored, reserve energy. Biologically regarded, we can well see the importance of such stored or reserve energy. In the struggle for existence, the organism whose energies are economically used and well guarded against waste will meet with better success in the process of survival of the fittest, or will have better chances in the process of natural selection. The high thresholds and inhibitions will prevent hasty and harmful reactions, useless waste of energy, unnecessary fatigue, and states of helpless classification of nervous and mental diseases 105 Horstchen. Moreover, natural selection will favor organisms with greater stores of reserve energy, which could be put forth under critical conditions of life. In fact, the higher the organization of the individual, the more varied and complex the external environment, the more valuable and even indispensable will such a store of reserve energy prove to be. Static energy may be divided into two phases according to the nature of the process of liberation of neuron energy. As long as the process of liberation of energy affects only a dissociation of systems of neurons, the correlative psychomotor manifestations fall under the category of psychopathies. If, however, the process of liberation affects the neuron itself, bringing about a disintegration of its constituent parts compatible with restitution, the correlative psychomotor manifestations fall under the category of neuropathies. This process of disintegration, equivalent to cell degeneration, may end in death, in the dissolution of the neuron itself. By psychopathies, then, is designated the pathological phenomena of psychic disaggregation correlative with the state or processes of dissociation within clusters or constellations of neurons, the neuron itself remaining undamaged. By neuropathies is indicated a group of psychophysical manifestations running parallel to fluctuations of static energy and accompanied by functional and organic changes in the neuron. By organopathies or necropathies is indicated a group of psychophysical manifestations running parallel with fluctuations of organic energies and accompanied by structural changes or by necrotic modifications resulting in the ultimate death of the neuron system. 106 Diagnosis of psychopathic diseases. The usual classification of mental functions is into intellect, feeling, and will. By intellect is understood such functions as perception, conception, memory, abstraction, imagination and judgment. Under feeling are ranged sensations, pleasures, pains, moods, affective states and emotions. By will is meant all the functions leading towards action, our conations, desires, strivings, tendencies, and decisions. If we accept this psychological classification, we may accordingly classify mental diseases. From our standpoint, we need not go into the details of psychological classification. What we wish is to classify the nervous and mental derangements that fall into the domain of psychopathology. We may take the physiological reflex arc as our basis of classification, namely the passage of a nerve current from a sense organ through a sensory nerve to an intermediary central neuron or ganglion, and thence through a motor nerve to muscle, we can conveniently classify all psychophysiological functions into sensory, intermediary or ideational, and motor. Biologically, this classification is well justified inasmuch as by means of the sensory function the animal receives impressions from the external environment, elaborates them in the center, and then reacts by motor adjustments and adaptations. Psychopathic states are classified into sensory disturbances of sense organs and viscera, the various forms of anesthesia, motor disturbances, and finally derangements of ideas, memory, will, and emotion. We give here a brief clinical description of various forms of psychopathic states in the ascending scale of their development, complexity, and organization, beginning with sense disturbances known as the anesthesias. Classification of nervous and mental diseases 107. According to the symptoms we may divide psychopathic maladies into I. Peripheral, 2. Peripherocentral, 3. Central. Under the peripheral may be classed the following: 1. Sensory disturbances, the anesthesias. 2. Motor disturbances, derangements of motor adjustments and epileptoid attacks. 3. Visceral disturbances, glandular affections, secretory, respiratory, cardiac, intestinal and sexual derangements. Under peripherocentral we may class 1. Illusions, 2. Hallucinations, pseudo-hallucinations, the dream hallucination, hypnotic hallucination, the aphasias. Under central disturbances we may class I. Delusions, the various forms of amnesia, aboulia, fixed ideas, morbid impulses, emotions, and morbid propensities. We shall follow this order in our account of the various psychopathic maladies. Chapter Sensory 12 Disturbances. Anesthesia is generally understood a loss of sensation in the epidermic layers of any of the sense organs, and specially a loss of sensation in the skin. The anesthesias may, with Janet, be classified as follows: by anesthesia, local, disseminated, special, general, total, systematized. Paresthesia, hypoesthesia, hyperesthesia. By local anesthesia is meant a loss of sensitivity in some one part of the body. The usual stimuli applied to the affected part do not give rise to their appreciation in consciousness. One or more of the qualities of sensibility may be lost. The anesthesia is frequently on the left side. It is sometimes confined to limited spots, sometimes to a part or to an entire extremity, or symmetrical portions of two extremities may be involved as in glove and stocking anesthesia. It may again extend to one half of the entire body, constituting hemi-anesthesia. 108 Sensory disturbances. 109 The face may be involved, often on one side, and along with it the eyes may be affected. Anesthesia of one side of the face and appropriate side of the body may occur. When the eye is involved, not only the retina, but also the lids are anesthetic. The eye muscles may also be affected. Of all forms of sensation, pain and the tactile sense are most frequently lost. Muscular sense and articular sensibility are rarely affected. In severe cases the loss of sensibility includes the deeper parts and is more or less complete to all, even to intense stimuli, while in mild cases, strong continuous stimuli are felt. The anesthesia may include parts of the mucous membranes. The abdominal viscera may be analgesic, strong compression giving rise to no pain. Disseminated anesthesia is like the local form, except that it is distributed over the body in patches. It may be in geometrical patches or in segments. The anesthetic areas sometimes take the form of bands. Special anesthesia I, a form in which the special senses are involved. Special anesthesia may be either visual, auditory, gustatory, olfactory, or thermal. The most frequent form of special anesthesia is that of limitation of the field of vision, usually of a concentric form. The loss of vision may be total, but this is a rare form. Visual acuity usually remains unaffected. There are not infrequently color disturbances, achromatopsia, in which all colors are seen as gray. Another far more common variety is that in which the reversal of the color field is present. In the normal eye, the largest field is for white light, blue, red and green come next in order, violet having the smallest field. The most frequent reversal in psychopathic vis no diagnosis of psychopathic diseases usual anesthesia is between red and blue, the red preceding the blue, and showing a larger field. Psychopathic deafness is less common than the other forms of special sense anesthesia. In most of the cases there is also anesthesia of the external auditory meatus and of the outer surface of the drum. The deafness is rather for notes of high pitch. The tendency to involvement of the various special senses is according to the law of adaptation, reproduction or recurrence. The senses involved in the trauma show the recurrence of anesthesia. The auditory is more essential than the visual in carrying on social relations, and is therefore less frequently affected. Taste, smell, and muscular sensibility, which are still more important in carrying on life activity, are more rarely involved. In the form of special anesthesia, one or both sides may be involved. In general anesthesia, all forms of sensibility of skin and mucous membrane are involved. This general anesthesia may be localized, in patches, or in bands. It may cover the entire body or half of it. When the anesthesia appears in the form of patches or as hemi-anesthesia, touching or pricking two symmetrical parts, the one normal the other anesthetic, presents interesting phenomena. The normal side may become red from the stimulus, while the anesthetic part remains relatively unaffected. Occasionally anomalies of sweat secretion, such as increase or decrease of perspiration, are present. There is no difference in temperature or circulation or general nutrition of two sides. The anesthetic part usually retains its reflexes. When the lower leg is involved, the patellar reflex may be increased, but often it sensory disturbances remains unchanged. The anesthesia may be total, it may affect the entire body, involving also the mucous membranes. The anesthesia may be for all qualities of skin sensation, such as touch, pressure, pain, heat and cold, and may also involve completely or partially the special sensory organs. This form of anesthesia is rare. In total anesthesia, the more frequent form is the loss of sensibility of skin and mucous membrane. The muscular sense is usually preserved, though in some cases it may be slightly diminished. In total anesthesia, the patellar reflex, the abdominal reflex, the secretory and vasomotor reflexes are present. Systematized anesthesia consists in the loss of sensibility in relation to definite systems of impressions, coming from certain external objects. That is, while the patient is anesthetic to certain objects, he is not anesthetic to other objects, though of the same nature. This form of anesthesia may affect any of the senses, and is specially characteristic of the psychopathic state. The tendency to dissociation or anesthesia is in inverse ratio of its biological and social adaptations. Systematized anesthesia becomes greater with emotional excitement and with increase of the intensity of attention. The pathological process here, as in other psychopathies, consists in a disaggregation of mental systems, either as its parallel in those forms of aphasia in which certain kinds of words only are forgotten, while others are retained. Along with the anesthetic or hypoesthetic disturbances, we sometimes find hyperesthetic spots in which the sensitivity is abnormally great. On account of the H2 diagnosis of psychopathic diseases general process of disaggregation, the touching, or pricking of certain spots gives rise only to indefinite feelings. The patient indistinctly or vaguely feels the stimulus. In some patients with psychopathic disturbances, touching, pricking, or sending even a strong electric current through a limb, a hand for example, is only vaguely felt and localized. This phenomenon is known as allochiria. If the hypersensitiveness is very acute, the patient may localize the impression in a symmetrical place on the opposite extremity. This may be termed complex allochiria. In psychopathic hyperalgesia, while the slightest touch may give rise to pain, often a firm pressure is not painful. The mucous membranes may be the seat of the hypersensibility, giving rise to pain during swallowing, urination, defecation, etc. Hyperesthesia of the special sense organs may occasion disturbances of vision, smell, hearing, or taste. A common form of psychopathic paresthesia is that of a boring pain at the vertex of the skull, as though a dull instrument were being driven into the head. This form of pain is sometimes termed clavus hystericus. There may be hyperesthesia or more commonly anesthesia of the genital organs. The breasts may often be the seat of paresthesia. In some cases the paresthetic member feels to the patients, as if amputated or belonging to some other individual. There may also be anesthesia relating to hunger, thirst, and micturition. When there is anesthesia relating to hunger and thirst, the patient may go on for some time without food, or take but little nourishment as the desire for food is diminished. When their sensory disturbances 113 is anesthesia of the bladder and urethra and also of the skin and muscles, there may be incontinence of urine. The anesthesia of the bladder may give rise to retention of the urine. Sensations of crawling, numbness, feeling as though snakes crawled beneath the skin are among the other forms of anesthesia. Disseminated or small islands of hyperesthetic or paresthetic spots are often found in psychopathic cases and may occur alongside of the anesthetic ones. In psychopathic cases in which anesthesia is present, there is almost invariably present some form of motor disturbance or paroxysm, occurring at irregular intervals. The anesthesia always becomes more pronounced after the attack, which may be considered as a form of hypnoleptic state. There are often pains in different parts of the body, especially about the breast, ovaries, and spine. Pressure upon these spots may provoke a so-called hysterical attack or sometimes stop it. Such zones are termed hysterogenitic. Pains of psychopathic nature in the vagina or in the breast have sometimes led to diagnosis of organic disease and consequent operations. // must always be remembered that psychopathic sensory disturbances are psychic in character. They are disturbances of patients' subconscious life activity. Chapter motor, visceral, and 13 circulatory disturbances. Long in this form of psychomotor disturbances time is required to execute voluntary movements. This is shown by the fact that the reaction time is greater for the affected than the unaffected extremity. The difference may amount to 1 in the simple reaction time of the fifth of a second. Affected extremity, it may rise to 2 seconds and some, usually the times, though rarely, to 20 seconds. Affected extremity is hypoesthetic or anesthetic, and the reaction time is more or less in proportion to the anesthesia, or to the depth of the process of disaggregation. When voluntary movements are executed, this may be carried out hesitatingly. Is as a kind of psychopathic ataxia. The kinesthetic memory of processes is present, while the kinesthetic sensations are lost, that is, the central process of kinesthesia is preserved, while the peripheral is lost. Hence we often find the following phenomenon: the patient with his eyes closed is told to raise his hand, he tries to do so. If now the hand is seized and held down, the patient still exerting force and endeavoring to raise it, finally believes that the hand is fully raised. The voluntary movements become simplified or rather weakened in their range. Only simple movements can be executed, while the more complex are affected. 114 The latter are carried out with effort, in a slow, uncertain way. Simultaneous movements interfere with motor, visceral, and circulatory disturbances 115 each other. If, for example, the patient is asked to close his hand, and at the same time to perform another movement, such for instance as raising the eyebrows, the one movement stops the other, they cannot be performed simultaneously. The voluntary movements become weakened in intensity. The movements and muscular power are less than one would expect from the general health and appearance of the patient. This condition is sometimes characterized as amyasthenia. Thus, for instance, it is sometimes surprising to find in one or both of the upper extremities affected, that the dynamometric force is unduly diminished. In some cases it may fall to 9 or even 5 units. In such cases the muscular weakness is both for active and passive movement. The patient is deficient not only in pressing or squeezing or in the performance of similar acts, but he likewise lacks the power of active resistance. Amyasthenia is as a rule greater when the attention of the patient is diverted. Sometimes when the patient is asked to press the dynamometer with eyes closed, he does not press at all, it may register 0. The pressure increases when the patient is directed to concentrate his power of attention and will upon the effort. During all this time while the patient is unable to press upon the dynamometer, he may still in some other habitual exertions show great muscular power. We may call this form systematized amyasthenia. The general law of amyasthenia is that the disturbance proceeds from the complex to the simple and from the less useful to the more useful, and the more habitual functions, from the functions more associated with traumatic disturbances to functions with fewer traumatic. N6 Diagnosis of Psychopathic Diseases Associations. The weakening of voluntary movements in psychopathy is especially pronounced in rapid repetition of the same movements, so that sometimes the patient may after a few endeavors be quite incapable of performing the movement. Tested, however, by other psychopathic methods, it is found that although the patient cannot perform these movements, he is still able to carry them out in a subconscious state. Psychopathic motor disturbances, like sensory troubles, are essentially morbid modifications of the subconscious. The general symptoms of psychomotor disturbances in psychopathic diseases have been formulated as follows. The patient's movements on the anesthetic side are largely guided by the sense of sight. If the patient does not see the anesthetic member, the movement is performed subconsciously. 2. In some cases when movements are apparently impossible without the sense of sight, if the eyes are closed in the middle of the movement, the process of movement may be continued. 3. In some cases, when without the knowledge of the patient, the anesthetic member is raised, it becomes cataleptic. 4. Movements can be induced in the patient without the help of sight, if the movements are brought about subconsciously. Among other phenomena observed in psychopathic motor disturbances are synkinesia, allokinesia, and heterokinesia. Synkinesia is the performance of associated motor, visceral, and circulatory disturbances 117 ments. If the patient's limb is anesthetic in the left upper extremity, for instance, he is able to raise either the right or left hand with his eyes open, and the right hand even with closed eyes. If, however, he is asked to raise the left hand alone, the eyes being closed, he raises both hands. When the patient is told to execute certain movements with the left anesthetic hand, he makes synchronic, symmetrical movements with the right hand. The patient is able to move his right hand alone, but cannot move the left alone, without synchronous symmetrical movement of the right hand. The phenomena of alokinesia are parallel to those of alochiria. In alokinesia the patient is unable to localize well his peripheral kinesthetic sensations. If, for instance, the patient is asked to raise the right hand, he raises the left instead and is not aware of the difference. In this way the patient's anesthesia or any form of motor disturbance may be transferred from one side to the other. The phenomenon of transfer is often due to this form of experiment. The phenomenon of heterokinesia is rare. It consists in the performance of opposite movements. When the patient, for instance, is told to close his hand, he opens it, or when he wants to bend the arm, he straightens it. Psychopathic tremor is usually hemiplegic or monoplegic, that is, the tremor may occur on one side of the body, or it may be confined to one limb. The tremor, as in that of epilepsy, is usually present in the intervals between paroxysmal states. If, for example, the tremor is in the upper limb, and the patient is asked to extend the limb and keep it in a certain position, a tremor of rather slight range, of about 8 or 10 oscillations per 118 diagnosis of psychopathic diseases second is observed. There are two types of psychopathic tremor. The one form is present during repose and is only slightly affected by voluntary movement, while the other form may not be present during repose, but is greatly increased by voluntary movement. The tremor of the first type resembles that of exophthalmic goiter, while the second form is more like that of disseminated sclerosis. Emotional excitement increases both forms. The nature of psychopathic tremor, like that of other psychopathic conditions, is some subconscious state. The duration of the tremors varies from a period of a few weeks to that of months or years. The tremor ceases during a psychopathic crisis, also called hysterical attack, but becomes exaggerated shortly after, and may also become marked when pressure is exerted over the so-called hysterogenic zones. The tremor may occur in many parts of the body, head, neck or extremities, and is increased by fixation of attention. Local and general clonic spasms of small range may occur. The movements in such spasms may assume a form which may be termed psychopathic chorea. Sometimes the movements are sudden and shock-like in character, suggesting electrical chorea. This form is easily acquired by imitation, and in the Middle Ages has at times become epidemic. Rhythmical movements of more extensive range may occur. This condition may be termed psychopathic rhythmical chorea, or psychopathic chorea major. The movements are of wide range, deliberate, and complex. They are of regular sequence and consist of more or less alternate contractions of the muscles, especially motor, fissural, and circulatory disturbances. 119 The flexors and extensors of the trunk and extremities. The movements are oscillatory, of regular rhythm, and may last for weeks or months. They invariably cease during sleep. Different parts of the body may be involved. The tongue, the eyes or the jaw muscles may be affected. The rhythmical movement may extend to various members, sometimes involving the whole trunk. The tremor may be of such a character as to suggest a neuropathic condition. The movements are sometimes arrested by a strong emotion or by an anesthetic, such as ether, or by a hypnotic, such as morphine. The temporary arrest is succeeded by psychopathic paralysis or contracture. The convulsive attacks of psychopathic origin may be divided into minor and major seizures. The minor psychopathic convulsive attacks usually follow some deep emotional disturbance. During the attack the patient may make wild and purposeless gestures, or aimless movements, utter incoherent cries, go into uncontrollable fits of laughter or weeping, sometimes of an alternating character. The onset of the attack is usually preceded by a premonition consisting of spasmodic movements of the muscles of the throat, giving rise to a sensation of constriction or to a feeling as though a foreign body were in the throat. This phenomena is known as globus hystericus, so named because it was believed that the cause lay in the ascent of the uterus into the pharynx. Some muscular rigidity may be present. Rigidity or contraction of certain muscles may be premonitory of the attack. The movements in these convulsive attacks, unlike those of epilepsy, appear to be not altogether without I2O diagnosis of psychopathic diseases purpose. The patient may make an effort to seize a person or object, or to kick at something or destroy it. Efforts to restrain the patient forcibly meet with opposition and increase the violence of the attack. Frequently a characteristic tremor or quiver of the eyelids is observed when the patient closes the eyes. Pulse and respiration usually remain unaffected, although the breathing may become shallow. After a time, varying from a few minutes to several hours, the patient becomes calm, passive, and then depressed. Major motor attacks, sometimes characterized by the inappropriate term of hysteroepilepsy, consist of convulsive seizures of a violent and extensive nature of definite types and stages. Attacks passing through definite stages are of rare occurrence, and when present are found in cases that show during the interparoxysmal period some form of disaggregation, such as anesthesia, aboulia or some motor disturbance. The major motor attacks are hypnoidic in character, being reproductions of conditions that have induced the psychopathic state. The major attacks have prodromal symptoms, which appear several days before the paroxysm. These may consist of anesthesia, aboulia, aphasia, general nervousness, etc. During the paroxysm, the sensibility of the patient is changed. There may be hyperesthesia, or anesthesia, clavus, epigastric pains or uneasiness, etc. This prodromal stage suggests the aura of epilepsy, but is altogether different in its nature. In epilepsy, the symptoms are due to neuropathic derangements, the neuron itself being affected, while in the psychopathic attacks the symptoms are due to dissociation of neuron systems. Epileptic states are due to motor, visceral, and circulatory disturbances, 121 organic or neuropathic disturbances, while psychopathies are subconscious affections. The prodromal period is followed by the epileptoid stage, which may come on either suddenly or gradually. The face becomes pallid, the expression vacant, the eyes staring, and the patient falls to the ground. The fall is not so violent and precipitate as it is in epilepsy, the patient rarely sustaining injury. The reason of this is that consciousness is really not lost. The subconscious self remains active and controls the movements and acts of the patient. In the beginning or during the epileptoid stage a sound is emitted, or word, or phrase is pronounced. At the height of this stage the muscles become rigid and finally the entire body is affected by tonic muscular contraction. This condition may be succeeded by relaxation of the muscles. The patient is motionless and only a perceptible movement of the eyelids is evident. In some cases the relaxation does not occur. The next stage in the epileptoid condition may be followed by clonism, or the rare phenomenon of opisthotonose may be encountered. The body is arched and rests upon the back of the head and foot soles, the abdominal muscles become exceedingly rigid. Soon opisthotonose gives place to bounding movements of great violence. The patient then passes through various emotions characteristic of the subconscious state. Various attitudes and expressions are assumed corresponding to the prevailing emotion. The patient talks incoherently. The movements are generally of such nature as to form more or less coordinated systems. They are usually of a struggling, defending nature. The eyelids are usually closed, the conjunctiva. *122 Diagnosis of psychopathic diseases: flex is diminished and general bodily sensibility is decreased. A pin stuck far into the flesh does not give rise to any manifestations or reactions of pain. A spasmodic laryngeal convulsion may be present, giving rise to dyspnea. The patient may be unable to swallow for hours or even days. There may be severe gastric disturbance, pain and vomiting. Anorexia may be so persistent, owing to fear of vomiting, that patients may absolutely refuse food for some time. The attacks may occur at long intervals and sometimes in such a rapid succession as to give rise to a psychopathic status epilepticus. The various stages of the major attacks should be regarded as the emergence of a hypnoidic state, as the growth and development of an abortive subconscious personality. A hypnoidic state consists of emotional disturbances with a change of sensibility accompanied by motor disturbances. The emotion forming the nucleus of hypnoidic state is generally the manifestation of some event that had occurred in the patient's life, but which afterwards subsided within the subconscious, in a form more or less disaggregated from the patient's upper consciousness, and now recurring at each favorable opportunity. The hypnoidic state is the hallucination of an actual past event. The reason why the attacks recur is that the emotional state with its train of psychomotor manifestations easily is brought to the surface by the influence of certain stimuli, events and circumstances recalling the original trauma with all its consequences. These stimuli, acting on the patient, may modify his general sensibility. This modification of sensibility when associated with the hypnoidic state brings motor, visceral, and circulatory disturbances. 123 about a recurrence of that very state. If the patient is disposed to this hypnoidic state, that is, if there is a tendency to the arousal of those subconscious mental systems, the least stimulus that suggests any of the component associations that go to form the total complex system will bring about that particular synthesis of systems of sensibility that go with that particular hypnoidic state. The general law of psychology and especially of psychopathology is that a sensory state has motor and glandular accompaniments or reactions. As Pavlov and his pupils have shown, modifications of sensory impressions are associated with glandular secretions. The same holds true of ideas. Every idea has relations to motor reactions and glandular changes. A change therefore of sensibility with its accompanying changes in ideas and images will bring about a motor disturbance. This motor disturbance is of a nature characteristic of that hypnoidic state with which that particular modified sensibility is associated. If two states have been associated, the presence of the one will recall the other. Thus epileptoid states arise with their sensory motor disturbances and glandular changes. Sensory motor, visceral, and glandular disturbances give rise in their turn to a change in the emotions, because different emotions are made up of various peripheral and organic sensations, coming from different parts of the body. A change, therefore, in sensory motor activity gives rise to a profound modification of emotional life. It is clear that a profound disturbance of sensory motor, ideomotor life and glandular activities must be followed by emotions with their concomitant motor. 124 Diagnosis of psychopathic diseases. Pressions. The emotions develop a fully systematized hypnoidic state, recalling and reviving in a perceptual form all the circumstances that occurred at that time, the patient, being in a delusional state having hallucinations and illusions, considers himself in quite another environment. Thus in the psychopathic convulsive attacks the hypnoidic state is apparently passing in an inverse form through the various stages of its original occurrence. In reality all the manifestations and symptoms are guided and controlled by the awakening of the submerged, subconscious, emotional, hypnoidic state. Contracture is common in the psychopathies, but it is less frequent than anesthesia. Contracture may be caused by various stimuli, such as a blow, electric current, massage, etc., and often follows a convulsive seizure, or an intense overwhelming emotion. As a rule, contracture occurs suddenly, and when of gradual onset follows a myasthenia, paralysis, or convulsive attacks. The contracture may affect a bundle of muscle giving rise to a kind of tumor, or it may affect a number of muscles. /JA rule: the voluntary muscles are affected, but the involuntary muscles, such as those of the bowels, may be involved. Psychopathic motor disturbances may be of the monoplegic, the paraplegic, the hemiplegic, the crossed, the general, the periarticular, or the irregular type. In contracture of the upper extremity, the fingers are strongly closed upon the palm, the wrist and forearm flexed in the position of pronation or supination. When the lower limb is affected, the thigh and leg are strongly extended and the foot is in the equinovarus motor, visceral, and circulatory disturbances 125 position. The thigh is in a position of adduction, the entire limb is held in strong muscle contraction. Occasionally flexion instead of extension occurs. In the hemiplegic form, the arm is usually flexed and the leg extended. The left side is often more involved than the right. Both extremities may be involved, or the contracture may pass from one to the other. In the paraplegic type, both legs are extended and adducted. All four extremities may be involved. In the so-called periarticular variety, in which the muscles about the joint are involved, the several forms of talipes are simulated. Contractures of the muscles of the face may also occur. Generally the contracture is uniform while it continues, but sometimes it varies at irregular periods. It is as a rule greater when an attempt is made to overcome it, and the increase of resistance of the muscle in proportion to the effort made to overcome it is of great value in the determination of the psychopathic nature of the contracture. The contracture, unless of a mild degree, may persist during sleep, but disappears in hypnosis and deep anesthesia, induced by such drugs as alcohol, chloroform, and ether. In rare cases of very long-standing structural changes may occur. So-called hysterical trismus is due to contracture of the muscles of mastication. In this condition the jaws resist all efforts to operate the mouth. When the trismus follows a motor paroxysm, it generally persists until another paroxysm occurs. Contractures in the jaw depressors leading to opening of the mouth are very rare. Contraction of the abdominal muscles and intestines may give rise to the so-called phantom tumor. Pressure may sometimes change the form of the tumor. 126 Diagnosis of psychopathic diseases. Psychopathic paralysis consists of a loss of control in certain muscles, and is a frequent symptom in psychopathic diseases. The paralysis may vary in intensity, and is usually of very rapid or sudden onset. The most familiar form of paralysis is the hemiplegic type and usually follows a paroxysm. When only one limb is affected, all of its muscles are involved, and the member is simply dragged along and not swung in a semicircle, as is the case in familiar forms of hemiplegia of organic nature. The loss of power is not complete. Certain forms of psychopathic ataxia are also observed. Resistance to passive motion is regularly sustained, but varies from time to time or moment to moment. An effort by the patient to set in motion a certain group of muscles, such as the fleggers of the foot, may throw into activity the opposite group, the extensors, thus bringing about the inhibition of the intended movements. A tremor is often present in the partially paralyzed muscles. There may be slight atrophy present due to disuse. The electrical reactions remain normal. Pain in the spine is not uncommon, and may intensify the paralysis. Complete loss of power is rare. The patient is able to move the limb slowly, but falls to the ground when attempting to stand. The myotactic irritability is often increased. A pseudo or spurious foot clonus, however, is sometimes elicited due to a subconscious contraction in the calf muscles. The contractures in psychopathic states are often persistent remnants of hypnoidic states, after the states themselves have subsided into the subconscious regions. The origin of psychopathic contractures, as indeed of all motor disturbances, may be well demonstrated. Motor, visceral, and circulatory disturbances 127 by experiments which may be made in hypnosis. If, for instance, during the hypnotic state the patient is directed to do something, to take an imaginary bird, for example, and keep it tightly in the hand, the subject upon coming out of the hypnotic state, will keep the hand closed and will be unable to open it, though he does not know why it remains in that position. Such states are termed by me hypnagogic. These contractures, like all other allied conditions in psychopathic states, are of the same nature as those induced during hypnosis and persisting in the post-hypnotic state. In the psychopathic disturbances the hypnagogic states are more persistent, although they may pass away again as easily and suddenly as in those of hypnosis. They are due to present and past mental and emotional disturbances. Astasia-abasia is a form of psychopathic incoordination observed most frequently in children, the principal psychomotor manifestation being the inability to maintain the upright attitude. Tremors and movements of a choreic nature are sometimes present. In reclining postures the legs have normal power, but on attempting to stand or walk the patient falls or moves in a most awkward manner. There are no objective signs to indicate organic change in the motor apparatus. The onset is sudden and is generally due to subconscious emotions, to dissociated mental states. Other psychopathic symptoms may be present. The psychomotor manifestations of astasia-abasia are as sudden in their disappearance as in their onset. Psychopathic mutism, or aphonia, is often of sudden onset and usually disappears suddenly. The difference between psychopathic aphonia and psychopathic mutism 128 Diagnosis of psychopathic diseases is that while in the former the patient can still speak in a whisper, in the latter he cannot speak at all. Sometimes in mutism words and phrases can still be produced, and are usually those that were uttered during the accident or fright that caused the functional disturbance. Such phrases are hypnoid in character. In sleep the subject of psychopathic mutism shows the ability to talk during dreams. Such dreams are really hypnoidic states. Psychopathic aphonia may have its origin in the local affection of the larynx, but in some instances it appears spontaneously, especially after an intense emotion with subconscious mental dissociation. The laryngoscope may show paralysis of the adductor muscles of the vocal cords. The voice may often be brought out during coughing, and is then found to be possessed of its usual character. Frequently the patient, though not able to speak aloud, is still able to use his voice in singing. In rare cases of psychopathic aphonia the tongue may also be affected in the paralysis. Stammering is often present in psychopathic persons. It is very much like the aphonia in character and is often the result of intense dissociative emotional states, occurring mostly in children. In cases of aphonia under my care the patients talked in dreams or in the deep conditions of induced subconscious states. The phenomena of stammering may be explained best by a brief reference to the factors operating in the production of speech. In the production of speech we have two sets of mechanisms, the laryngeal and the oral. The former produces the vocal elements of speech and the latter, the oral, modifies the sounds of the larynx as to tone or motor, visceral, and circulatory disturbances 129 timbre and helps in the production of new sounds. In stammering the common defect is due to delayed activity of the laryngeal mechanism. Occasionally the oral mechanism may be at fault. When the patient tries to speak he throws the increased force into the lips. The center of the oral mechanism thus becomes surcharged with energy, and spasmodic movements even of great extent may occur. The nerve centers of the speech mechanism become so surcharged with energy that its liberation may give rise to irritation of other centers, and extensive movements in various parts of the body may result. Stammerers find it especially difficult to pronounce the first syllables of words. No matter how difficult it may be for the patient to speak, he can always sing with ease, because the vocal elements which form a part of speech and by which song is produced are formed in the larynx, and the laryngeal mechanism in itself is not affected, but only its cooperation, or association activity with the oral is interfered with. Stammerers in ordinary conversations may be excellent preachers, and in rapid conversation or speech, experience but little difficulty. Partial catalepsy is a psychopathic motor disturbance in which the extremities of the patient tend to maintain any position impressed upon them, and is due to a local disaggregation of the systems of neurons innervating the particular limb. The pathology of this state may be well represented as follows. Let C represent the muscles of the limb, B the motor center which innervates them, A the center for the kinesthetic sensation of the limb, D and E the fibers going from the center to the limb and from the limb to the 130 diagnosis of psychopathic diseases center. Assume now that the centers A and B are dissociated from the other brain centers, thus forming a closed system. Any impulse brought to the center B will provoke a discharge, which propagated through D will excite movement in C. The contraction of C gives rise to a discharge which is propagated through the sensory nerve to the kinesthetic center, A, awakening a kinesthetic sensation. The energy from A is then propagated to B, and there is once more a discharge of energy in B which again gives rise to a contraction of C. This goes on until the centers are exhausted, the limb being maintained in the same position. This form of catalepsy is known as a recurrent state or a circular reaction. Partial catalepsy usually occurs in limbs which are anesthetic. A very slight stimulus may change the position of the limb, leaving it in the same state of rigidity and catalepsy. The cataleptic condition is characterized by its persistency and duration, the affected limb retaining for a long time positions impossible in the normal state. So rigid and steadfast is the cataleptic limb that tracings taken of it on a smoked drum show a straight line, while the normal member held in the same position shows a quite irregular tracing, due to tremor. The rigid limb can often maintain its position for a half an hour, and the interest lies in the fact that no fatigue is felt by the patient, although sometimes he may complain of severe pain in the limb. During the cataleptic state the patient does not know the position of the limb, and may have an erroneous impression as to its position when his attention is distracted. If the patient is asked to change the attitude of the limb, he is unable to do it, not knowing its motor, visceral, and circulatory disturbances 131 position. In the cataleptic state the phenomena of rapport may be present. If the arm, for instance, is placed in a certain position, that position can be changed only by the experimenter who induced it, and by no one else. If a definite movement is imparted to the cataleptic limb, the member will continue to move with regular rhythm, the patient being unconscious of the movements. If, however, the patient's attention is drawn to the movements, they cease at once, to be resumed when the attention is withdrawn. If the arm is placed in a cataleptic state, adaptation to certain objects placed in the hand occurs. For instance, if a pencil is put in the hand, the fingers grasp it, and sometimes begin to write. Catalepsy is said to be general, when it involves the whole body. General catalepsy is common in the third stage, that of emotional attitudes, of the major attacks of the psychopathic paroxysm. At the beginning of the attack there may be some rigidity and then a condition of wax-like flexibility, seria flexibilitas, follows. Such a condition occurs also in insanities as in catatonia. General catalepsy may also be produced in hypnosis. It occurs also in melancholia, and is sometimes present in epileptics. In complete catalepsy, the entire body becomes more or less rigid, the limbs remaining in the position they have originally assumed. At first the muscular rigidity is considerable and an attempt at passive movement is resisted. Soon, however, the limbs become flexible and remain in any position in which they are placed. The rigidity finally yields when the energy from the innervating centers becomes exhausted. The state of SEN 132 diagnosis of psychopathic diseases stability varies. In deep cataleptic states, sensibility to touch, pain, and electricity is lost. The reflexes including the conjunctival are lost. In rare cases the reflexes and the general sensibility remain unaffected. Cataleptic attacks are sometimes preceded by hiccough, headache, and dizziness. It is not uncommon to find a periodicity in the recurrence of the cataleptic attacks. This periodicity, however, is readily understood, since the cataleptic state is hypnoidic in character. Catalepsy is a hypnoidic state. The physiological tendency of systems of cells in their functional activity is to form habits in which the energy discharges or runs down in some regular clock-like form. The hypnoidic state in catalepsy may be called up by stimuli which may happen to come at regular or irregular intervals. More often, of course, they will come at irregular intervals, and the hypnoidic cataleptic state will then occur irregularly. Some stimuli, however, may happen to come a few times at regular intervals. The disaggregated systems thus form a habit to appear at regular intervals, hence the periodicity of the attacks. Lethargy is a psychopathic disturbance in which the patient is in a sleep-like state, with slowness of muscular movement, due to exhaustion of neuron energy. The patient is aroused with difficulty. Etiologically, hereditary or neurotic predispositions play important roles. Excessive mental work, exhausting fevers, such as typhoid, etc., influenza and trauma, especially when associated with strong emotion, are among the proximate causes. Intense emotions alone in those predisposed may be an exciting cause. Lethargy is generally sudden in its onset, the state motor, visceral, and circulatory disturbances 133 lasting from a few days to several weeks. During the attack the limbs are limp and the face is pallid. The closed eyelids cannot be opened, the subject apparently resisting the attempt. The eyeballs are turned upward, the pupils remain normal in size and in their reaction. There is occasionally a change in reflex activity, the nasal and conjunctival reflexes sometimes being absent. The upper consciousness is in abeyance and the special senses may be unusually keen, although motor manifestations are inhibited, owing to a disaggregation within the psychomotor areas. The pulse, as in sleeping states generally, is often small and the respiration may become shallow and scarcely perceptible. The temperature is normal. The urine may be retained or may be passed involuntarily. The vital functions may be so depressed that the patient may be seemingly dead. This state is sometimes characterized as morbus hypnoticus. If the trance state is long in duration, the patient may awaken partially and partake of nourishment. The end of the state is often indicated by sighing or deep breathing. Vasomotor changes, such as extravasations, may occur. The deep lethargic state sometimes closely simulates real death. The fundus of the eyeball, however, is normal, the muscles react to electricity, and there are no signs of degeneration. The lethargic state, like the cataleptic, is doubtless of a hypnoidic nature, subconscious activity being occasionally made manifest by movements and exclamations. In some cases it is possible to come into direct communication with the disaggregate subconscious, and to induce illusions, hallucinations, various movements and reactions and adaptations to the illusory and HAL 134 diagnosis of psychopathic diseases hallucinatory environment. In visceral disturbances of psychopathic character, gastric paresthesia is common, giving rise to sensation of fullness or distension, sinking, emptiness, etc. So-called nervous dyspepsia with its attendant feeling of distress may be present. There may be spasmodic contracture of the esophageal or pharyngeal muscles produced by taking food in solid form. The spasm may last for a short period, or may persist for months. When there is vomiting, it may or may not be accompanied by nausea. The vomiting sometimes seems to be provoked by food, irritating the gastric mucous membrane. There may be slight hematmesis, the blood being of a bright color. Psychopathic anorexia or anorexia nervosa is not uncommon. The patient in this condition has a disgust for food and rejects it. A perverted taste for odd or indigestible material is occasionally present. The patient's nutrition may suffer severely, and he may lose greatly in weight. Intestinal derangements are not unusual. Nervous diarrhea or obstinate constipation is sometimes observed. Accumulation of gas in the bowels giving rise to borborygmus is common, often causing cardiac palpitation and respiratory difficulty. The heartbeat is rapid and weak. There is paleness, general muscular weakness and dizziness which may end in syncope. Polyuria, either permanent or temporary, is not uncommon, the patient sometimes passing a large quantity of pale lutein. Hematuria is rare. Ischuria occasionally occurs. Perspiration may be profuse. There may also be severe vomiting. In psychopathic states patients, especially women, motor, visceral, and circulatory disturbances 135 often locate the trouble in some part of the genital apparatus. This gave rise to identification of psychopathies in general with those associated with uterine disturbances, under the name of hysteria, or sometimes hystroneurosis, which really bear no relation to sexual organs in general and to the uterus in particular. The sexual organs, like any other organs, may give rise reflexly to psychopathic disturbances, but psychopathic states can be as little identified with sexual troubles as with gastric disturbances. Women are prone to refer their ills to sexual derangements, because by education, training, and persistent suggestion the sexual functions are given undue prominence in the patient's mind. Frequently, especially in former years, all sorts of operations, hysterectomy, ovariotomy, etc., have been resorted to for the alleviation of psychopathic affections. The recent psychoanalytic theories of hysteria and hystroneurosis, implying the relation of psychopathic states to sexual life, are scientifically fallacious and practically extremely harmful to the patient and pernicious to the community. A good deal of the sexual matter claimed to be revealed by psychoanalysis is due to suggestions given by the patient's surroundings and education, and then specially enforced by the physician's psychoanalytic, preconceived prejudices. Among the psychopathic visceral disturbances involving the mechanism of respiration we find psychopathic asthma. There may be cough and profuse expectoration, occasionally followed by convulsive or spasmodic attack of dyspnea. There is often a reflex so-called nervous cough of psychopathic nature. It is of a hard, dry, paroxysmal character. It may occur many times during the day, and be of short or of long duration. 136 Diagnosis of psychopathic diseases. The cough ceases during the night when the patient sleeps. Psychopathic coughs are sometimes produced in imitation of the cry of an animal, such as the barking of a dog or mewing of a cat. These peculiar noises sometimes occur in epidemic form. Hiccoughs, yawning, sobbing, etc., may occur in paroxysms. Irregularities in cardiac rhythm are common, and these are provoked by the least emotional excitement. Tachycardia is frequent. The attacks may be of several hours' duration. Angina pectoris of psychopathic origin is sometimes observed. Bradycardia is rare. Vasomotor changes are found in some cases. Sudden flushing or pallor of the face, or of the upper part of the body accompanied by heat and cold sensations are observed. At times constriction of the blood vessels may cause local cyanosis. Various skin eruptions are occasionally observed in psychopathic cases. These have been regarded and described as hysterical or psychopathic. They are, however, neuropathic in their nature, though they may be often associated with psychopathic states. We cannot impress too much on the physician's mind that all psychopathic disturbances, whether sensory, motor, visceral, and glandular, are essentially morbid affections of the patient's subconscious life. One important law holds true of all psychopathic maladies, and that is all conscious losses are subconscious gains. Whatever function is lost to the upper consciousness is present to the subconscious. This can be tested by the various methods for reaching the subconscious. Chapter 14 Illusions F*He brain receives impressions from the external world. These impressions stimulate the activity of groups and systems of new happy smiley neurons and give rise to complex physiological processes having sensations as their concomitants. These processes stimulate activity of still more complex systems, groups of systems giving rise to physiological processes, having percepts as their accompaniment, and finally with the awakening of the activity of the highest constellations of neurons with their concomitant moments, the highest form of consciousness, conceptual thought and judgment, is formed. There may be a disturbance in any of the several levels of psychophysiological activity. Where the disturbance is chiefly of a perceptual character, it gives rise to illusions and hallucinations. An illusion is a wrong perception of stimuli coming from an external source, a false perception of an external object. If an object, such for instance as a chair, is regarded as a man, the percept is illusory, and the perception is an illusion. Illusions may often appear in healthy individuals in waking states and more specially in dream states. In fact, art, such as painting, scenic effect produced in the dramatic world, etc., is based upon illusion. Illusions are common in psychopathic diseases. They may be induced in hypnosis and in other forms of subconscious states. Illusions occur most frequently in the insane. 138 Diagnosis of psychopathic diseases. An hallucination differs from an illusion in the fact that the projection of the percept is more subjective in its nature. There may be nothing in the external world and yet the subject or patient perceives a person or hears a voice, for instance, which no sound is present. An illusion seems to be more peripheral in its nature while an hallucination seems to be more central in its character. There can be as many illusions or hallucinations as there are special senses. Hence they may be classified as visual, olfactory, gustatory, auditory, tactile. The physiological processes which operate in an illusion are as follows. In general, the perception of an object consists in a synthesis of a present sensation with emerged subconscious, secondary sensations. Take for instance an apple. The perception of the apple may be by simple vision. We may see the outside general form, or perhaps only the general outline of the form and color, the one due to muscular eye movements and the other due to processes within the optic nerve. These sensations are peripheral incoming impressions. They would not in themselves constitute the perception of the apple. Along with them is aroused the spherical form of the apple, which could not be perceived by the visual sense alone. but depends also on muscular eye movements, and depends also on previous tactile and muscular sensations in the handling of the apple. The solidity and hardness of the apple, which depend on sensations given by the resistance and the weight of the apple, are due to muscular and tactile sensations. Then the peculiar taste and smell of the apple depend on previous gustatory and olfactory sensor illusions 139 tions. The average temperature of the apple is also innate. All these psychic processes are awakened as soon as the eye perceives the apple. The eye itself cannot smell, or touch or weigh the apple, it cannot feel the solidity of the apple, and yet all these are present in the vision of the object. It is evident therefore that in seeing an apple the visual sensation awakens, by association, many subconscious psychic processes which form a synthesis in the percept, apple. This can be accomplished not only by vision, but also by the olfactory or tactile sensations, or even by auditory sensation, such as the peculiar sound which the paring of the apple produces. If A, B, C, D, E, F, etc., represent the associated physiological processes, and if A is peripherally awakened, then the others become synthetized and form the percept. The same occurs if B first appears, the rest of the processes may become synthetized, etc. In short, all these processes form a system, and if one is awakened all the rest may appear and become synthetized. Suppose now another synthesis, that is, one resulting in the percept of another object, is formed in which one, two or more of the elements of another system, elements which are common to both, are present. The two synthetized systems may become interchangeable by the principle of association by contiguity or resemblance. Thus it is possible that under certain circumstances, such as change of intensity of one or of some of the sensory components, or of lack of critical discrimination of the differences and details of the presented content instead of the one system exactly corresponding to the object being awakened, another one, which does not exactly correspond to the object is brought out in 140 diagnosis of psychopathic diseases stead. This will constitute an illusion. In art we find common examples when for instance artificial objects are made so as to represent as nearly as possible the real object. Living in a more or less constant environment, certain sensations naturally give rise to the most familiar systems, but when the environment is changed we often fall into illusions. Our environment, however, does not go on changing so rapidly as to give rise to illusions, and, therefore, our familiar percepts are correct, corresponding to external objects. These familiar percepts are adaptations between external objects and internal relations. Instead, however, of there being a disturbance in the external relations, in the environment, there may be derangement of internal psychic processes. A stimulus therefore may give rise to sensations and instead of calling out the most familiar synthesis corresponding to this aggregation of external stimuli, calls out some other system, having something in common with the most familiar system. This gives rise to illusions. As a rule in ordinary illusions of common life, there is some similarity between the object and the illusory system awakened, but in insanity and under the influence of some toxic agents, the disturbance may be so great that but slight, inessential similarity is present. In illusions the peripheral sense organ may be in no way at fault, as a rule it is not, but rather the subconscious psychic systems which are excited and go to form the percept are at fault. In short, the fault is not in the sensation, but in the association. An aggregation of stimuli giving rise to peripheral illusions 141 sensory impressions and awakening sensations excite also subconscious psychic processes which in themselves are not of the nature of direct sensation, but rather of the nature of indirect sensation belonging to the most familiar systems of synthetized psychic processes forming familiar percepts. There are, however, cases, the rare and unusual in common life, in which an impression, giving rise to a special sensation, directly revives another impression also of a sensory character, giving rise to what we may call a secondary sensation. There is no external stimulus present to awaken this sensation, but it is awakened by the excitement of another special sense organ. It seems that in such persons there must be an association formed between two or more of the lower sensory centers. Thus, for example, there are persons who, seeing a certain color, for instance, red, will at once hear a certain sound. This is not in the nature of a memory merely, the patient seems really to hear the sound. A sensation of smell may give rise to a sensation of light, etc. Sometimes the sensations may be related. For instance, a certain form, say that of a certain letter, may awaken the sensation of a certain color. In this way all kinds of combinations may be formed. There may be various combinations of primary with secondary sensations. We may have the following photisms and phonisms or synesthesia. 142 Diagnosis of psychopathic diseases: sound photism, taste photism, pressure photism, movement photism, smell photism, touch photism, temperature photism, light phonism, taste phonism, pressure phonism, movement phonism, smell phonism, touch phonism, temperature phonism. In fact, any combination of primary with secondary sensation may be present. These secondary sensations are due to the formation probably of certain special, subcortical associations between the respective sensory centers. The following laws have been formulated. 1. Photisms bright in color are produced by sounds of high quality, by intense pain, sharply defined sensations of touch. Dark photisms form opposite conditions. 2. High phonisms are produced by bright light, well-defined outlines, small objects, pointed forms. Low phonisms form opposite conditions. 3. Photisms are associated with well-defined forms, small, pointed. Photisms are often produced by sounds of high pitch. 4. Red, yellow, and brown are frequent photism colors, violet and green are rare, while blue stands between these extremes. Secondary sensations in their pure form, although found in normal persons, usually appear in those of neurotic tendency and in psychopathic states. Chapter Hallucination and 15 Perception consist in the PSYCHOLLUCINCTSNS of Abgio, which as far as it is possible to determine have no existence in the external environment at the time perceived, or may have no existence whatever. If a man sees, for instance, the stump of a tree and takes it for an animal, we would say he has an illusion. If, however, there is no object at all, but still the man perceives a moving animal or object, he is the subject of an hallucination. In the same way, hallucinations may be of a gustatory, olfactory, tactile or auditory character. Putting together hallucinations and illusions, we may arrange them in the following order of frequency: hearing, sight, common sensibility, smell, and taste. Various theories have been advanced to explain the mechanism of hallucinations, but none seem satisfactory. In my works I ventured to advance the following theory: hallucinations are of the nature of secondary sensations. When a certain stimulus makes an impression on a peripheral sense organ and gives rise to secondary sensations, we really have an hallucination, but in its simplest form. The one who on perceiving the letter A sees at the same time a yellow or red color, or hears a sound or feels a touch, really has a hallucination. He has a sensation which has no corresponding external 143 clear that hallucination's stimulus. Thus far it is quite, at least in their simplest form, may be nothing else than 144 Diagnosis of psychopathic diseases secondary sensations. We have seen previously that sensations form the cue, awakening subconscious psychic processes which become synthesized into a percept. If the secondary sensation is of such a nature as to enter into a subconscious synthesized system, it will awaken a percept, and we shall have the hallucination of objects. The corresponding physiological process is the dissociation of the sensory centers or of some groups of neurons within the sensory centers from the corresponding perceptive center, and associations of these groups with those of another sensory center. This process gives rise to secondary sensations, which in their turn may give rise to a complex physiological activity, awakening subconscious processes, with the psychic correlate, the percept, the hallucinatory percept. The least stimulus may give rise to such dissociations of groups of neurons within the higher perceptive centers, and to the formation of new subcortical associations of the disaggregated groups, resulting in the formation of hallucinations. The stimulus will in fact be disregarded by the patient and the hallucination will absorb his entire attention. The hallucination in such a case is regarded of purely central origin. In this way voices, visions, and similar hallucinations are generated. Hallucination plays an important role in the domain of psychopathology. It is therefore advisable to enter into a more detailed study of the subject. The subject of hallucinations forms the stumbling block both of psychologists and psychopathologists. The deeper we penetrate into the subject, the greater confusion we encounter. Some regard hallucinations as being of peri-hallucination and perception-feral origin, others regard them as central in character, while still others go to the extent of claiming that the most central hallucinations are of supernatural origin, being communications and messages from a transcendental world. In view of the importance of the subject, it may be well to make an attempt to throw some additional ray of light on this obscure matter from the standpoint of psychological and psychopathological analysis. The usual definition of illusion and hallucination is with regard to the external object. Illusion is defined as fallacious perception of some actually existing object, while hallucination is perception of a non-existing object. This definition is good for practical purposes of the clinician, but it is not psychological. From a strictly psychological standpoint, illusions and hallucinations cannot possibly be differentiated from other psychic states by the presence or absence of external objects. External objects can hardly be regarded as constituents or necessary ingredients of psychic states. Illusions and hallucinations should be defined in terms of psychic processes. In order to get a clearer insight into the nature of illusions and hallucinations, it may be well to begin with a brief analysis of the process of perception. If we take a cross-section of a moment of consciousness and try to fixate it with our mental eye, we find a central psychic experience, or psychic element round which other psychic experiences or psychic elements are crystallized and organized. This psychic experience, or central element, is prominent, vivid, and constitutes the vital point of all the other organized states, giving the tone to the rest, to a whole, to one organized X146 diagnosis of psychopathic diseases perience. The psychic matter that surrounds the luminous central point does not stand in a free more or less disconnected relation to the latter. It is intimately related to the center, and cannot be separated without destroying the moment as a whole and even the life existence of each particular constituent. The whole moment seems to form an organic network in which the other elements take their place according to a plan. The structure of the moment may in this respect be compared with that of the cell. In the cell we discern a nucleus round which cytoplasm is grouped. The protoplasm is connected with the nucleus by a network embedded in the cytoplasm. The destruction of the nucleus affects the cytoplasm and the destruction of the cytoplasm affects the nucleus. The two are intimately, organically interrelated by the common network, the general plan of their organization. If we closely examine the percept, we find in it a central, sensory element, surrounded by other elements. This central element stands out prominently in the given psychic state, while the other elements are subordinate. Not that those elements are unimportant for the percept, on the contrary they are of the highest consequence and moment, they only lie outside the focus of the mental state. Along with the focus, those elements form one organized whole. All the elements of the percept form one texture, having the central sensory element as its nucleus. Integrated, however, as all these elements are, they are not of equal value and importance to the life existence of the whole. The central sensory element is of the utmost consequence. It is the vital point of the hallucination and perception 147 total experience. While the change, or destruction of one or of some of the subordinate elements may still leave the total percept unchanged, or but slightly modified, a change of the central sensory element or of the nucleus will profoundly modify all the other elements and their interrelation. The elements of the percept may be regarded as bound up in a chemical compound, so to say, together giving rise to the qualitative aspect of the total combination, the difference being that in the psychic compound there is a central element that gives the keynote to the combination. In the chemical compound the elements are all equal in value and importance. To form water, for instance, an atom of oxygen to 2 of hydrogen is required. The oxygen and the hydrogen are both equally requisite to the formation of the compound, one is not more important than the other. Not so is it in the psychic compound, there the elements are of unequal value. The most important of them is the nucleus, it determines the interrelation of the psychic elements and also the outcome of the whole combination. From a biological standpoint we can well see why this should be so. A psychic compound is biological, not purely physical or chemical. In the physical components there is no higher and no lower, all are of equal value. In the psychic, as in all life existence, there is a higher and a lower structure. In other words, the biological compound is peculiar and different from the chemical, inasmuch as the former is really not a compound, but an organization. The characteristic of organization is just this systemic combination of parts related in different grades and orders of importance for the total life existence of the whole. 148 Diagnosis of psychopathic diseases. Looked at from another standpoint we can further see the necessity of such a central element. We have pointed out in another place that one aspect of the biological process is that of purpose, and if that be granted, then psychic processes regarded as highly developed biological processes should present this general characteristic of purposiveness in its fully developed form. Now, where purpose is involved, the end alone is the important thing, all the other elements are for that end, subordinate and determined by it. Not that the other elements are unimportant, they may be intimately related, but they, after all, are only means to accomplish the end. The elements that have for the time being the organizing power to aggregate round themselves the proper elements and lead towards the required end are predominant. For every psychic state is essentially for some reaction, and that sensory element which gives the cue for the formation of the psychomotor elements, leading to some given reaction, is for the time being the center, the nucleus of the total state. The flower before me attracts my attention. I see its color of a light violet tint, its rounded bell shape and its velvet-like softness. I stretch out my hand, carrying the flower to my nose, to enjoy its fragrance. What I really see is the violet tint, the rest of the elements are not given directly, they are largely inferred. The shape is largely an inference from previous muscular eye movements, and its softness is derived from previous tactile experiences. They are all, however, perceived by the eye, the cue being given by the prominent visual sensation. Although the flower as percept appears as an organ hallucination and perception 149 is whole, still the sensation of sight forms the nucleus round which the others cluster. The perceptual tone is given and determined by the particular sensations of sight. The softness, though perceived, is still altogether different from the sensation softness as directly experienced through the organ of touch. It is a sensory sight softness. The same is true of all the other sensory elements. They are all essentially determined in their quality by the central sensation. In seeing a lump of ice we perceive its whiteness, its transparency, its hardness, its smoothness, etc. The hardness and smoothness are essential elements of the percept ice. These elements seem to be given directly in sensory experience. They seem to be directly perceived and still are qualitatively different from the hardness, smoothness, and coldness as given directly by the experience, when the hand gets hold of a smooth lump of ice. The sensory elements are determined and colored by the central, visual, sensory elements. The sensory elements of coldness, hardness, smoothness are of a visual character. It is usually claimed that such additional elements that are not given directly by the stimulated organ are elements representative in character, derived from memory. This statement is not quite correct. In seeing the piece of ice, the hardness, smoothness are not represented, they are presented to the eye. We really seem to see, to experience these sensations going to make up the percept ice. It is not true that on catching sight of a whitish, transparent, glittering lump we remember that it is also hard, smooth, and cold. The whole percept with all its sensory elements appears at once in the synthesis of the percept ice. We 150 Diagnosis of Psychopathic Diseases C. We perceive the hard, smooth, cold ice. The hardness simply remembered is altogether different from the hardness perceived in the seeing of the lump of ice. The hardness, smoothness as they appear in the ice are different to the eye, and as different psychologically from the corresponding representations as the latter differ from the corresponding sensations directly experienced by the appropriate sense organs. Pathological cases seem to confirm the same point of view. There are certain mental diseases, when the patient can perceive the object correctly, though he cannot represent it to himself. The patient can perceive all the elements on being confronted with the object, but by no means can he remember them. On the other hand, there are cases when the patient can easily represent to himself objects, but cannot recognize the object when directly confronted with it. The subordinate elements in their turn play an important role in the total unity of psychic experience, in the percept, inasmuch as they give the content of the total moment, fermented, so to say, by the predominant nuclear element. The visual elements, the perception of play of light and shade would have been nothing but mere play of light and shade, if not for the subordinate tactual and motor elements that give rise to the perception of distance, dimension, size, body. The leading element gives the character to the content by having it appear under its own special sensory aspect, while the other elements give the content to the whole moment. Thus where space is perceived through the organ of sight mainly, the space is visual in character, though the content that gives rise to the perception of space itself is filled in by other psychic elements. Hallucination and perception 151. The central element with its content may be regarded as the nucleus of the cell, surrounded by its cytoplasm, and the total organic whole may be termed psychic compound. Now in the psychic compound the constituent elements of the content can no longer be directly discriminated. In the lower forms of mental life the elements are firmly bound as we find it to be in the psychic compound, the percept. In the forms where the elements are more complex the synthesis results in fusion in which the elements can be more or less easily discriminated. Thus if one listens to the beats of a metronome and to the rhythmical vibrations of a pendulum, The sensations blend and fuse, the sounds seem to proceed from the vibrating pendulum. The same case is well illustrated in the well-known amusement of having one hidden behind a screen and making a speech, while another one is watched who is gesticulating in accordance with the modulations of the speaker's voice. The two series of sensations blend and the voice seems to proceed from the gesticulating person. The synthesized elements here are fused or more or less mechanically joined instead of being firmly combined in a sort of mental chemistry. In the higher and more complex mental states, the constituents of synthesis are neither chemically nor mechanically fused. The constituents stand out free and distinct. While I am writing this page, I see on my table at one glance the light, the lamp, the paper, the pen writing words and lines, and hear and feel the pen move on the surface of the paper. At the same time I see the table, the chair in the room, and hear the ticking of the clock. The multiplicity of all these experiences, 152 diagnosis of psychopathic diseases, is simultaneously synthesized, and at the same time discriminated in the unity of the total experience. In the processes of succession of complexes of psychic elements, in the trains of ideas, the constituent elements attain their greatest freedom and independence. In the states of perceptual synthesis, on the contrary, the directly experienced sensory elements, constituting the nucleus of the percept, call out immediately their appropriate associated, perceptual elements, and the compound, the percept, appears, as a whole that can be analyzed only under highly artificial conditions. Fixity is the essential characteristic of lower mental stages as well as of the percept. The constituent psychic elements are so intimately united in the percept that they resist efforts at decomposition. A perceptor is composed of elements A, B, C, D, and if A be the nucleus, the stimulation of the nucleus brings out the rest, B, C, D. The central, or nuclear element is purely sensory, but the rest of the psychic elements B, C, D, are not sensory in the same sense as A is, since they are not derived from direct stimulations of the appropriated sense organs. Their character is not primarily, but only secondarily sensory. The retina gives only light sensations. The most differentiated and highly organized retinal structure of the highest vertebrates, such as that of the higher mammals, can only give rise to local signs, to highly differentiated light sensations varying with each retinal point or element, or cellular termination. The stimulated retinal elements with the neuron terminations of the optic nerve can give nothing else but light sensations. PND, the image formed on the retina, is in fact nothing else but a series of light sensations. If this be so, how? Hallucination and perception. 153 Then do we come to see that tangible, heavy, solid body yonder at a more or less definite distance. Solidity, bulk are not given in light sensations as such. How then are those spatial and physical characters perceived so distinctly as to assume a direct sensory character? It cannot be ascribed to the principle of association of ideas. For the object and its distance appear at once, in one single glance, before any idea comes to the mind. Furthermore, an idea from its very nature stands out distinct and definite. It is essentially free, but the psychic elements of object and distance are not discriminated. Again, phylogenetically and ontogenetically, sensation and perception precede ideation. The infant, the animal, perceives objects and distance, and certainly with little or no ideation present. In the visual perception of distance, the subordinate psychic elements derived from other senses are not of an ideational character, they are of a sensory character. The eye sees the distance. The eye sees distance or volume directly, because of other elements involved in the process of perception, such as the kinesthetic sensations coming from the movements of the eyes in their adjustment to the stimulations from the external environment, Also tactile, muscular and kinesthetic sensations derived from skin, muscles, joints and articular surfaces, all synthesized in the given percept. The subordinate psychic elements are neither of the character of pure sensations nor are they of the nature of pure ideas. What are they? They seem to be intermediary in character, intermediary between the nature of sensation and that of idea. Perception appears to be an intermediary process. We may regard the same process from hypothetical 154 diagnosis of psychopathic diseases physiological standpoint, which may possibly help us in picturing the mechanism. A specific physical stimulus produces in the peripheral sense organ a definite physiological process which is transmitted to groups of neuron systems, stimulating them to activity and giving rise to specific physiological processes. Whenever these specific physiological processes are peripherally induced, the special, sensory elements arise. If groups and systems of such psychophysiological elements become associated and organized round a central nucleus, the result of the functioning activity of the total organic complex is a psychic compound, a percept. Whenever one of the groups is peripherally stimulated and is awakened to activity, the other elements become stimulated, and the result is the organized activity of function of all the elements, thus giving rise to the synthesis of all the psychic elements, namely the percept. Now we should postulate some difference in the psychic state as to whether psychophysiological elements are stimulated directly through their own appropriate sense organ or whether they are awakened to activity indirectly through other sense organs. The direct peripheral stimulation gives rise to psychic elements characteristic of particular sense organ and its nervous tracts and central systems of neurons, whilst the indirect peripheral stimulation gives rise to psychic elements whose pure and real sensory character is not clearly revealed in the total psychic state or moment. These indirectly induced sensory elements are so much colored and infused with the sensory qualities of the nuclear sensory elements that their character and origin are transformed, and they appear not to differ in their nature from the nuclear elements. Hallucination and perception 155. A closer inspection, however, fully reveals their real nature as sensory elements, extraneous to the nuclear elements and derived from different sensory sources. The nuclear elements are primarily derived, insofar as they are directly initiated by the incoming peripheral stimulations, while the extranuclear sensory elements may be regarded as secondarily initiated by peripheral stimuli. Let V be the sensory visual system, T and M tactile and sensory motor systems, A sensory auditory systems. Let V** be the visual sensations peripherally stimulated, 7% me, the tactile motor and auditory sensations of the corresponding sensory systems. Let, further, V** T** mz, A** be the psychic elements indirectly or secondarily initiated, then the percept when V** is the nucleus may be represented by VTFT** m***. Psychic elements primarily or secondarily peripherally initiated are not identical with ideational states. An idea or image differs qualitatively from a percept and its elements. An image lacks sensory character. An image is more generic, while a percept is more specific. I see that lamp post yonder. It is a particular object rigidly limited in a particular space. Not so is the image. The image of the lamppost refers to lampposts in general. When I perceive an object and then try to represent it to myself, the object is not presented to consciousness in its sensory perceptual form, it is present to consciousness rather as a symbol, ideally representing perceptual experience peripherally initiated. From an anatomical and physiological standpoint, it is quite probable that ideomotor systems are neuron organizations different from those of the sensory motor systems. Psychopathology, with its rich store of facts, 156 diagnosis of psychopathic diseases, seems to favor this view. As we have already pointed out, there are pathological cases where the patient does not know the object on perceiving it, although he can represent it to himself, and again there are other cases where the patient cannot represent to himself the object, but he knows the object on perceiving it. Flickseeg's embryological studies go further to show that the sensory centers are different from the associative centers, which do not stand in direct relation with the external environment and appear rather late in the course of ontogenetic development. The view often maintained that the same sensory structures underlie both sensory and ideational processes does not seem to be probable in the light of recent research. The activity of the sensory motor neuron systems does not give rise to ideas, but to psychic states essentially sensory in character. In the case of the percept, the subordinate psychic elements entering into the synthesis of perceptual psychic compounds are of a sensory nature. They only differ from pure sensations insofar as they are not directly peripherally initiated, but centrally, or trill to say, indirectly peripherally initiated, and as such occupy an intermediary state between sensation and ideation. In other words, the subordinate perceptual elements may be regarded as reflex in character, as being of the nature of secondary sensations. The nature of illusions and hallucinations is more or less cleared up from this standpoint, and the latter in its turn may be still further illustrated and confirmed by the facts coming from the domain of abnormal mental life. Let us take a series of cases of abnormal or fallacious perception. In looking through the stereoscope, the two plain dissimilar views are combined and give the hallucination and perception 157 shorn of a solid object. Here the illusion is due to imitation of external conditions. The external stimulations that give rise to the perception of a solid object are here closely reproduced. The visual sensory elements are stimulated and the rest of the groups are reproduced. Associated sensory elements or secondary sensations emerge, and perceptual synthesis arises. The illusions to which in my student days I attracted Professor Minsterberg's attention are of a similar character. If each eye looks through a separate tube, and if the other ends of the tubes are brought together, the openings of the tubes coincide, appearing as one, and the eye appears to look through one tube only. If now only one tube is looked through, and the other eye glides along the surface of the tube, the opening of the tube appears outside, removed and raised higher than the real opening, the opening appearing to be directly seen not by the eye which looks through the tube, but by the other eye that does not look through. The illusion can be made more striking by putting the hand where the illusory opening appears and the hand appears to be pierced by a round hole. The conditions are such that the convergence of the eyes displaces the lighted up opening towards the field of vision of the open eye not enclosed in the dark tube. Similarly, when closing one eye and having the other wide open, we press the closed eye sideways towards the nasal side. The round phosphen seems to be projected into the field of vision of the other eye, and the phosphen really appearing in the field of the closed eye, as one can convince oneself by closing the open eye, appears to be directly seen by the open eye. In all these experiments the arrangement is such as 158 diagnosis of psychopathic diseases to imitate conditions under which other percepts normally arise, and the result is the reproduction of those specific states of perception. To take another example, in a fog or in the darkness we may take a tree for a man or mistake a rope for a snake. Similarly, in the shape of clouds and blots we can often see different figures. The illusion here is rather due to the vagueness of the cue or of the sensory nucleus, the character of which may vary with distance or with the intensity of light. In mental derangements, such as in the different forms of insanity or of psychopathic functional diseases, in hypnotic, post-hypnotic and hypnoidic states the object is perceived as different, independent of external conditions, such, for instance, as convergence, divergence, light, distance. A chair may be perceived as a tiger no matter how the visual axis is placed or what the distance be, or how intense the light is. Certain definite visual sensations may be correctly perceived, but on account of dissociation in psychopathic states, sensations different from the customary, associated secondary sensations are aroused, which in turn awaken different secondary sensations in the sensory motor systems of neurons, and the result is a different psychic compound, an illusion or a hallucination. In the preceding cases, the nuclear elements obscured in different ways by the subordinate elements are nevertheless present in consciousness and still form the nucleus of the percept, into which other subordinate elements enter as constituents, and give rise to fallacious perception. Should now the nuclear elements themselves, on account of inattention or of their minimal sensory intensity, or what is still more often the case, on hallucination and perception account of states of dissociation, should such nuclear elements be left out of consciousness or remain in the subconsciousness, as in dissociative states, then the fallacious percept stands out clear and distinct in the light of consciousness, and a fully developed hallucination results. Sensory elements which themselves may remain unperceived stimulate other sensory elements that give rise to a perceptual compound which is entirely of a secondary sensory character. The hallucinatory percept does not contain the primary sensations aroused by the stimulus, it consists of secondary sensory elements, and as such a hallucination may be regarded as a secondary percept. Hallucinations are of the nature of secondary sensations. The simplest state of hallucination is found in the phenomena of synesthesia or in the phenomena of secondary sensations, such as light phonisms, sound photisms, etc., when one sensation, instead of giving rise to a subsequent idea, awakens instead a qualitatively different sensation derived from another sense organ, a color or letter arousing a certain sound, definite sounds arousing certain colors, and so on. When a certain stimulus makes an impression on a peripheral sense organ and gives rise to secondary sensations, we really have a hallucination, but in its simplest form. He who on seeing the letter A, for instance, also hears a sound or feels a prick, or a touch may be regarded as having a hallucination. In this simple form we can possibly more clearly discriminate the character of hallucination. When on seeing letter A, we hear a sound, the indirectly aroused auditory, sensory elements do not contain the primary sensory visual elements. In the secondary sensation or in the more complex state of perception of secondary character, the primary elements are left out. A stimulus may 160 diagnosis of psychopathic diseases arouse sensory elements in one sensory center, which in its turn may stimulate systems of sensory elements in other sensory centers, thus giving rise to a group of secondary sensations synthesized into a percept, while the original sensation with its nuclear sensory elements may remain in the background. Such a physiological stimulus may often be not an external physical stimulus, but a pathological process going on either in the peripheral sense organ from which the nuclear sensory elements arise or in the sense organs from which the secondary sensory elements originate. Let S be the stimulus and V plus or minus the visual sensory elements and A asterisk T asterisk M asterisk the secondary sensory elements, then T7 may be dissociated, while the secondary sensory elements A2 T2 M2 stand out alone in consciousness as a secondary percept or hallucination. It may again be that not only the primary but also the appropriate system of secondary elements may be left out of consciousness, while associated systems of secondary elements may be awakened and stand out fully in the light of consciousness, thus giving rise to a hallucination removed in its character from the original primary elements with their organized secondary elements. The preparedness of remote secondary groups may often be determined by the type of mental structure. Hallucinations of visions, or of voices, or of movements will predominate, according as the type of mental structure is visual, audile, or motile. The mental type plays no doubt a very important part in the formation of illusions and hallucinations. In the insane, auditory illusions and hallucinations predominate in the audiles, and while, on the one hand, paranoiacs are often audiles, on hallucination and perception 161 the other hand, audiles are inclined to paranoia. In hypnosis, hallucinations become more easily realized, if they are adapted to the mental type of the subject. Preparedness and sub-excitement of ideomotor groups with which the secondary sensory groups are associated also form an important factor in the final determination of the character of the illusion or hallucination. This is rather of an indirect character. It is not that the ideomotor groups themselves directly enter into the structure of fallacious perception, but they often may determine which of the remote secondary sensory groups should be stimulated to activity. Groups of elements are more easily brought into active functioning, the greater the activity of the elements with which they are associated, the course of group excitation being, so to say, in the direction of least resistance. Pathological processes going on in one sense organ may sometimes give rise to secondary sensory elements belonging to other sense organs, especially when favored by general states of dissociation. In fact, we may say that from our point of view a state of dissociation is an indispensable condition to the formation of hallucination. The following cases may be taken as clear typical instances. In none of the cases the patient saw spirits and regarded them as ghosts of her deceased daughters. On examination her eyes were found to be normal in all respects. The patient saw the spirits even when her eyes were shut, and furthermore the hallucinations were not in the least affected even when her eyes were injected with atropine. When, however, the ears were examined, a pathological process of old standing was discovered. Now when auditory stimuli were applied to the ear, the Hallu 162 diagnosis of psychopathic diseases sinations were at once strongly affected, the spirits multiplied in number. This increase of spirits ceased as soon as the auditory stimuli were removed. A closer examination revealed the fact that the patient was greatly affected by the loss of a daughter. The pathological process served as the stimulus, while the excitability of the ideomotor systems along with the general state of dissociation determined the nervous processes, initiated in the ear in the direction of the sensory visual systems and gave rise to secondary sensory elements, formed in the hallucinatory perceptive ghosts and spirits resembling the patient's daughter. The oral pathological process itself remained in the background of consciousness and was unknown to the patient. A similar case is that of a paranoiac who had visual hallucinations of spirits, hobgoblins, and saints. The organs of sight and hearing were found normal, but a pathological state was found in his scalp, especially in the sensibility of the muscles of the neck. An inclination of his head in any direction caused him to see the spirits and hear their voices. In another case of mine, definite auditory stimuli, such as the singing of birds, brought about hypnoidic states which are really complex states of hallucinations. In another case, in a female paranoiac with clearly defined auditory hallucinations, a similar state was revealed. The patient heard voices not through the ear, but through a spot located just over the region of the fallopian tubes. Examination of the spot revealed tenderness and painfulness to pressure. The hallucinations, which were of a sexual character, became exacerbated during the menstrual period. Similarly, in another case under investigation, the hallucination and perception 163 auditory hallucinations were shown to be intimately connected with phenomena of unconscious phonation and with frequent earaches, with a limitation of the field of vision due to an error of refraction which, when corrected by eye glasses, modified the auditory hallucinations, the latter finally becoming dissolved. More cases of similar nature could be adduced, but the ones referred to are sufficient, and extreme as they are, they bring out clearly the secondary reflex character of hallucinations. Hallucinations are essentially secondary percepts. Hallucinations are frequently due to peripheral processes, pathological or otherwise, occurring under conditions of dissociation, within the same sense organ, but the reflex hallucinations originating in other sense organs bring more clearly to light the secondary nature of hallucinations. The contention generally maintained that there are hallucinations independent of peripheral sources, or hallucinations of purely central origin which some even regard as supernormal experiences is highly dubious. As far as directly observed facts go, whether they be normal or abnormal, there is little to justify the central point of view. Like percepts, hallucinations are peripheral in character, and are only insofar central as peripherally initiated secondary sensations are concerned. Hallucinations are of peripheral origin, and may be regarded as complex cases of secondary sensations with the original primary sensation dissociated from or left in the background of consciousness. If, however, hallucination is abnormal perception, perception is normal hallucination. If a hallucination is a secondary compound with the primary sensations absent, a percept, insofar as it consists of secondary 164 diagnosis of psychopathic diseases sensory elements, is a hallucination with the primary sensations present. Normal perception, illusion and hallucination have the same underlying process and as such may be arranged in a continuous series, according to presence or absence of the primary sensory elements. Chapter Hallucination, 16 Dissociation, and Dreams process often of a perif nature a state of dissociation and a logical sub-excitement of secondary sensory and ideomotor elements constitute the main conditions of hallucinations. The peripheral pathological process and the state of dissociation are requisite to the formation of the hallucinatory percept, while the content of such percepts is given by the systems of sensorimotor and ideomotor elements. A peripheral process alone, even if it be pathological in character, does not give rise to hallucinations. Similarly, a state of dissociation by itself or a state of sub-excitement of secondary and representative elements cannot give rise to hallucinations. It is only when these conditions cooperate, it is only then that hallucinations arise. The state of dissociation and that of sub-excitement of central systems may be regarded as the central conditions of hallucinations, while the peripheral process is the factor that supplies to the systems the primary, sensory, nuclear elements round which the secondary elements crystallize and form a hallucination. States of dissociation, provided the other conditions are present, are preeminently favorable to the formation of hallucinatory percepts. In sleep, when the mind is immersed in darkness, isolated isles of systems may stand out of this general night of consciousness and give rise to dreams of various degrees of intensity. 166 Diagnosis of psychopathic diseases / dreams are sleep hallucinations, while hallucinations are waking dreams. Both hallucinations and dreams develop under the same conditions of dissociation. The nature of dreams and hallucinations is essentially the same. An isolated dissociated system of secondary sensory and representative elements predisposed to function becomes awakened by a special peripheral stimulus or by a summation of series of stimulations, and gives rise to hallucinations or dreams, according to the general state of consciousness, waking or sleeping. This process can be clearly traced in all hypnagogic and hypnapagogic dream hallucinations. The hallucination of the comparatively waking state stands out alone, it remains more or less isolated and becomes obliterated by the general inrushing flood of peripheral sensations and perceptions of the waking consciousness. The dream is made up of a series of hallucinations going sometimes to form a complicated hallucination, expanded into a whole life history. From this standpoint we may say that a hallucination is an abbreviated dream, while a dream is an expanded hallucination. In sleep, the primary sensory nucleus of the dream hallucination is supplied by the peripheral processes coming either from external stimuli or from internal stimulations, from changes taking place in the organism. The psychophysiological threshold is raised in sleep, the resistance to the entrance of sense impressions is increased, the rise being proportionate to the depth of the sleep state. The peripheral sensory channels are closed to external stimulations. External stimuli, however, assail the peripheral sense organs from all sides and now and then, whether on AC hallucination, dissociation, and dreams 167 count of the intensity of the stimulus or of the summation of a series of stimulations or of the temporary rise of the sleep level and consequent fall of the threshold and decrease of resistance to the influence of external stimuli. Sense impressions force an entrance and awaken to activity some slightly slumbering systems, thus giving rise to the dream hallucination. Under such conditions the sense impressions have but small chance to awaken their appropriate systems, and hence they become incorporated into systems with the lowest psychophysiological threshold, thus giving rise to the fantastic combinations characteristic of dream life. Sense impressions form the nucleus around which cluster systems of secondary sensations and representations, all tinged with the sensory color derived from the original primary, nuclear sensory elements. The systems of secondary sensory and representative elements once awakened may go on expanding and developing, awakening other groups and systems, assimilating them or being assimilated by them as much as the nature of their content permits and being further reinforced by incoming stimulations. During the whole course of its expansion the aroused groups and systems maintain their sensory or rather their perceptual character. For, if a system is once awakened to activity, the threshold, the resistance to incoming stimulations is lowered, and many more sense impressions gain access to the functioning systems and become incorporated and assimilated. This assimilation of chance systems and sense impressions * recent speculations about the interpretation and meaning of dreams are unscientific, arbitrary, and meaningless. The Traumdeutung is nothing but a play on words, an ingenious play of Talmudic, Kabbalistic puerility and childish scholasticism. 168 Diagnosis of psychopathic diseases often gives birth to highly elaborated fantastic dreams and visions. Systems awakened by stimuli must have some relation of familiarity to the nuclear sense impressions. If perception is to take place, there must be some congruence between the sense impressions and the stimulated systems. Only on such conditions can assimilation take place. Similarly, the awakened systems in sleep assimilate congruent sense impressions, the latter becoming so transformed as to fit the system, and the system is modified by the incoming impressions. This congruence in the dream state is often strained and remote and consequently often of a fantastic and irrelevant character. Thus the taking off a plaster may give rise to a dream of being skinned alive, or of being scalped by an Indian. A change to an easier position and a freer respiration may generate a dream of flying. In one of my experiments of dream hallucination, the uncovering of the feet in a cold room gave rise to the dream of walking on the frozen surface of a river, the impeded respiration awakening the feeling of fear of falling into the water. In a great number of experiments and dreams carried on by me for years, I have been enabled to trace dreams to sensory changes and stimulations. The internal sensations such as arise from the different functions of the bodily organs are important factors in the generation of dream hallucinations. Everyone knows the fact that indigestion often gives rise to nightmares and unpleasant dreams, but not many realize the fact that co-anesthetic sensations, sensations that come from our internal organs, play an important role in the production of dream hallucination, dissociation, and dreams 169 tions. The circulation of the blood, the secretion of the various glands, the peristaltic movement of the small intestines, the action of the stomach, the changes in the muscles, the metabolism going on in the various organs of the body, in the cells of the organism, all these give rise to sensations which, though obscure and confused, go to make up the general sense of organic life activity. This sense of kinesthesis may, in fact, be regarded as the basis of our physical being or of our physical personality. A change of this sense is frequently an important factor in the formation of delusions, when mental life becomes dissociated and disaggregated. Hypoesthesia or anesthesia of the leg, for instance, may form the nucleus for the formation of the delusion that the leg is made of glass or of putty or is totally gone. Anesthesia of the body or of the internal organs may develop the delusion of being dead, the patient asking to be buried. Similar conditions are also present in dream life. Toxic and antitoxic material, accumulation of waste products, various drugs, gases and injections of various poisons have in my experiments given rise to hallucinatory dream states. Affection of special organs have given rise to nightmares. Changes of co-anesthesis play no doubt an important role in the activity of the dream consciousness. Changes in the various component elements that go to make up the obscure but highly in another work I shall take up the study of the dream consciousness more in detail. Meanwhile I must strongly protest against the flood of psychoanalytic literature about the supposed psychology of dreams. Psychoanalysis in general and psychoanalysis of dreams in particular display not only arrogance of the ignorant parvenu in psychology, but also manifest a total incapacity of comprehension of psychological problems. 170 Diagnosis of psychopathic diseases. Plex life of organic sensibility affect profoundly the rich exuberant play of the dream consciousness. Since the channels to external stimulations are closed, the co-anesthetic sensations that form the obscure basis of waking consciousness become the sole possessors and guides of whatever mental activity is present in sleep. These internal sensations are woven by the dream consciousness into fantastic images of all shapes and forms. The dream consciousness presents many characteristics found in states of mental dissociation and disintegration. Moral tone is lowered, attention is greatly reduced, logical thought is enfeebled and the sensorimotor and ideomotor elements are thrown out of gear, often resulting in the formation of illusions, hallucinations, and delusions. In the dream state there is present the mental degradation of dementia, the sordid delusions of hypochondria and melancholia, the delirious states of mania, the delusions of grandeur of general paralysis, and even the persistent systematized delusions of paranoia. The dream consciousness is extremely unstable, it forms no definite type of mental disintegration and has no determinate course, it is extremely fluctuating in its states, and its background is usually shifting ceaselessly. From this standpoint it may be said that the dream consciousness is a normal form of mental alienation and that mental alienation is an abnormal form of dream consciousness. A very characteristic diary brought to my notice in which a retrospective and introspective account is given by a patient in the normal condition of the experiences lived through in the state of mental hallucination, dissociation, and dreams. 171 Aberration opens with the suggestive title, Memories of My Dream Life, and with the following interesting introductory remarks: where shall I commence? How shall I begin to recall and record this to me mysterious life I have been living? So beautiful, so strange, and in some way so terrible. Yet I would not forget, for it seems as though I must have been in communication with intelligences above, Spirits of the air, if it were possible. When did it commence? How long has it been with me? Are questions I cannot solve. For weeks before coming to the hospital I must have been living this ideal life as in an ideal world. I have jotted down what I have thought, though they are not 1/100th part of the thoughts which passed through my mind during this strange time of dreaming. In my cases of catatonia, the frightful dreams of the year preceding the disease became hallucinations of the maniacal stages, and appeared again as dreams during convalescence. The dreamer dreams with his eyes closed, the insane dream with their eyes open. In both the dreamers and the insane, the disaggregated states under the influence of external and especially of internal stimuli give rise to illusions, hallucinations and delusions. Dissociated states grouped round nuclei of primary sensations form the internal organizations of hallucinations and delusions so often characteristic of dream life and insanity. Co-anesthetic sensations are important agents in the formation of insane delusions and hallucinations. They are so many fermentation nuclei among masses of dissociated states. Irritation of the genitalia may in the insane awaken hallucinations, and the 172 diagnosis of psychopathic diseases illusions of a sexual character. Constipation and heaviness in the intestinal tract may generate delusions and hallucinations of rats and pigs in the stomach. Rumbling in the stomach and the intestines may give rise to the delusions and hallucinations of devils in the body or of electric discharges of powerful batteries placed in the abdomen. The difference between the waking life of the insane and that of dream consciousness is the mode of activity. The dream consciousness works in images, in secondary sensory percepts, while in the insane mind the activity is largely representative. This difference is due to greater dissociation present in dream consciousness. The awakened dissociated systems in dream life become tinged with a perceptual sensory color by the process of absorption and assimilation of all the incoming sense impressions. Pathological states of rapid mental dissociation, such as the acute states of maniacal excitement, or in states of psychopathic functional dissociation, such as the damatustandi of psychic epilepsy and other states of functional psychosis, closely approximate to the condition of dream consciousness, though the former are more stable and far more consistent, being narrowed to the active functioning of definite mental systems, conditions rarely to be met with in dream states. The dream consciousness lacks unity of logical thought, certainly fails in critical judgment, and is sometimes indifferent to immoral situations and acts. The credulity of dream consciousness is well known to every active dreamer. Changes of time, place, and of objects are often instantaneous, and the most incongruent situations as well as transformations of personality, hallucination, dissociation, and dreams 173 are placidly and credulously accepted. The dream consciousness entirely is at the mercy of incoming sense impressions which spin the dream experience regardless of truth and reality and steadiness of logical purpose and moral ideals of the race. From this standpoint it may be claimed that the dream consciousness is to some extent a reversion to the earliest forms of mental life, when the race was as yet undisciplined by the accumulated experience of ages of social life. The teleological aspect of the dream consciousness may possibly lie in the fact suggested by some that the many trains of thought started in the activity of waking consciousness and arrested by the selective thought and logic of things and events of waking life find their vent and completion in the activity of dream consciousness. This vent relieves us from the high pressure of suppressed thought and makes it easier to sustain the rigid selection of sequences of mental states required by the struggle of existence and social life in our adjustments to the conditions of external environment. This view, however, is not correct. For the dream consciousness follows not only along the lines of thoughts started in waking life, but more often forms new lines of associations, giving rise to highly dramatic situations bearing no relation whatever to the interests of waking life, and far from relieving waking thought impedes and depresses it, since the mind feels unrefreshed by the sleep, and in many cases serious mental troubles arise, due to the disturbing influence of active dreams on the course of waking thought. It is more likely that there is little teleology to dream life, and if any teleology there be, it may consist in the freedom and ease in which the mind finds itself in the 174 diagnosis of psychopathic diseases dream state, fettered as the mind is by the rigid relations of the external environment. In dream life the routine of waking life is interrupted and new associations are formed. This possibility of forming new associations and thus breaking through the routine of life, a possibility maintained and fostered by the dream consciousness, might have possibly proved of some consequence to the human race. The dream consciousness may thus be regarded as an important factor in the progress of human thought, as an agent in the breaking up of habits of thought, due to the routine of life, calling the attention of man, absorbed as he is with the interests and requirements of the needs of his physical world, to another life existence and strange universe of reality. It is out of the activity of dream consciousness that the concept of an independent spiritual life has developed. In sleep and dreams man breaks away from the bondage of the interests of this world. Chapter Hallucination, F17 Dreams, and Reality. He sense of reality and the belief in the external existence of the hallucinatory objects are quite strong in hallucinations and in some of the more vivid and intense dream states. In order to explain this seemingly anomalous sense of reality, it may be well to revert to our general principle of subsuming both the normal and the abnormal under the same general laws and processes. Although the abnormal is of the highest importance in revealing new relations which the customary and habitual normal seems to hide, as found, for instance, in the growth and development of physiology, largely due to pathological research, still we must clearly remember that from a strictly scientific standpoint the normal and abnormal are but teleological concepts which are of importance for the practical purposes of our habitual life activity and possibly for classification of various types of phenomena, but which science is to reduce to the same laws and processes. The abnormal is the normal out of place. In mental life as in the phenomena of life in general, the atypical, or the variation, helps to explain the typical, the normal, and the latter in its turn explains the atypical, the abnormal. We may therefore turn to the criterion of the normal sense of reality and validity of 15 experience as explaining the 7 same relations in abnormal mental life, and the latter in its turn may throw light on 176 diagnosis of psychopathic diseases, the reality and validity of normal experience. A brief review will suffice for our purpose. It may look as if we attempt to make an excursion into a domain not belonging to normal or abnormal psychology proper, but to epistemology. This may be so, but the nature of our subject brings us so closely to this problem that a brief discussion may help us to see the facts in a clearer light. Abnormal psychology, with its various forms of mental aberration, such as are to be found in the phenomena of insanity, functional psychosis, hallucination, delusion, somnambulic states, hypnoidic states, is so intimately connected with aberrations of the sense of reality and validity of experience that not only the abnormal psychologist, but also the clinician must take it into account from a purely practical standpoint. We shall view the problem only insofar as it directly concerns and illustrates the general subject of our discussion, namely hallucination and illusion, or fallacious perception. The objective reality of the physical world is sometimes defined, and apparently with best of reasons, as social experience, as experience common to ourselves and our fellow men, as experience which men share in common. This view, however, of external reality seems in contradistinction to the psychic experience, which is essentially of an individual character. The tree yonder can be seen by everyone who possesses eyes, but my perception of the tree, or my idea of it, can only be experienced by myself. It may be said that this difference between the physical object and psychic state is a valid and valuable one. It is, however, neither general enough, nor specific enough. For on the one hand it may be claimed that from a hallucination, dreams, and reality 177 more general philosophical standpoint even the physical object belongs ultimately to the individual only, and on the other hand, it may be claimed that psychic experience is communicated to our fellow men not only in terms of the physical object, but far more often in terms drawn directly from our mental life. Neither the physicist nor the psychologist will be quite satisfied with this point of view, as both physical objects and psychic objects are entirely emptied of their specific contents and must remain at best in the dubious regions of epistemology. Still, this social aspect of the physical object is significant and valid, and is even used by the psychiatric clinician as a practical standard in the valuation of abnormal mental life in general and of insanity in particular. It may, therefore, be of value even if we do not agree with the extreme way in which this view is sometimes put. It is true that at the first glance we cannot help being struck by the import of the common or social aspect of external reality. We are well assured of the existence and presence of an external object, if we have the assurance of our fellow beings, and what is accepted by our fellow men assumes the dignity and authority of actuality. A fact is regarded as existing beyond the shadow of any dispute, if everyone can verify it in his own experience. The categorical necessity of our modern science rests entirely on this principle of validity: the social object is the valid object. This criterion of validity of the external object stands out specially clear and distinct in our standard of abnormal mental life. A belief is regarded as insane and delusional if it is in opposition to social beliefs and X178 diagnosis of psychopathic diseases periods, and is emphatically rejected by all other men. An object is regarded as illusory or hallucinatory if it is treated as non-existent by other people. A desire, an action is considered immoral if it is spurned by our neighbors. The real object is the social object. The valid belief is the social belief, and the social will is the moral will. The individual object, the individual belief, the individual will are treated as insane. One cannot help noticing the semblance of truth in the assertions of those pathological anthropologists who put genius in the same category with insanity. What is social is alone true, valid and real; the individual is false, non-existent. The individual can buy the reality and truth of his being on condition of becoming social. Sociality is verity. Let us now, however, try to break through, if for a moment only, the traditions of social regime with its criteria of social reality and validity. When being pricked or getting a blow, or when cut or scratched, along with the experience of the sensation, the experience of the external stimulus is also given. In looking out of the window and seeing the tree with its green leaves moving in the wind, along with the perception of sensory elements, primary and secondary, the external existence of the object tree is also given. Similarly, in listening to the sounds of a familiar and dear voice and listening to the words as they form into phrases and sentences is not the sense of reality of the external object given along with the series of sound sensations. Sensation carries along with it the sense, the reality of its stimulus. It is not that the sense of reality is different from the sensation, it is given in the sensation itself. Similarly, the percept and the sense of reality of the hallucination, dreams, and reality 179 external object are not two different things, they are given together in the same process of perception and are identical. The percept tree is the perception of the reality of the objective tree yonder. The sensory process is also the process of the sense of reality. As Spinoza puts it in his Ethics, if the human body is affected in a manner which involves the nature of any external body, the human mind will regard the said external body as actually existing. In seeing or perceiving the chair yonder, we do not perceive it as real, because of its social or common aspect. The reality of its existence is given directly in the sensory processes of the percept itself. Sensory elements involve the reality and existence of their stimuli. The percept involves the existence of the perceived objective content. The sense of reality of the external stimulus or object is strengthened by association of the original sensory systems with other sensory systems, and the intensity rises in proportion to the number of systems of sensory elements, brought into relation with the functioning sensory system. If on perceiving an object, we wish still further to assure ourselves of its reality, we verify it by means of other sense organs. If one sees an apple and wishes still further to assure himself of the real presence of the object, he goes to it and examines it with his other sense organs. He touches it, presses it, bites it, tastes it. Kinesthetic elements, being the most important in adaptations and reactions to the stimuli coming from the external environment, are possibly of all sensory elements the ones that give the keenest and most intense form of sense reality. Facts warrant us to assert with some show of probability that the sense of reality diagnosis of psychopathic diseases is chiefly centered in the sensory-motor or kinesthetic elements which serve as nuclei for other sensory elements. Whether this be correct or not, it remains true that the sense of reality is given directly by sensory elements and their combinations and organizations. The more systems of sensory elements are pressed into service, the stronger is the sense of reality and the more assured is the reaction to the stimuli of the external environment. In the evolutionary process of man's adaptation to his environment, he becomes extended in being and grows more developed, because of his social relations with other men. Man presses into active service the systems of sensory elements of his fellow beings. Adaptations and hence successful reactions to the external environment are now more assured, and the sense of reality is still further emphasized and intensified. Throughout the course of intensification of the sense of reality, the principle remains unchanged in nature. The sense of reality is given by and consists in nothing else but the sensory elements. Social experience may be regarded as more real or as giving a more intense sense of reality, because of the greater number of sensory systems involved, but an object is not felt as external and real, because of its social aspect merely. The sensory aspect is by far the more fundamental. If one's perception of the house yonder is of a purely individual character, not shared by his fellow men and even emphatically denied by them, the visual perception, as such, still directly perceives it as real, external, and physical. Should furthermore this experience be intensified or hallucination, dreams, and reality 181 confirmed by all the other senses, should he be able to touch it, to press it and feel its resistance, knock against it and feel concussion and pain, and have a series of tactile and muscular sensations by walking into the perceived house and around it, and should he further have this purely individual experience of all the senses each time he comes to the same spot, the perceived object would then be a real, external, physical object, and no amount of social contradiction and lack of the earmarks of community could make it less real, objective, and physical. Epistemologically regarded, community may be sufficient for the purpose of reality. Psychologically regarded, the real, existent physical object is essentially the perceived sensory object given by the community of sensory elements. Sensory elements give the objective reals. From this digression we may turn again to the question, What is it that makes hallucinations in general and dream hallucinations in particular appear real, objective? The solution is given in the question itself. We have shown in our analysis that hallucinations are essentially peripheral and sensory in character and do not differ in their makeup from sensation and perception in general, which furnish the very foundations of our sense of reality. Hence hallucinations are real and objective, because of the constituent sensory elements. Strictly psychologically considered, percepts do not differ from hallucinations as far as process is concerned. Normal percepts differ from hallucinations mainly by the fact that the former are the habitual, the customary, confirmed by other systems of sensory elements, and that in the struggle for life, they proved the fittest to 182 diagnosis of psychopathic diseases call forth the best adapted reaction. Dream hallucinations, like hallucinations in general, are initiated by peripheral stimulations. Even the so-called central hallucinations are really peripheral in origin, the dream hallucinations naturally falling under the same category. The entrance of external peripheral stimulations being difficult in proportion to the depth of sleep and extent of hallucinatory dissociation, the internal sensations predominate in the functioning systems of dream life. For in sleep the activity of the internal organs, though depressed, still goes on uninterruptedly, the glands continue their function of secretion and excretion, the heart continues to contract and dilate, the blood goes on circulating through arteries and veins, the liver, the spleen, the stomach, the intestines, the lungs and other organs carry on their functions without a moment's arrest, the whole sympathetic nervous system, the vasomotor, the spinal cord, the medulla and other basal ganglia, all, contributing to the vast mass of internal sensations, can hardly be regarded as being asleep. All these peripheral internal sensations go to form nuclei of primary sensations around which secondary sensory elements become crystallized and organized, and give rise to hallucinatory percepts, to dreams. To these must be added the external peripheral sensations coming from touch and pressure of bedclothes, from changes in the muscles, joints, ligaments, and synovial surfaces, from changes in the superficial temperature of the extremities, from chemical changes in the olfactory and gustatory organs, from summation of minimal acoustic stimulations, and above all from changes in the visual apparatus, and especially from the masses of light in the retina and macula lutea. Hallucination, dreams, and reality 183. With the obscuration and dissociation of the mind, the internal sensations along with the external peripheral minimal sensations come to the foreground of mental life. The dreaming consciousness stands in closer relation to the bodily functions than the waking consciousness, absorbed as the latter is with the intense stimulations coming from the external environment. The intense, external, peripheral sensations of waking consciousness obscures the weaker, but more constant internal sensations, as Hobbes puts it, much as the light of the sun obscureth the light of the stars. This intimate relation between internal sensations and dreams was clearly seen and pointed out by Aristotle, for the movements which occur in the daytime, within the body, are, unless very great and violent, lost sight of in contrast with the waking movements, which are more impressive. In sleep the opposite takes place, for then even trifling movements seem considerable. Similarly Hobbes says, and because the brain and nerves, which are the necessary organs of sense, are so benumbed in sleep as not easily to be moved by the action of external objects, there can happen in sleep no imagination and therefore no dream, but what proceeds from the agitation of the inward parts of man's body, which inward parts for the connection they have with the brain and other organs, when they be distempered, do keep the same in motion. Dreams sometimes reveal in fantastic and grotesque images the conditions of bodily function, conditions which the waking consciousness cannot detect, because they lie in the subconsciousness and cannot overstep the threshold of waking consciousness. It is here in the deeper regions of co-anesthesis that we have to look for 184 diagnosis of psychopathic diseases, those prophetic dreams which seem to foretell some future event, some future state of the organism. An incipient irritation of the nerve endings in the teeth, an irritation not yet felt in the waking consciousness, may become the nucleus of a dream and give rise to a dramatic vision of sitting in a dentist's chair and being operated upon, a prevision that may actually become fulfilled soon after. Incipient organic affections, not yet felt in the waking consciousness, may become the starting point of a highly dramatic prophetic dream. Dreams of such a veridical character often appear highly mysterious, and their fulfilled prophecy seems nothing short of the miraculous and supernatural. There are many such cases on record, but the following may be regarded as typical. A lady, a relative of mine, had a vivid vision which proved veridical and seemingly could only be accounted for on supernatural grounds. One evening, on being left in a room all alone, she suddenly saw the apparitions of her deceased parents. The lady became much frightened, but the parents quieted her and told her not to be afraid, as they came to bring her good tidings. "You will give birth to twins, a girl and boy, name them after us, they will be strong and healthy." With this the apparitions vanished. The lady became greatly agitated and, although she did not suspect to become a mother, still, being religious and a firm believer in spirits, she had implicit faith in the actual presence of her parents, who appeared to her in order to bring her glad tidings from another world, and naturally she even began to prepare clothes for the promised twins. As this happened in a remote country place, the news of this hallucination, dreams, and reality 185 vision soon circulated among all the neighbors, and expectations were aroused as to the fulfillment of the prophecy. It soon became apparent that at least a portion of the prophecy was being fulfilled. The lady soon discovered that she was going to become a mother. The skeptics were somewhat confused, still they maintained their front, but they were completely silenced when after a few months the lady gave birth to twins, and that a boy and girl. The vision then did prove to be of supernatural origin. If, however, we analyze the vision somewhat more closely, we find that it can easily be resolved into elements which admit of a perfectly natural explanation. The vision first of all occurred during the state of repose and was really a dream hallucination. Still, this does not explain the fact that the hallucination appeared in such a dramatic form which turned out to be so strikingly prophetic. On further examination of the lady's history, it was found that she lost both her parents but a few months before the occurrence of the hallucination, and that this loss deeply affected her. This mental system was an important factor in shaping the course and development of the hallucination. At the same time, there was another factor at work in the elaboration of the dramatically effective dream hallucination. The lady, before she gave birth to the twins, was already a mother of 14 children. It is quite possible that, although in her waking state she did not suspect of being pregnant, still in her dream state, being cut off from the intense external stimulations, she could more easily realize her condition from symptoms and changes in the internal organic sensations which now alone regned 186 diagnosis of psychopathic diseases in the dream consciousness. These symptoms and changes in the organic sensations during the incipient stages of pregnancy could all the more be easily appreciated by the lady, as she had ample experience of them before. Some special changes in the organic sensations, such as the arrest of the menses, changes in the circulation, in the metabolism of the generative organs, and other changes of similar nature, served as so many peripheral stimulations which, in states of dissociation, such as occur in the light states of sleep, favored the occurrence of a dream hallucination that took the form of apparitions of the deceased parents, because of the sub-excitement of this particular system, and because for the time being, the system played a dominant role in consciousness. Moreover, The organic changes differed greatly from the previous experiences of similar kind, and it was therefore quite natural that the dreaming consciousness should suspect the coming of twins, a circumstance which connected itself all the more closely with the formation of the dream and was no doubt a factor in the determination of the appearance of the apparitions of the parents, which in turn helped her further to confirm the intuition that she was to be a mother of twins. All this was represented in that vivid way characteristic of dissociated states in general. Another theory, based on subconscious wishes, symbolism, and on a fancifully elaborate mechanism of condensation, displacement, dramatization, and secondary elaboration, finally reduces dreams to the sexual wish, dating as far back as the sexual or bisexual life, as the school terms it, of early childhood and infancy. Of course, this theory is not psychological, but rather teleological and metaphysical, inasmuch as the whole of psychic life activity is reduced to wish and desire, of which the sexual instinct is supposed to play the sole role. There is the manifest content of the dream, which is directly given hallucination, dreams, and reality 187 by the dream, and the latent content which underlines the dream activity. The four factors of the dream activity distort the dream so that the latent content cannot be recognized in the manifest content. This distortion is done by the censor who, for the protection or self-defense of the person, does not permit the subconscious latent content to come forward in dream. As I shall discuss dreams more in detail in my forthcoming volume on the causation of mental diseases, I limit myself here with a few remarks on the subject. The psychoanalytic theory is unpsychological and arbitrary, as it introduces a process of symbolism which by sufficient distortion and suggestion leads the whole investigation astray and puts it on the same basis with the one erology of ancient times and the Middle Ages. Professor William James, whose introspective powers no one can call in question, in speaking to me about this theory told me that he could not find anything of this kind claimed by the theory in his own dream experience. I myself have dealt with dream experiences in my own case as well as in the case of subjects and most of my patients for about 15 years at least, and I could not find anything that should in the least substantiate this fanciful theory of what may be termed symbolic psychology. There is no doubt that with sufficient distortion, twisting and suggestion one can get anything out of a dream. By a series of associations and suggestions long continued, aided by ingenious symbolic interpretation, there is no difficulty in arriving at sexual complexes and then fix the subject's or patient's attention on them. T is the easiest thing to do with suggestible people. I may add the view dream symbolism is understood psychological fallacy. That fallacy is the confusion of what is by symbolism with the associative activity of the dream consciousness. Thus one writer tells us there is no doubt of the presence of symbolism in dreams. When we hear in our sleep the singing of birds, we may dream of hearing an orchestra. Now an orchestra is not at all a symbol of birds. A symbol is the use of a certain definite image indicating the essence and meaning of a complicated psychic activity coming from another sphere of mental life. Even the psychoanalytic enthusiasts would hardly regard the above example as one of symbolism. Still, fundamentally there is the same fallacy present in all the works on psychoanalysis, and, that is, the identification and confusion of the associative image activity characteristic of the dream consciousness with the widely different mental activity of symbolization, which is essentially universal and abstract, and utilizes the object or the percept as the embodiment of its highly abstract meaning. Chapter 18: The vividness of hallucinations and dreams of dissociation, light sleep, and especially lies the intermediary states occurring in the course of falling into deep sleep or coming out of it are favorable to the formation of hallucinations. Such conditions occur in abnormal mental states, in hypnoidal and hypnosis, in somnambulism, noidic states, in the so-called psychic equivalents of epilepsy, in pure psychic epilepsy, and, generally, in states of functional psychosis. In the intermediary states between waking and sleeping, dissociated systems awake and become accessible to the influence of external stimuli. This is clearly shown in the hypnagogic hallucinations, as well as in the frequent dreams often taking place in the lighter sleep states usually before waking. I have often observed in myself, when being fatigued and becoming drowsy and closing my eyes, how fast phantoms and scenes flit before the mental gaze, most of them being formed by the flitting masses of light in the field of vision. Often in closing my eyes and keeping quiet, so as to become somewhat drowsy, and watching the field of vision, not directly, but, so to say, from the corner of the eye, animals, figures, faces, can be seen forming and dissolving into mist. These have an important influence in the guidance of the mental content of the dream consciousness. These dream phantoms can be directly traced to 188 the vividness of hallucinations and dreams, 189 specks of light and masses of color, coming from the retina and especially from the macula lutea. In many psychopathic cases, not only vision, but sounds and voices are experienced, as in some of my cases that have hypnagogic hallucinations of voices. The dimly lighted up regions that lie on the borderland of sleep and waking states are peopled with phantoms, ghosts, and apparitions. Statistics seem to confirm this point of view, since about 50% of cases of hallucinations may be classed as borderland hallucinations. Some recent critics in this field of inquiry strongly favor the view that hallucinations occur in dream states, hallucinations being but vivid dreams, the percipient not being conscious of having fallen asleep. This view is not new, it is favored by Hobbes. The most difficult discerning, Hobbes tells us, of a man's dream from his waking thoughts is then when by some accident we observe not that we have slept. Many cases no doubt admit of such an explanation. I myself had an experience of such a character. While sitting and studying one evening, I felt myself suddenly transported into my father's house and looking out of the window, seeing the scenery characteristic of the locality and hearing the voices of my parents in the next room, but I could discriminate the words. The vision was so real that I was surprised to find myself again at my book and in a place hundreds of miles away from home whither my hallucinatory state had so suddenly transported me. The hallucination was so strong and real that had I not critically analyzed the conditions of its occurrence I should have been fully certain that the hallucination appeared. 190 Diagnosis of psychopathic diseases in the waking state. As a matter of fact, I was fatigued from my studies and dropped off. The actual surroundings, the room, the table, the book, the voices of my friends present, all disappeared from my view during the intermediary state, and when I came out of it I gave a start in realizing once more the actual situation. According to records, hallucinations take place when the percipient is in bed, just after retiring, or about to wake up, or after waking. The percipient is really asleep, only he is not aware of it, so brief is the state and so intense and vivid is the hallucination. It may, therefore, be maintained with some show of truth that hallucinations are dreams and take place in sleep states. We must guard, however, against carrying a generalization too far. This contention that hallucinations occur in dissociated dream states is somewhat overstated. It is true that hallucinations require states of dissociation, but this does not necessarily mean sleep states. Not all states of dissociation are dream states taking place in sleep, although it may be safely asserted that all dissociative states have many traits in common and are at bottom of the same nature. Hallucinations and dreams may be analogous, may be of the same structure requiring the same general conditions, but it does not for that reason follow that they occur in the same states, in sleep states. Dissociation with consequent hallucinations may also take place in waking states. Those who have studied hallucinations in different forms of mental diseases know that most of the hallucinations occur under widely different conditions, and they further know that it is the vividness of hallucinations and dreams 191 precisely in the waking states that hallucinations are most commonly present, while in the sleeping states they are more frequently absent. Insanity may be compared with dream states, but they are by no means identical. The important condition requisite for the occurrence of hallucination is dissociation, and this condition often occurs in waking states, such as the hallucinations found in many forms of insanity, as for instance paranoia, hebephrenia, catatonia, general paralysis and other states of mental aberration. Even hypnotic and post-hypnotic hallucinations can hardly be claimed to have been really induced. In dream states, they who have devoted time and labor to hypnosis know that the hypnotic state can by no means be identified with sleep, and that in the very deepest stages of hypnosis the subject is to all intents and purposes fully awake, he is full of activity, his eyes are open, his senses are on the alert. He is far more awake to external stimuli than even in his normal state. The mind is active and the subject carries on long trains of reasoning, argumentations and discussions with the people around him. In short, the subject in the deep somnambulic state is in a condition the very opposite from that of the sleeping state. Hallucinations occur both in the waking and sleeping states and require dissociation as an indispensable condition. If we inspect more closely the relation of the stimulus to the hallucination, especially to the dream hallucination, we find that the intensity of the content is disproportionate to the intensity of the initiating stimulus, to the peripheral sense impression. A comparatively slight stimulation often gives rise to a dream 192 diagnosis of psychopathic diseases of a highly dramatic character. This exaggerated character of the dream hallucination is well known. Thus a prick of a pin may give rise to a dream of being attacked by robbers, and finally being run through by a thrust of a dagger. The application of a warm bottle to the feet may develop a dream of ascending a volcano and walking on molten lava, while a cold stimulus may give rise to a dream of participating in a dangerous expedition to the North Pole. Pain in the head, impeded respiration and pressure in the region of high neck may develop, as in the case of a friend of mine, the horrible dream of being dragged into a narrow dungeon and then beheaded. To explain this dream exaggeration, a theory is advanced based on dissociation. It is claimed by James that dissociation tends to convert the physiological ideational currents into sensory currents and thus intensify and exaggerate the psychic states. Before discussing the theory, it may not be amiss to examine the facts which the theory is called to explain. It is questionable whether the general relation of dream stimulus is quite correctly stated. It appears that the generalization is stated somewhat in the form of the well-known question, why do great rivers flow by great cities? It is by no means generally true that the characteristic of dream consciousness is to exaggerate stimuli received and work them up to a pitch so as to convert ideational into sensory currents. The relation is far simpler. The dream does not necessarily exaggerate incoming stimuli and make of them exciting and sensational dream hallucinations. What happens is this: the commonplace, non-exaggerated, unaffective the vividness of hallucinations and dreams 193 dreams tend to fade away almost immediately on waking, while the impressive dreams are usually remembered. I have observed a number of dreams in my own case as well as in others and have found that the number of ordinary commonplace dreams far predominates over the striking and extraordinary dreams. Even in psychopathic cases in which subconscious dream life is often well developed, Even in such states I have found in the cases which have been under my observation and experimentation that the commonplace dreams far predominate over the dramatic and extraordinary ones. The only way to convince oneself of it is to try to write down the dream immediately on waking. I find that the ordinary dream is hard to hold in memory, it is elusive and is constantly slipping away from us. A special effort of attention is requisite to hold on to it. It is usually hazy, vague, and confused. On the whole, the indifferent dreams really predominate, but it is only the impressive ones that remain in memory. Even the freshness and recency of the dreamy do not save it from falling into oblivion. Now, while commonplace and indifferent dreams are forgotten, older dreams, but more impressive, more awakening our emotions, especially emotions of fear, will be clearly and vividly remembered. Still, the fact that exaggeration and intensification of the sense impressions received by awakening a greater volume of secondary sensory elements and representations more often than in the waking state requires an explanation. This intensification is partly due to the fact that in sleep sensory impressions often enter consciousness suddenly. This brings about a shock. 194 Diagnosis of psychopathic diseases. Awakening emotions which are conducive to a stimulation of a greater volume of secondary sensory elements and their accompanying representations. Even in the normal waking state, sense impressions suddenly introduced into consciousness may cause a shock and give rise to an illusion, the object appearing as something strange and formidable. We can often observe it in ourselves. When falling into a drowsy condition, a slight stimulus which we otherwise ignore will give us a sudden start. I often observed in myself when in a drowsy state and dropping off how an ordinary stimulus, such as a cough, for instance, will produce a shock, affecting the visceral organs, the feeling being somewhat similar to the condition commonly described as a sinking sensation in the pit of the stomach. The shock seems to reverberate all through the organism. To this must be added another important factor, namely, the emotion aroused. When an object is perceived under conditions that do not permit its recognition or its assimilation and consequently its customary reaction, an emotion of fear is produced. Such is the case, for instance, when some objects impress us in the dark or when we get hold in the dark of some slimy, slippery, and especially of moving objects. These two factors often work together, inasmuch as an object suddenly introduced into consciousness is also not speedily assimilated, so that the shock and emotion due to non-recognition or non-assimilation go together. Now in sleep, stimuli entering into consciousness affect it in a sudden way, and from the very nature of the sleeping consciousness the external stimulation is but imperfectly assimilated. Both factors, the vividness of hallucinations and dreams. 195 Shock and emotion, due to non-assimilation, are present and sometimes give rise to a highly wrought-up emotional state which is so apt to transform objects by arousing different systems of elements and at the same time to impress the memory powerfully. It is claimed that the very fact of dissociation brings about an intensification of ideational states, converting them into sensory states. Physiologically, the assumption is made by James that the sensory nerve cells can be set into activity not only by peripheral stimuli, but also by central currents going from center to periphery. The sensory centers are like a bucket with water, the upsetting of the bucket being likened to the upsetting of the sensory centers, giving rise to sensations. This upsetting can be affected by peripheral currents. Small intracellular, ideational currents flow freely through the centers without upsetting them. Now when an obstruction occurs in the sensory centers, the ideational currents which otherwise flow out and disperse may accumulate, and aided by a chance activity of central character may upset the nerve cell in the same way as our bucket may be upset by the accumulation of water from the small incoming currents, like the ideational currents, when the holes and interstices through which they usually flow out are stopped up. The hypothesis, as far as explanation goes, is good enough. The drawback is that it explains too much. For it is hard to understand why intense dreams of this character do not occur more often. Besides, it is hard to realize how an idea can give rise to a sensation of any intensity by the mere agency of ideas, the sensation and its intensity being entirely a function of peripheral stimulation and consequent sense. 196 Diagnosis of psychopathic diseases. Impressions. An idea, a representation, may be very vivid, but does not become a presentation or sensation. A sensation is not an intense idea, nor is an idea a weak sensation. A series of sensations arranged in ascending or descending gradation of intensity may be likened to the continuous series of the spectrum in which there is a qualitative difference from line to line, a difference that admits of no substitution. A sensation the intensity of which is changed is a fallacious percept, an illusion. A thunderclap perceived as a whisper perceived as a thunderclap may be equally regarded as fallacious perception as any other change in the content of the percept. The rustling of leaves perceived as an explosion is as much of a fallacious perception as when the paranoiac, for instance, hears in it curses and threats of his enemies. Sensations and percepts cannot change in content or intensity without giving rise to illusions or hallucinations. The changes that may occur in regard to sensations and percepts, without their being qualitatively changed and becoming fallacious, can only be in vividness belonging to the representative elements which cluster round the primary and secondary sensory elements. A less intense sensation may be more vividly represented than one of greater intensity. A weak sound, a pale color, a light pain may be more vividly represented than the ones the intensity of which is far greater. This vividness, however, is not at all a characteristic attribute of the sensory elements, it is rather an attribute belonging to the functioning system of representative elements into which the given sensory elements, the vividness of hallucinations and dreams. 197 enter as constituent nuclei. Taking all this into consideration, we inevitably arrive at the conclusion that James' view of dreams is not psychologically valid. Chapter Vividness, Functional 19 Psychosis, Ancients hallucina as possible. We keeping to facts as closely may venture without much risk on the following generalization which may be regarded in the light of a working hypothesis. Just as sensory primary or secondary sensory elements vary in intensity and can be arranged in a continuous series of gradations of intensities, so do the representative elements vary in vividness and may be arranged in a consensory element's tenuous gradated series of vividness. Have intensity, but no vividness, while representative elements have vividness, but no intensity. Representative elements may refer to the same presentative content with different degrees of vividness. Vividness of representative elements, like intensity of sensory elements, may pass through all degrees of variation from maximum to minimum, and finally reach a vanishing point. In this respect, vividness is like sense intensity, and as a matter of fact the two are usually interrelated. Under ordinary conditions of psychic activity, sensory intensity and representative vividness vary together. An intense sensation is vividly represented and a weak sensation less so, the vividness varying directly with increase or decrease of sensory intensity. This direct variation, however, is not always constant. There are conditions under which the two may part company, such 198 Functional psychosis and hallucinations. 199 For instance, as are found in states of distraction or in states of dissociation. Under such conditions a strong stimulation giving rise to sensory elements of great intensity may awaken representative elements of but slight vividness. In states of distraction, as well as in various states of mental dissociation, Sensations of great intensity may meet with so little vividness in the representative elements as to fall below the threshold of consciousness. They may be submerged into the twilight region of the subconscious and not be perceived at all. From this standpoint we may say that the depth of dissociation varies inversely as the degree of vividness. When vividness is at its minimum, dissociation is at its maximum, and inversely. Briefly stated, dissociation and vividness are inversely interrelated variables. Functional psychosis, the basis of which is dissociation, may also psychologically be regarded, according to the gravity of the psychopathic affection, as a decrease or even loss of vividness of representative elements. The diminution or total loss of vividness may be of different systems of representative elements, and will thus give rise to various forms of psychopathic amnesias, which play such an important role in functional psychosis, which in the main is a disease of representative life, consisting in a decrease of functional activity of representative elements, and which from the present point of view may be regarded as the tendency towards a minimum of the most important attribute of ideational elements, namely, vividness. From this standpoint, the degree of vividness of ideational elements can no more confer on them sensory intensity than the idea of riches, however vivid, can contour diagnosis of psychopathic diseases confer upon one the power of wealth. Dream hallucinations, like hallucinations in general, are sensory in character, not because of the intensive nature of the central elements or ideas, but because of the primary and secondary sensory elements present, directly and indirectly peripherally initiated, as it is in the case of all sensory and perceptive processes. Hallucinations are induced peripherally, and are started either in the same sense organ, or indirectly in some other sense organ. The secondary sensory elements form, so to say, the hypertrophied portion of the hallucinatory percept, but they are always sensory in character and peripherally initiated. The more closely one investigates hallucinations, the more one learns to trace cases of supposed mysterious hallucinations to external peripheral sources. A pure central hallucination is as rare as the fabulous phoenix. A central hallucination means an unanalyzed psychic state. Whenever an analysis of such hallucinations is made, the peripheral sensory character, primary and secondary, stands out distinctly in the foreground. In the so-called purely central hallucination, the nuclear primary sensory elements remaining in the background of consciousness cannot easily be traced to their appropriate peripheral sense organs and their external stimuli, and they are on that account regarded as centrally initiated. Dream hallucinations, hypnotic, hypnagogic and pseudo-hallucinations, if closely analyzed, can be clearly traced to peripheral origin, to peripheral stimuli that give rise to primary sensory elements that form nuclei around which secondary sensory elements become organized as cytoplasm. These so-called central hallucinations form the stumbling block of the psychologist and the psychopatholo. Functional psychosis and hallucinations 201 gist. To account for them, the theory is commonly advanced that the irritability of the ideational centers may reach such a pitch as to give rise to intense ideational states amounting to a full-fledged sensation or perception, thus bringing about a pure central hallucination. It is strange that such a theory should be maintained at all, and that it should gain currency. The theory does not accord with experience, its very principle disregards facts. For no matter what strength an image may attain, it is still far from becoming a sensation. An image of a bell does not sound and an image of a blow does not strike. The fact is, as we have pointed out before, images or representations are qualitatively different from sensations. An image can as little be converted into a sensation as the sour taste of vinegar can be turned into the violet color of the spectrum. Images and sensations differ fundamentally. they differ in kind, and no amount of ideational activity can ever be made to become sensory in nature. A higher pitch of ideational activity will make an image more vivid, but can no wise confer upon it sensory qualities, just as all the immensity of space and infinity or eternity of time cannot make them weigh as much as a grain. A further modification of the same theory is given by those who maintain that central hallucinations are due to the irritability of the higher ideational centers, from which ideational currents are propagated to the lower sensory centers. In other words, it is not the image that becomes by its intensity or by its vividness directly transformed into a sensation, but an intense or vivid image may give rise to a corresponding sensation without the presence of an external stimulus, or of a peripheral sensory process. 202 Diagnosis of psychopathic diseases. Psychologically as well as biologically regarded, the theory is untenable. For it is not in accordance with observed facts that an image, however vivid, should give rise to a corresponding sensation or percept. Were that the case, the course of internal and external worlds would have become confused and confounded, man would have become the dupe of his own ideas, the world a gigantic madhouse, and the process of ideational activity would have long ago become eliminated in the struggle for existence. From a physiological standpoint, the theory can hardly be considered, inasmuch as it is in direct opposition to the known physiological laws. Sensory excitation, ideational processes and motor reaction form, so to say, a sensory ideomotor arc, the excitation going from peripheral sense organs to central systems, and thence to the muscles and glands. Now the conditions postulated by the central theory are such as to have the processes reversed. Sensory processes work upward, from periphery to center, while motor processes work downward, from center to periphery. On the modified central theory, the sensory process in hallucinations is reversed, it goes downward instead of upward. There is not a particle of evidence for such reversal, the assumption being in contradiction to the principles of physiology. The claim of special structures for effecting such a reversal is unfounded. As far as can be ascertained, the neuron works cellulipitally in the direction of the sensory ganglia and central neuron systems, while the neuroaxon works eucellulifugally, that is from sensory ganglia and central neuron systems to the periphery to the muscular apparatus. There is on the other functional psychosis and hallucinations 203 hand not the least bit of evidence that the functions of neuron systems can be reversed in their course. The central theory then cannot stand the test of critical examination, as it is neither in accord with FHE facts it is called to explain, nor does it fall in line with the facts and principles of physiology. We are therefore forced to fall back on the peripheral origin of hallucinations under the condition of central dissociation. According to our theory, the origin and structure of hallucinations, of dream hallucinations as well as of pseudo-hallucinations, do not differ in the least from those of normal perception, a difference unwarrantedly claimed by the theories of central origin of hallucinations. Hallucinations are peripherally initiated. Hallucinations are abnormal percepts, occurring under the conditions of central dissociation with primary and secondary elements as their central nuclei. Chapter IXXX Thinking. Phenomena of so-called double thinking are extremely interesting from our point of view. The patient hears his own thoughts uttered aloud. He has the hallucination of his thoughts uttered when engaged in writing or in reading, though loud reading may check the hallucinatory voices. These hallucinatory voices may be of an imitative character and simply repeat what is spoken or read by the patient, or they may be of an anticipatory character and utter the patient's thoughts before he himself utters them. The usual explanation of such cases is found in the theory of the so-called overcharged centers, where the voices follow and repeat the patient's words and phrases, It is assumed that the auditory centers are highly irritable and overcharged, so that stimulations from other centers bring about a discharge into the ideational auditory centers and auditory hallucinations result. In the case of reading, for instance, the visual image of the word awakens also an auditory image, but when the auditory centers are overcharged, the visual images awaken directly an auditory image before the spoken words take place. Now this auditory image is so intense, on account of overcharge, that it 204 becomes an auditory hallucination and the patient hears his own thoughts uttered aloud. This reflex action from one ideational double-thinking center into another occurs while the patient reads or writes, and that is why he has the experience, the hallucination that there is a voice often regarded as inner which repeats his own words and phrases. Cases where the voice utters the words and phrases before they are written are explained on the hypothesis that the central discharge into the overwrought auditory centers occurs before the words are written down or before the motor discharge takes place. When, however, the patient hears the voice repeat the phrases soon after he has uttered them, the phenomena are explained on the supposition that the centripetal currents from the speech centers into the auditory centers give rise to the voices, the patient hearing his own words shortly after he has uttered them. The efferent discharge from the graphic centers into the auditory centers will give rise to an auditory hallucination of hearing the words and phrases he has just written. In the phenomena of double hearing, the patient hears his own voice while talking or reading aloud, and then hears another voice due to the discharge from the speech centers to the overcharged auditory centers. Thus in some patients these hallucinations of hearing are brought about by the voluntary suppression of speech. The patient then hears a voice uttering his own thoughts. This is claimed as confirming central initiation, the currents from the word images in the speech centers not having a free outlet run into the overcharged ideational auditory centers and give rise to inner speech heard by the patient. In opposition to this central theory of double thinking or of inner speech 11 held in various forms by psychologists and psychopathologists, there are some 206 diagnoses of psychopathic diseases who maintain the view that these double thoughts hallucinations are not of central, but of peripheral origin, being due to hyperesthesia of the centripetal paths. The apparatus employed in speech carries out not only the requisite delicate movements, but also forms the sensitive movements executed. Apparatus for information of the sense of movement may be regarded as originating in the muscles, especially in the joints and articular surfaces. Sensory stimulations coming from these structures to their appropriate central systems give rise to kinesthetic sensations and motor ideas. Now if the peripheral sensory tracts of the muscle sense or of kinesthetic sensations become hyperesthetic, kinesthetic sensations and motor ideas are aroused automatically and may give rise to hallucinations of positions, movements and acts. Movements which have not been performed are thus experienced. If now the centripetal sensory tracts of the speech centers are hyperesthetic, then kinesthetic sensations and ideas arise which go to form the hallucinations known as double thought. The patient experiences inner speech, a voice repeats after him his own thoughts, his own words and phrases. When the speech centers are overcharged and give rise to automatic, centrifugal discharges, then the hyperesthetic centripetal paths bring it back in the form of spoken words, and the patient experiences his own thoughts uttered by an inner voice which is foreign to him. In speaking, the inner voice comes after the speech and reverberates like an echo. It persists as an after-image of the spoken word or phrase. When the patient is engaged in writing, the voice usually precedes double thinking 207 the written phrase. Because the spoken word image precedes the written word image, the inner voice thus anticipates the patient's writing by uttering his thoughts. This theory seems further to be confirmed by cases in which such hallucinations take place. If one observes closely cases of double thinking or of inner speech, he often finds involuntary whispering present. The patient whispers to himself. These whispers come back to him. On account of the hyperesthesia of the peripheral paths, he hears it as speech of some inner voice. A close examination of the two theories, of the central and of the peripheral, reveals their inadequacy. The central theory, as it is generally put forth and commonly accepted, may possibly be regarded as the more inadequate of the two. For the central theory rests on the psychological fallacy, so prevalent in psychopathology that it may be regarded as the psychopathologist's fallacy, namely, that an image may reach such a high pitch of intensity as to become sensory in nature and give rise to a percept. The percepts, formed by the visual perception of reading, awaken, according to this theory, also accompanying ideas of sound intimately related to and associated with visual word reading, and it is these ideas that reach such a high intensity as to give rise to hallucinations of hearing. The words are read aloud, as if by a strange voice. This explanation, as we have already pointed out, is psychologically incorrect and rests on the fallacy that ideas or images have intensity, and that an intense idea becomes a sensation, or that a sensation is but an intense idea, and an idea is a weak, a faint sensation. To modify this view and assume that an 208 diagnosis of psychopathic diseases intense idea stimulates and gives rise to the formation of a percept is to assume a supposition not warranted by facts that an idea is equivalent to the action of external stimuli or objects with their requisite physical structures and processes. In either case, the central theory as it stands is not in accord with psychological and physiological data, and, as such, cannot possibly be accepted, at least in the shape as it is usually put forth. Furthermore, there is an inherent difficulty in the central theory itself. For if it be correct, as the theory claims, that the visual image calls forth an intense auditory image amounting to a hallucination, the hallucinatory voice should precede and not follow the patient's reading. In order to explain the hallucinations of double thinking or of double hearing in the case when the voice follows the reading, it would have to be assumed first that the visual image of the written or printed word stimulates the speech centers, which, innervating the muscular apparatus of speech, give rise to reading, which in turn stimulates the peripheral auditory apparatus, awakening activity in the auditory centers, giving rise to the hearing of the read words, and that then only do the indirect stimulations of the visual image, coming from the visual centers, awaken once more the same central connections, thus bringing about a repetition of the self-same words heard. We have to assume that the action of the visual centers in stimulating the motor speech centers with the resulting acoustic stimulations and functioning activity of the auditory centers are enacted before the direct central stimulations from visual center to auditory center take place. In other words, we must assume central retarded double thinking. Now what does this central retardation mean? It means that the phenomena of double thinking or of viewable hearing are brought about by some form of central inhibition, of central blocking of pathways as it is usually put. In other words, the requisite condition of double thinking is reduced to the psychopathological state of central dissociation. The inadequate side of the central theory as it is commonly advanced lies in the supposition of referring auditory hallucinations in the phenomena of double thinking or hearing to the intensification of the auditory image or idea, but no straining of an auditory image can get a sound out of it. Moreover, were the central theory correct, it would really involve a double auditory hallucination, one preceding and the other succeeding the reading. For in the process of reading the visual image of the word awakens the auditory image along with its kinesthetic image, stimulating the centrifugal motor apparatus and giving rise to the spoken word. Now this awakened auditory image preceding the spoken word, on account of the assumed irritability of the auditory centers and the consequent intensification of the stimulated auditory images, should necessarily give rise to a full-fledged hallucination. When the voice also follows the reading, a sudden dissociation of the visual from the auditory centers is assumed, a momentary dissociation that gives rise to a secondary succeeding hallucination of the words and phrases read and spoken. The fact that the central theory requires the presence in all phenomena of double thinking, that when the voice follows the reading, another hallucinatory voice must have also preceded, and that there is 2 diagnosis of psychopathic diseases, also a double stimulation from the visual into the auditory centers, that the hallucination first appears under conditions of association of visual and auditory centers, while the succeeding hallucination occurs immediately under the opposite conditions, namely dissociation. All these assumptions make the central theory wholly unsatisfactory and unacceptable. The peripheral theory of double thinking is on general grounds more acceptable as it falls in line with psychological and physiological principles and facts. Unfortunately, the special facts which the theory is called for to explain do not exactly tally with it and may even be said to contradict the hypothesis. For if the hallucinations of double thought are due to hyperesthesia of the centripetal sensorimotor tracts, then reading aloud should intensify the hallucination, but the case is quite the reverse. Reading aloud makes the hallucinatory voice to disappear altogether. On this theory again, the voice should follow and not precede the reading. We are thus confronted with the opposite difficulty met with in the central theory. On the central theory the hallucination should precede, while on the peripheral theory the hallucination should follow the reading. The central theory cannot account well for succeeding hallucinations, while the peripheral theory does not account well for preceding hallucinations. On the central theory there should be double hallucinations in cases where the voice follows reading, while on the peripheral theory there should be double hallucinations when the voice precedes the reading. Besides, hyperesthesia should rob the perception of its hallucinatory character. The patient should be all the more conscious of his own utterance. Double thinking 211. A closer examination of the peripheral theory discloses a fundamental fallacy which it primarily involves, a kind of ignoratio elenchi. The theory is probably correct in principle, but it misses the essential point of the whole problem. It may be an adequate explanation for motor, but not for auditory hallucinations. Hyperesthesia of the central motor speech tracts would at most give rise to pure kinesthetic hallucinations. The patient may have hallucinations of actions, tension, or of movements in his peripheral speech organs, but he will have no hallucinations of hearing. To have an auditory hallucination, as to have an auditory perception in general, the auditory peripheral and central apparatus should be stimulated. No other organ but the acoustic apparatus can possibly supply sensations and percepts of an auditory quality, unless the hallucination be of a reflex, secondary character, but then it may be induced through any other peripheral source than that of kinesthesis of the speech organs. Although each theory taken by itself proves to be inadequate and leads to contradictions to facts, still the two may be regarded in a certain sense as supplementing each other. Now the central theory emphasizes the aspect of the central character of the phenomena, while the peripheral theory lays stress on centripetal factors. Both theories can be brought in line with facts, if assuming centripetal factors of kinesthesia and auditory hyperesthesia, we also refer to the central conditions of dissociation. The patient in double thinking is subject to subconscious states, to states of dissociation. This dissociation is of a central character and specially affects the visual and kinesthetic systems. Impressions, on account of dissociation and peripheral 212 diagnosis of psychopathic diseases hyperesthesia, are subconsciously received and subconsciously reacted upon. The visual impressions of the written and printed characters are subconsciously perceived and subconsciously uttered in a whisper and sometimes quite loud, as I had occasion to observe in my cases. This subconscious utterance, unperceived by the patient, comes back to him as a strange, external voice proclaiming the patient's thoughts or repeating his words and phrases. The phenomenon of double hearing is due to subconscious whispering which comes back to the patient as an auditory hallucination. I had the occasion to verify this phenomenon of subconscious whispering in cases in which functional dissociation was quite marked, and in which auditory hallucinations and double thought were quite persistent. In cases where the auditory hallucinations precede the reading or writing, it is the subconscious whispering along with kinesthetic and auditory hyperesthesia that give rise to the phenomena of double thought or of double hearing. The dissociation being in the kinesthetic systems, the patient does not experience consciously the peripheral incoming sensations due to his subconscious whispering. More often the patient continues to whisper subconsciously what he has just read consciously. Such a habit is common with many people in the normal state and is due to the persistence of the peripheral sensory impression, to a kind of verbal after-image. The absence, however, in the normal condition of dissociative states prevents the formation of subconscious whispering with its consequent auditory hallucinations, partly due to hyperesthesia of the auditory tracts. Double thinking. If cases of double thinking are closely examined, one finds in them the presence of subconscious states with their psychomotor reactions. The patient in walking on the street, for instance, may hear a voice telling him words and phrases that can be traced to signs and advertisements which he has read subconsciously, though he himself has not been aware of it. What happens in such cases is this: the patient whispers or even utters aloud the words he subconsciously sees on the signs. It is this subconscious whispering that comes back to him as an auditory hallucination of a voice. In my cases in which the patients suffered from auditory hallucinations, found I on close examination the phenomenon of unconscious or subconscious whispering, which became aggravated in proportion to the state of distraction in which the patient was, ranging from an almost inaudible whisper to a loud talk, the patient being entirely ignorant of it, so that he could not be made aware of it, even when his attention was called to his talking. One of my patients suffering from pronounced auditory hallucinations, but in whom the dissociation is not deep, aptly describes his experiences as auto-vocalization. Similar conditions can be induced in hypnosis, thus confirming our point of view by experiment on otherwise normal people. If a post-hypnotic suggestion of subconscious whispering is given, the subject experiences an hallucination analogous to that of double thought. The subject hears a voice telling him the words and phrases which he himself whispers, but of which he personally is entirely ignorant. The peripheral character of the double thought under condition of central dissociation may thus be regarded as an efficient 214 diagnosis of psychopathic diseases working theory in accord with facts. From the whole course of our review of facts and theories, it appears that we remain more closely in touch with facts, if we accept the view that hallucinations require states of dissociation as a central condition, and that they are primarily peripherally initiated, having secondary sensory elements as their main content. In other words, hallucinations are dissociated secondary percepts.